We are living in one of the most unsettling and disruptive times in modern history. COVID-19 has altered how we venture into the public and how healthcare needs to approach medicine. However, Houston Methodist has experience with pandemics. It was founded a century ago when another deadly virus ravaged Houston, the Spanish flu. Now we stand on the shoulders of those giants who fought that pandemic. Their actions set the benchmark for medical innovation. It is with this in mind that Center for Critical Care will work to discover and introduce advances in critical care medicine for the benefit of patients and to be prepared and anticipate future needs.
We are in the second century of critical care delivery at Houston Methodist. The center brings much needed focus in areas of research, education, and clinical innovation together and integrates multidisciplinary areas at all of our Houston Methodist locations.
And comprised of 8 ICU locations, including the virtual ICU, and over 300 ICU beds in over 5 subspecialties, the center unifies clinicians and researchers practicing at Houston Methodist who are actively involved and dedicated to the continual improvement in critical care medicine. Working together and leveraging our centers of excellence for the benefit of our patients makes us uniquely positioned to revolutionize the future of critical care medicine, while our collaboration with academic and research institutes drive our spirit of innovation.
Over the years of my career, I've seen critical care undergo many changes, but never have I seen the pace of change be faster or the kinds of changes more profound than during this last year with COVID-19. That's why I'm so excited about the Houston Methodist Center for Critical Care. It enables us to share best practices, it enables us to integrate new technologies, and we're developing our academic mission throughout our great system.
When we look at the innovations from whether it was intubation boxes or the way that everything was done to bringing care into the room from outside of the room, from virtual family visits and others, it was amazing to watch the innovations that were happening inside of the ICU. And not only happening inside of the ICU, but then actually watching the publication after publication happen from the work that was being done at Houston Methodist.
I'm confident the center will achieve its mission through groundbreaking academic research and by collaborating within and outside of our system. Of course, there is no doubt in my mind that by continuing to partner with Houston Methodist Centers of Excellence to achieve shared goals in the spirit of leading medicine will ensure success for today and in the many years to come.
All right, good morning. Saturday morning, 7 o'clock, and I was thinking to myself, did I really put myself this agenda 7 a.m.? Maybe we'll do a little bit later, you know. Well, good morning, good afternoon, and good evening to people who are online. This is the second exciting day. We had a fantastic, plethora of speakers yesterday. I thoroughly enjoyed, we had a very good diversity of topics we talked about. And today is really a great lineup of speakers, fantastic workshops. You'll get to do a lot of those things. And we put in a lot of effort in those workshops tremendously. And that's why we encourage people to attend, whoever can attend in person. But we're very grateful for all the people who are logging in and listening in. And you won't be disappointed. We will go from how to understand X-rays, from the whole PERT program, from Dr. Monet from France, who will be logging in, listening in, and speaking about whole pulmonary dynamics. So I think there's a lot of learning, there's a lot of exciting thing, and we really would like also feedback from you. I mean, I think the strength of any program, any symposium is feedback. What worked, what didn't work, what would you like to do? And if there is any speaker or topic you all feel that is valuable to bring, we're more than happy to accommodate that. And I think, this is something which is very important, because this symposium, it's not about us, it is about you. This symposium about how we as an institution, as healthcare entity and health critical care provider can make a difference is about learning. And the beauty of medicine is that it is shared learning. We learn from each other. We don't have all the answers, we learn from each other. We are not stockbrokers or we hide secrets, we share. And we share generously, and I think one of the key things Dr. DeBakey also said is the best medicine is the best information, so we have to be well informed. With that, I'll bring the star of the show, Dr. Dala, who's the better looking one, and I'm just a filler. When you have a concert, you bring the filler in, I'm the filler, and she's the real person. All right, thank you, welcome again.
Good morning, everyone. Thank you for joining us today. I think we had a terrific session yesterday, and I hope you all enjoyed it and learned a great deal. Today, we have another very exciting day. So let me begin with some announcements. We gratefully acknowledge the following exhibitors for participating in this activity. Please take time to visit them during your breaks and meal times. We also gratefully acknowledge GE Healthcare for providing in-kind donation to partially support this activity. If you're watching online, please submit your questions in the chat box on the live stream page. If you are here, obviously, please log in, click on this link, and submit your questions. The questions will be moderated, and we'll address them based on time and content. Disclosure and CE information can be reviewed in the handouts provided at the registration desk or within the description area of the live stream page if you're watching online. You can expect to receive an email from Houston Methodist CME within 2 to 3 business days to complete a survey, which will prompt you to receive a certificate. This is today's lineup. And this morning, we'll start with the world's #1 expert in acute kidney injury, according to Expertscape, and a master of the Society of Critical Care Medicine, our keynote speaker of the day, Dr. John Kellum. Dr. Kellum is professor of critical care medicine, bioengineering, and clinical and translational science at the University of Pittsburgh. His research interests span various aspects of critical care medicine, but center on critical care nephrology, sepsis and multi-organ failure, and clinical epidemiology, including consensus development and research methodology. He has authored more than 700 publications and has won several awards for teaching. For more details about Dr. Kellum's work, please refer to his full bio sketch on our Symposium website. Joining us virtually and speaking on the topic of renal replacement therapy in the ICU and Goldilocks effect, please welcome the legendary Dr. John Kellum.
Legendary, thank you. Well, with an introduction that kind, I can only disappoint you now. So, but thank you. Thank you for that. Well, it's very nice to be with you again. It's I guess we're all saying the same thing now, right? It's getting tiring to be online and miss the personal contact, but maybe that's not too far off in the future. So as my slide title slide suggests, I'm going to be speaking about timing of renal replacement therapy in the ICU, but I'll also touch on some other issues that sort of stem from the use of renal replacement therapy in the ICU as well. My disclosures are here. I'm currently on leave from the university, and I'm serving as a chief medical officer for Spectral Medical and its wholly owned subsidiary, Dialco. I won't be speaking about any of the products specifically that these companies make, other than at the very end, I will touch on some biomarker technology which is being developed by Astute Medical, which is shown there. I'd like to begin by just sort of reminding you of sort of what the landscape looks like, sort of where we are with this question, and sort of where we've been perhaps in the past. I think not long ago, and I've been speaking about this issue for a long time, so I can certainly speak to the fact that we used to talk about the role of CRT relative to intermittent hemodialysis. And we used to talk about whether, we should use one modality, versus another. We used to talk about dose a lot. I think that will probably rear its head again, but just in different contexts in the future. But I think in large measure, the dose question has been settled by large clinical trials, which have shown that there may well be a minimum dose, but once you get above that dose, you're not getting significant benefit from further dose increases in terms of, even if you may be getting increased solute clearance, it's not having an effect on outcome. I think the new questions that we're wrestling with, and arguably some of these have been around for a while, but the new questions, or the consistent questions that we're wrestling with, include whether to provide renal replacement therapy in certain situations at all, whether to wait and see whether a patient develops an emergent indication, or whether to provide preemptive therapy, and that is the major question that we'll wrestle with this morning. I think, though, that we're beginning to also ask questions about the total net ultrafiltration rate, which is, different than how we conceptualize dose, because now we're just speaking about the rate at which we remove fluid from patients. This, of course, has been an issue for many years in the chronic population, but it looks like the thresholds for harm in critically ill patients are much, much lower. And this has become an issue that many people are concerned about, even in the context of CRRT. And then finally, this issue of how to anticoagulate patients for CRRT, whether to use heparin or citrate, has come back again and again in the literature. And I'll show you some recent provocative data from clinical trials that has emerged in that space as well. So this began, I think, just to reiterate, I think the old questions of CRT versus intermittent hemodialysis, I think, what we said in the 2012 KDIGO guideline, that these therapies have complementary roles and that most centers use both of them, is still true today. And I think that this field has matured to the point where I think that most institutions, use one or the other or both, given the patient's clinical circumstances. Now, I will tell you, this has changed a lot over, the 30 years or so that I've been in clinical practice. We can't, in Pittsburgh, we don't even provide emergent intermittent hemodialysis. If you come in with a potassium of 10, even if unless you're already on dialysis and you've got a fistula, and if you're an acute patient, you're going to get CRT, because that's where we don't really even have a mechanism in place to provide emergent IHD in the middle of the night for a patient like this. So that's changed a lot. I think we would have provided intermittent hemodialysis in the past for patients like that. For dose, I would say that multiple studies have demonstrated similar outcomes when you sort of look at doses between 20 and 30 mLs per kilogram per hour in terms of total ultrafiltration, in terms of total rate. And going beyond 35 really hasn't produced much help. There's some older studies that have shown that less than 20 is harmful or not as useful in terms of mortality. I don't think we'll ever repeat those studies, so I think we're stuck with that as a floor. And then generally we have to aim, for a higher dose in order to achieve 20. So most people say, well, we should aim for 25. So that's sort of where the old questions have taken us. I think in terms of the new questions, I think we can say that there's no evidence that all patients with stage 2 or even stage 3 RRT AKI will benefit from RRT. We can also say there's harm associated with renal replacement therapy in patients that may not require it, and the mechanism of this is not entirely clear. Although I'll show you where we think that's coming from. We also know that there's harm associated with delay in renal replacement therapy in patients who require it, and we're equally unsure of the mechanism of that. And then we'll talk about net ultrafiltration rate, and we'll talk about citrate versus heparin. So that's sort of an overview of the next 30 minutes or so. I want to begin, though, by reminding you, because I think there's still some confusion out there about the extent to which renal replacement or AKI contributes to mortality, and why why we have such a strong rationale for providing renal replacement therapy in patients who require it. And it's really the question about who really requires it, and that's a question we'll wrestle with in this lecture. But we should start with just recognizing just how significant a problem this is, and this is data from a septic shock study that we did a few years ago. And this is just to remind you, because I think it's just such a dramatic example of how patients, even with septic shock, these are patients that have, they have shock, they have other organ failures, and yet AKI emerges as a dominant cause of mortality. In fact, if you don't have AKI with septic shock, you're a patient who's admitted with septic shock, you're on a ventilator, you're on pressors, but your kidneys hang in there, your mortality at 60 days is only 6.2%. Even with stage 1, it goes up to 17%, and with stage 2 or stage 3, we're talking about nearly 28% 60-day mortality. Now, is this an association? Is it causally related? I don't have time to talk about this in great detail. In fact, I don't have time to talk about it at all this morning. It's a sort of a separate lecture entirely, but there's good evidence to suggest that this is a causal relationship in terms of, at least with patients with sepsis, it may be important in other settings as well. And so AKI is really in the causal pathway for mortality in critically ill patients. And so that gives us a very strong rationale for trying to provide support for these patients, obviously trying to avoid AKI to start with, but in patients who develop acute kidney injury, it's more than an academic exercise as to consider how one supports these patients with renal replacement therapy and when one starts. So this is literally a life and death decision in these patients. And so this timing puzzle that we've been struggling with for a long time is not unique to renal replacement therapy at all. It is arguably an issue for all kinds of therapies that we provide. But, to treat late means that we have to suffer some unnecessary delay. And usually a necessary delay of life-sustaining therapy is bad. So it's not surprising that there would be a hazard associated with that. But to treat early means that in some patients, we'll be providing unnecessary treatment. And unnecessary treatment, when we talk about an invasive therapy, like renal replacement therapy, probably carries some risk and will cause harm to some patients. And the evidence certainly suggests that that's in fact the case. This is not unique, or this is not new. This is some work that Perry Wilson did when he was still at Penn. Before he went to Yale, and which he looked at patients receiving or not receiving dialysis in the ICU. And what he found essentially was that although admittedly, this was not sort of a critical care focus in a way, in the fact that he didn't look at fluid overload, but none of the other variables that he looked at in terms of, except perhaps creatinine. If you had a really high creatinine, meaning that if you were sort of end stage already, you were more likely to benefit from dialysis. But pretty much everything else, really, there wasn't anything that indicated which patients would benefit from renal replacement therapy versus not receiving renal replacement therapy in terms of survival. This is very similar to what Stefan Godry showed some years later, in which he randomized patients to receive an early strategy of renal replacement therapy, which essentially meant starting these patients when they met what I think most of us would consider to be reasonable thresholds for solute levels and for in terms of BUN and oliguria, fluid status, or delaying that therapy until someone met a more traditional trigger for renal replacement therapy in terms of not just a level of solute imbalance, but one that was producing a sort of a critical need for, the sorts of levels that are in the textbooks in terms of potassium above. I think they used 6.0 as a threshold, metabolic acidosis, things like that. And what he essentially found was there was no evidence for initiating renal replacement therapy in all the patients who met stage 2 or stage 3 acute kidney injury, but rather waiting for these patients to develop one of those kind of traditional triggers for renal replacement therapy. This is his inclusion criteria: stage 3 AKI, mechanical ventilation or vasopressors, excluded patients who already had one of these indications for dialysis at enrollment, one of these life-threatening indications. And then again, early initiation was immediately following enrollment. Late meant waiting to develop severe hyperkalemia, metabolic acidosis, pulmonary edema, a BUN greater than 112, or oliguria for more than 72 hours. Interestingly, he excluded as many patients, in fact, more patients than he actually randomized, because many of these patients were already receiving renal replacement therapy or already had one of these indications. But if you didn't have one of those indications, randomizing patients at this point was unable to show a difference. However, only 51% of patients in the delayed group ever received renal replacement therapy. And a post hoc analysis showed that the lowest mortality was found in patients who never received renal replacement therapy, which makes perfect sense, right? These are patients who recovered from their acute kidney injury without requiring renal replacement therapy. And the highest mortality was seen in patients who received renal replacement therapy late, and the mortality was in between in patients who were randomized to the early arm. So what this suggests is there essentially are winners and losers if you wait for one of these acute indications. If you win and the patient never develops one of them and recovers, your mortality will be lowest. If you lose and you develop an acute indication emergently, you have the highest mortality. And so that gives us real pause, right? I mean, this is a pretty substantial difference in mortality. Even between these two is a substantial difference, in such that one would like to know better exactly how to make that decision in these patients. The START investigators essentially found exactly the same thing. Again, only 62% of patients in this study of what they called standard versus accelerated renal replacement therapy, pretty much the same inclusion exclusion criteria, and found again that there was no benefit. Yet the Elaine trial, which had a little bit of a different design, this was a study in Germany, which compared delayed renal replacement therapy again to early. The only real difference between this study and the Akiki trial that Stefan Godfrey performed was that all the patients, or virtually all the patients in this study, received renal replacement therapy. The only real question was, did you receive it at stage 2, or did you receive it when you progressed to stage 3? And so these really could be labeled at stage 2 or wait to stage 3. And there was a substantial difference in this population. Now, some of the differences are that not only did everybody receive renal replacement therapy, but also these were more cardiac surgical patients, whereas the French trial was more medical patients, and maybe there's a difference there. But I think what it's really telling us is that if we knew who was going to receive renal replacement therapy, then early therapy is better. And where the advantage comes, or where the confusion comes, is the fact that we just don't know who's going to receive renal replacement therapy, and providing renal replacement therapy for patients that really don't require it is hazardous. And so if we could just have a better crystal ball and know who is going to ultimately need renal replacement therapy, then many of the concerns here would go away. And that's essentially what was found in the follow-on study published last year in the Lancet, again from Stefan Godfrey's group, the so-called Akiki 2 study. And basically what they looked at here was whether they could delay further renal replacement therapy. And what they found was that after reaching KDIGO stage 3 plus mechanical ventilation with either catecholamine requirement or oliguria for more than 72 hours, or a BUN in this range, 112 to 140, waiting to achieve those criteria actually resulted in harm, at least in the multivariate analysis, that there was harm associated with further delay. So the question then is okay, we can perhaps wait and see, but we can't wait and see too long, or we can't wait too long, because there's a hazard in patients if they develop further solute imbalance. And of course, this I think you put all this together, and you would say that, like everything else in medicine, there's a balance of benefit and harm, and this is true for renal replacement therapy. So, there are a variety of potential benefits, correcting or preventing fluid overload, uremia, acidosis, hyperkalemia, and drug toxicity. But at the same time, there are potential harms from starting renal replacement therapy, inducing hemodynamic instability or worsening it, increased risk of infection, bleeding, the immobility that comes with CRRT. And I think that for a given patient, one has to judge whether the potential for harm is greater than the potential for benefit. And if that's the case, we withhold renal replacement therapy, at least for the time being. And if we judge that the potential for benefit is greater than the potential for harm, we would start renal replacement therapy. And again, this is not rocket science, but it is now. And maybe it's the way we've been practicing for a very long time. I think the only thing we can say is that now we have very solid evidence that, in fact, there are these benefits and harms, that we can't just assume that everybody's over here or assume that everybody's over here, and we have to make some decision about the individual that we're taking care of as to whether they will fit on one side of this coin or the other. And of course, it's not just their medical indications, it's also whether or not a renal replacement therapy sort of fits with their values and preferences. Some patients who meet these criteria, who may, in our judgment, have a better chance of survival if they're treated, may still not want this therapy. And although, again, as sort of probably a separate conversation, perhaps, the extent to which withholding renal replacement therapy in patients who have multiple problems and in the ICU is maybe a separate discussion entirely. But there will be some patients who really will want to withhold renal replacement therapy for whatever reason. Although one of the things to remind patients is that it's actually fairly unusual for a patient, if they start with normal renal function or near normal renal function, to end up on chronic dialysis as a consequence of developing renal failure in the ICU. If they survive, they don't tend to go on to chronic hemodialysis, at least acutely. There's an increased risk long term, but the bigger risk is just surviving the hospitalization. So this brings us to this question of precision renal replacement therapy, and we had a series of papers that came out of an ADQI, Acute Dialysis Quality Initiative Congress a few years ago. You can read these at your leisure. They are a series of very detailed analyses of really this question of not just timing, but of all kinds of other aspects of personalizing renal replacement therapy. But in terms of conceptual model that came out of that, of those deliberations, I think this one is a particular value for making a decision in a particular patient. And the idea here is that there is a demand and a capacity for renal function. The demand is influenced by things like solute load, by volume load, which is typically the biggest factor. But there's also aspects of the acute illness and the chronic disease burden that are all sort of summed together, which influence the demand for kidney function. And then there is the function that the kidney can have to meet that demand. That's the capacity to manage solute and clearance, electrolytes, and volume. And there are times when there may be an increased demand, but there's sufficient capacity, and the demand capacity imbalance is not necessarily severe, or may not occur at all. There may be excess capacity relative to the demand. But there are other times when either the demand is high or the capacity is low, or both, in which there is a significant gap in the demand capacity ratio. And above a certain point in that gap, there's really a renal replacement therapy threshold. Where that threshold is, I think, is still something that we're struggling with. But this concept provides I think, a useful conceptual model of thinking about it's not just the degree of renal dysfunction, it's not just the demand for the particular patient, but it is both, and one has to consider those things. So not all patients with even relatively severe diminished kidney function require renal replacement therapy. It's really a question of their demand, and that may help explain the differences between what we're seeing in for example, the AKIKI trial, which included a lot of medical ICU patients who may have a lower demand, and the ELAINE trial that may have had patients with a higher acute demand for renal function. So you could put together sort of a bit of a decision tree like this. You could say, well, okay, does the patient have any of these acute problems that would prompt me toward initiating renal replacement therapy? I might start with fluid overload, and if the patient has emergent fluid overload, then I go down a path of management. If they don't, but they're heading there, I may still go down that path, but I may well start, unless it's an emergency, I may well start with diuretics. And if they're effective, I therefore hold renal replacement therapy, again, if that were the indication. If it's an emergency, though, I may have to move directly to renal replacement therapy. If fluid overload is not the only problem, or not a problem at all, I may consider other factors. And again, this notion of is it an emergency, and if it is, I need to move directly. If not, I can try other medical therapies to see whether or not I can provide adequate therapy for these patients. And I think the fluid accumulation aspect is a significant one, has been looked at in multiple different studies, and there's a very strong association with fluid overload and mortality in critically ill patients. I won't go into that in great detail now, but I think there's a very strong literature on this particular aspect, coming first and foremost from pediatrics, where even in pediatrics, where mortality is usually much lower than in adults, you can see this very strong relationship between the amount of fluid overload and the hospital mortality in these patients. This was work from Stu Goldstein's group back some years ago now. And this has been shown in multiple studies, regardless of how you choose to initiate renal replacement therapy or using diuretics. And there's a large range of clinical practice, but in all cases, deresuscitating patients with fluid overload is associated with reduced mortality. And the question, therefore, is, how do I manage this most effectively in the patient that's in front of me? Sometimes using diuretics is reasonable. Sometimes using renal replacement therapy as a first-line approach is required, given the urgency for that particular patient. And this notion, of use of diuretics in concert with renal replacement therapy has been sort of codified in what we refer to as the furosemide stress test, where you give a dose of furosemide, and if you get a reasonable response, that's likely that the patient won't ultimately require renal replacement therapy, whereas if they don't get an adequate response, they do require renal replacement therapy. And the area under the receiver operative characteristic curve for this it can be as high as 0.87. So it's a fairly good way of sorting out whether a patient's ultimately going to need renal replacement therapy or not. We took a look at this to see whether or not, in collaboration with, in fact, when I say we, they did all the work, but this is some work from Thailand in which I was a part of, and what we did here was we basically said, look, can we use the furosemide stress test to determine whether or not to randomize patients into an early versus standard renal replacement therapy approach? And although we underpowered to really show a difference here, the furosemide stress test was able to differentiate patients. So the patients we randomized, 86% of those patients, as opposed to 50% in the Akiki trial, received renal replacement therapy, and we excluded patients with a very low risk of renal replacement therapy. And so I think it was useful to use that methodology to determine who should receive renal replacement therapy. Now, another corollary to all of this is that the harm associated with providing renal replacement therapy emergently, so waiting for a patient to develop one of these emergent indications and then providing that renal replacement therapy emergently as opposed to preemptively, can be associated with harm. This is a study that we looked at retrospectively to see patients who were treated in the middle of the night with renal replacement therapy, and that in our institution always meant that the patient developed an acute or emergent indication. We don't provide renal replacement there. We don't start renal replacement therapy at 3 o'clock in the morning unless the patient has an acute emergent indication, and there was a significant hazard associated with initiating renal replacement therapy under those circumstances. So what that means essentially is that, if you know, or if you have a very strong belief that the patient will need renal replacement therapy sort of that night, it's far better to provide it during daylight hours. Finally, I think, and I alluded to this at the beginning, I think there will be some further help. So in addition to the furosemide stress test, there may be biomarkers that can ultimately be used to help with this. This is one that was published last year. This is CCL14, which will be clinically available in Europe in the next couple of months. and hopefully United States in the next year or so. It will be marketed under the name of NephroClear, not to be confused with NephroCheck, which is TIMP2 and IGBP7. But this is CCL14, and CCL14 is a marker of persistent acute kidney injury. So patients with high levels of CCL14 don't recover acutely, and that's often the question that we have. And so this biomarker may allow us to say, oh, okay, this is a patient who's not going to get better, and now I may want to consider renal replacement therapy. Whereas if it's low, most of those patients, the vast majority of those patients, do recover in the next few days, and therefore a wait-and-see approach for those patients may be much more reasonable. So then finally, I think if you start renal replacement therapy, the rate of fluid removal also matters. And this is one of several papers that our group has published on this, but there's some work from others as well, showing that this association with net ultrafiltration rate and mortality among critically ill patients with receiving renal replacement therapy. So net ultrafiltration rate is the total effluent rate minus the sum of the renal replacement therapy and the spent dialysis. So essentially what you're removing from patients and expressed in terms of fluid removal relative to their body weight. And if you achieve a net ultrafiltration rate greater than 1.75 versus a rate between 1 and 1.75 mLs per kilogram per hour, you show evidence of harm. And so this is a pretty low rate, right? I mean, this is, we're talking about, in a typical patient, really only about 150 cc's per hour of fluid removal. And yet, if we get above that rate, there's association with harm. And of course, this notion of an association between the rate of fluid removal and organ dysfunction, particularly cardiac dysfunction, but other organ dysfunction as well, has been around for quite some time, and it's given us thresholds to use in chronic dialysis, but they're much greater thresholds, right? I mean, we keep patients from receiving fluid removal greater than 13 mLs per kilogram per hour, or maybe we lower that to 10 in some patients. But 1.75 is a pretty low value, and yet there's this strong evidence from multiple different studies showing that exposure to higher ultrafiltration rates in various thresholds is associated with increases in mortality and morbidity. Finally, I want to talk just briefly about some new data on citrate, the effect of using citrate versus heparin in critically ill patients for renal replacement therapy. And what this study showed clearly was that, as other studies have shown, there is a much greater length of filter life when you use citrate versus heparin. So in addition, citrate resulted in significantly fewer complications, bleeding complications, I should say. And this was statistically, and I think also clinically quite important. However, surprisingly, there were significantly more new infections associated with patients receiving citrate versus patients receiving heparin. Subsequent analysis showed that it really wasn't a function of the citrate, though. It was a function of longer filter life. And so if you kept the patient on the same filter for more than about 48 hours, you increase the risk of infection. So citrate does seem to result in longer filter life, but maybe you don't want to keep patients on these filters for as long as you can with citrate. So the advantages of citrate may still be present, but you don't want to keep patients on the filter for more than about 48 hours. So in conclusion, whether to provide renal replacement therapy, I think, again, as I've said, there's really no evidence that all patients with stage 2 or even stage 3 AKI will benefit from renal replacement therapy. There's a harm associated with with providing renal replacement therapy in patients that don't benefit from this. Sometimes this is a result of hemodynamic instability, even below a threshold that we can measure. So the patient doesn't have to develop hypotension to develop microcirculatory dysfunction, and that may compromise nutrient blood flow to various vital organs, and this may be an issue for these patients. We also know that there's harm associated with delay of renal replacement therapy in patients who require it. This may be due to increased exposure to fluid overload. There's the best evidence for that, but there may also be things like increased drug toxicity, uremic neutrophil and platelet dysfunction, which occurs in these patients, might be the cause. But also net ultrafiltration rate is important. And if we exceed 1.75 mLs per kilogram per hour, now this was an average rate, so there may well be a need to exceed this for short periods of time to manage emergent fluid overload. But if we achieve an average rate above this, this appears to be harmful. And then finally, there's new data on the length of filter life. And when you get beyond 24 or especially 48 hours, you begin to see you actually begin to see the association as early as 24 hours. It becomes much stronger still after about 48 hours. So it may be important to not push these filters out as far as you can with the anticoagulation. And with that, I thank you for your attention.
Thanks, Dr. Kellum. That was very informative and fascinating.
You want to try this?
Can you hear me, Dr. Kellum? Dr. Kellum, can you hear me?
Yeah, I can hear you.
Great. Thank you so much for that very informative and fascinating talk. We have a couple of questions from the audience. The first one, can AKI biomarkers help to further improve the timing of initiation of RRT in the ICU?
So I think they can in a variety of different ways, but I think the real question that comes up most often that biomarkers may be able to address, particularly the new markers that I was mentioning, is this question of whether the patient's likely to recover renal function in the next few days. And the AKI biomarkers, the injury biomarkers, you would think would have some value here. There's some older research suggesting that NGAL, for example, is higher in patients who don't recover renal function. We looked at this in some of the trials, and what we found essentially was that everybody with stage 2-3 AKI basically had high NGAL levels, so it wasn't really that useful. NephroCheck, which is available clinically as a predictor of AKI, tends to be elevated, but also it can go down in patients. It's really a renal stress marker, a kidney stress marker, and it can go down in patients who don't recover. And so timing becomes very important. If you measure it in a patient with established renal dysfunction, it may no longer be elevated, and yet they still have acute kidney injury, and yet they still may be requiring renal replacement therapy. So it's not that helpful. The emerging biomarker CCL14 is a marker of persistent kidney dysfunction, and that will be potentially useful as a way of improving the timing. And then we have the furosemide stress test as well.
Dr. Kellum, are there any AI or deep learning models for, predicting who, would require the renal replacement therapy?
There are, and there are models that have looked at, who's likely to develop acute kidney injury, who's likely to develop severe acute kidney injury. I think, and there's some very sophisticated models out there. Google's DeepMind, deep learning algorithms have been applied to this. One of the challenges, though, as we talk about in an editorial that was just published yesterday in JAMA Surgery, speaking about some of these models, is that some of the problems that people really don't, I think about is that in order to apply some of these models, you really need to have very, very high fidelity data coming directly out of the EMR. And we're just really not there yet. To apply an AI model clinically. We can do it in a certain research setting, but it's very challenging to put it into clinical practice, whereas measuring a lab test will ultimately be probably a lot easier. And of course, then it's really a false choice when you think about comparing AI to biomarkers, because ultimately we can have both. We can have an AI algorithm that also incorporates biomarkers. So the short answer is yes, there is some data. We're not there yet clinically to apply these things at the bedside.
Thank you. There's another question from the audience. Is there significant differences in morbidity, mortality when it comes to CRRT versus SLED?
So the short answer is no. There's not significant differences, and SLED therapy, depending on how you define it and how you apply it, can be an alternative for some patients. I think one of the things that is missing in some of these studies is integrating it with what we now know about net ultrafiltration rate. So obviously, if you're trying to remove a lot of fluid from a patient and you have to compress that from 24 hours into, say, 8 or 12 hours, you're certainly going to have a higher net ultrafiltration rate. If, on the other hand, you have a patient who doesn't need a lot of fluid removal, what they need is solute clearance, then they may not need CRRT for that. They may well benefit from a modality which gives them a little bit more mobility, that gives them time off of therapy, and SLED may be a very reasonable alternative for that. And those studies really approach the problem from that standpoint.
We have another question.
Thank you, Dr. Cohen. This is Dr. Masood. Thank you for speaking at our symposium. I do have a question. In your experience and interaction, all the vasopressors that we use, typically, we have norepinephrine, vasopressin, people use epinephrine, and with the newer agent, angiotensin II, is there any benefit into renal protection strategies, which is evolving in terms of utilization of these presses and renal protection strategies?
Yeah, so very good question. I think that historically, there's going back many, many years, there's certainly data to suggest that not all catecholamines are the same, and then this question has reemerged with newer agents, angiotensin II, I'm speaking of specifically. And so if we look at catecholamines, I think my review of that literature suggests that although there are some hints of potential differences amongst the catecholamines and vasopressin, there really isn't significant differences across this strategy with respect to renal protection. There are other reasons why, for example, norepinephrine is better than dopamine, for example, in providing support to blood pressure in terms of the side effects associated with dopamine, in particular atrial fibrillation. And there are also other off-target effects of dopamine which are undesirable. Adding vasopressin, or in some cases using vasopressin as a first-line agent, has been looked at. I'm not convinced that any of that data really it provides evidence that there's much of a benefit for one strategy versus another. So that I think most people feel like you use norepinephrine as first line, you add vasopressin if you're using very high levels of norepinephrine, how you get to define what high level is for a particular patient. But then came along angiotensin II, and I think there is data and there's underlying rationale to believe that angiotensin II is a better agent for patients who have, particularly for patients that have low angiotensin II levels. And so, unfortunately, the drug is very expensive, and that precludes its use in many situations. But we were part of. I wasn't, but our institution was part of that trial, and it was very clear that there are some patients that really get a very brisk response to angiotensin II. You can take them off of norepinephrine very quickly. And it's a safer drug than vasopressin, even though the recent trials have been relatively small and didn't really look at safety that carefully. The drug's actually been around for a very long time, and so there's a very, very solid safety signal for it. And we know that vasopressin and norepinephrine are associated with, digital ischemia and things like that. So there's rationale to believe that it's better for the patient, and the data that I was alluding to suggests that it's also better for the kidney. But I think additional trials need to be done to really cement that. The data we have right now is from the post hoc analysis of the trial.
I guess the last question from the audience, slightly loaded. What is your take on intensivist role in initiating emergent renal replacement therapy? Should more be comfortable doing this, or should this all go through nephrology? Center specific.
Well, that's a very controversial question. Obviously, I think it depends on how you're set up. I mean, we've had a at the University of Pittsburgh, we've had a very collaborative approach between intensive care and nephrology for many years. I think intensivists are obviously in the ICU 24/7. Nephrologists are not, and so therefore there's no question that intensivists need to be involved in this process. But I think that in many ICUs there's not as much renal replacement therapy as there are in other ICUs, and certainly the need for a lot of support from nephrology is certainly greater in certain settings than it is in others. I mean, I'm very comfortable initiating renal replacement therapy. Back in the days, I did this without nephrology input. We have a much more collaborative approach now, where nephrology sees all of the patients. But if you're in an environment where you're short on nephrologists and you require renal replacement therapy, I don't know that it's mandatory. I think the best approach is to have both nephrologists and intensivists involved in the decision making and the management for these patients.
Thank you, Dr. Kellum. I'm sure we have a ton more questions, but for want of time, we appreciate you doing this, and have a great rest of the day and the weekend.
Thank you very much. My pleasure.
Next up, we have another speaker who happens to be an excellent surgeon, in addition to being one of the kindest, most compassionate people I know. I'm thrilled to introduce our distinguished colleague, Dr. Charu Bawari. Dr. Bawari is a vascular surgeon at Houston Methodist Hospital. He completed his training in general surgery, followed by a fellowship in vascular surgery at Houston Methodist Hospital, and has been in practice for 8 years. He enjoys both open and endovascular surgery, and his special interests are pulmonary embolism, complex aortic aneurysm repair, nutcracker syndrome, and thoracic outlet syndrome. He's also focused on developing robotic vascular surgery to deliver the precision of robotic surgery to various vascular beds. Dr. Bawari will be talking today on the topic of pulmonary embolism, a case-based discussion. Please welcome Charu Bawari. Good to see you.
see that? Okay, good, wonderful. Okay, Dr. Dhala, Dr. Masood, thank you so much. Dr. Dhala, thank you for that extremely generous introduction. I don't know, not many people call me kind, but I really say thank you so much for your kind introduction. You know, I feel like pulmonary embolism is very close to my heart. The clot is also close to the patient's heart. It affects them. And it's a topic where I think a lot of specialties should come together. One of them is us, who do procedure-based therapies for pulmonary embolism. I wish pulmonary embolism was as easy as appendicitis. Either you leave it or you take it out. But PE has so many facets to it. We need a help of many people. So it's not just a one specialty effort, it's a multi-specialty effort. I am a consultant for Boston Scientific. Now this is an exercise I wish you all to try. They say don't be on the phone during a conference, but I want you to be on the phone during the conference if you can. If you can text Charu Bavare 486 to 22333. And that's for people who are here or even at home on the phone. And then for people who are online, the polev.com/charubavare486. This is to respond to these case-based discussions as we go ahead. Now, these numbers are going to keep on coming as a footnote on the slide. So if you miss this, don't worry. It's not like PE. You won't die from this. We will keep coming with these numbers. So my hope is after this talk, we should be able to learn about diagnosis, what are the current recommendations, how to operate or how to pursue non-operative management, learn the recommendations for recurrent VTE or venous thromboembolism, and in some special cases if we have time. So this is case 1. There is a case of recurrent DVT and PE. There is a patient who is a 48-year-old gentleman who came in 2 years ago. He had a VTE. He was treated with anticoagulation. He has known protein C deficiency and hypertension. He was on an antihypertensive, he was given a NOAC, and he stopped his NOAC 4 months ago, as is the story in some of our patients. He was seen in the ER again with left leg pain, swelling for 24 hours, and some dyspnea. He is tachycardic, he is slightly tachypneic, he is borderline hypoxic on supplemental oxygen. He is a little hypertensive. He took his antihypertensives, he was good with that. His D-dimer is high. The venous ultrasound shows acute and chronic femoral and popliteal DVT, and the vein is non-compressible, which means it is a fresh acute DVT. There is a saddle pulmonary embolism, and the RV-LV ratio is 1.3. It's high troponins, high BNP, and this is what this poor gentleman has. So you see left PE, saddle, right PE, and you would expect this guy to be on death's door, right? But he wasn't. He was talking to us. He's like, well, it's not my fault I stopped my Eliquis. We said, yes, sir, the customer is always right. So, what management plan would you all recommend is my question, and I'm going to go on to our POLEV. Okay, if you all can put in anticoagulation only, would you do in systemic thrombolysis? Would you all do catheter-based thrombolysis, or would somebody want to place an IVC filter? Look at that, you all are thinking like surgeons now. Okay, good, we got a fair amount of responses, that's nice. Now we shall go back to our talk. So, we did what you all told us to do. We took him for catheter-based treatment. Okay, so he was taken to the OR for percutaneous pulmonary embolectomy or thrombectomy. We had a groin access with a venous sheath. We stick the femoral vein to go up to the right heart and to the lungs. He had an arterial line in the other groin. He had hypotension, PEA arrest, and CPR was initiated in the OR. Okay, so at this point, what would you all do next? Is you continue the procedure, you administer some TPA, you put the patient on ECMO, you do a pulmonary embolectomy. That's where the cardiac surgeons come in. They are much more qualified than we are. And then you stop all efforts. Remember, he's only 48. Very nice. Have you all seen this slide before? You're not doing so well with this. Okay. Oh, it'll come to the end. That's what I'm saying. Did you all read the slide? Because we put him on ECMO. See that? Decision was made to place him on ECMO. So then he was taken to the ICU for resuscitation. He had a planned open pulmonary embolectomy in 24 hours. He was decannulated. We had placed an IVC filter at that time to prevent recurrent VTE because he's known to be non-compliant. And then the patient was discharged home on post-op day 6. So victory for everyone. Second case, this is a provoked DVT with PE. 76-year-old gentleman who came, he has a CAD, MI 5 years earlier. He comes in with an aspirin, antihypertensive, statin, and glycemic control. He has shortness of breath, right leg pain for 48 hours. He underwent a total hip replacement 1 week earlier, and he has not been taking his DVT prophylaxis. He is tachycardic by definition at 90. He is tachypneic. He is not very hypoxic at all, actually, and blood pressure is slightly hypertensive. He has a DVT in the femoral popliteal system, and his CTHS shows a PE involving the left lower lobe segmental arteries, not the kind of picture we saw earlier. So on this patient, what would you all like to do? So we say we give anticoagulation for 3 months, we give him systemic thrombolysis, we do catheter-based thrombolysis, or we do an IVC filter insertion. Oh, good. All right, so this is what we did. We did anticoagulation for 3 months. Then he is in the hospital, he's ready for discharge. In the absence of any bleeding concerns, how long should he be anticoagulated? That's the next question. Three to 6 months, 6 to 12 months, indefinitely, or 6 weeks. The 6 weeks was because I ran out of options. Nobody gives 6 weeks of anticoagulation. Uh-oh. I just gave that one away actually, but yeah. Okay, so you're all saying 3 to 6 months. Very nice. So 3 years later, he's on aspirin again. Patient is compliant for those 3 to 6 months, comes back for an appendectomy. 7 days after the procedure, he has new leg swelling and diagnosed with acute left leg DVT. Aspirin is suspended. He's starting on NOAC for 3 months again. So how long should he be treated with anticoagulation? So he's had one DVT, he got treated, he was compliant. He's come with another DVT which is also provoked, and he has, now you say 3 to 6 months, 6 to 12 months, indefinite, or 6 weeks. Disclaimer, 6 weeks because of no options. So a lot of it, so this is where even I was in dilemma when we treat patients, indefinite between indefinite and a short term. So that's good, we have some controversy, good. Third case, last case, and then we'll go over all the stuff that we have to go over. Provoked intermediate high-risk PE. This is a 56-year-old woman who has an inflammatory bowel disease. I put it there, please remember this fact. Inflammatory bowel disease, has some chronic kidney disease. She's on infliximab for IBD. She comes with 2 days shortness of breath, pre-syncope, and some chest pain. She's tachycardic, tachypneic, hypoxic, little hypertensive. She has a troponin leak. She has a CTA that shows pulmonary embolism involving bilateral segmental arteries. Multiple small segmental arteries are involved. RV-LV ratio is high, and then the bedside echo says there is moderate heart strain. Next question is, patient has extensive bilateral PE, positive troponin, radiographic signs of right heart strain. All this is intermediate high-risk PE. She's tachycardic, but she's stable, and she's responding to some IV fluid. So what management would you want to consider in her? So we have anticoagulation only, systemic thrombolysis, catheter-directed thrombolysis, IVC filter insertion. Oh, very nice. I'm telling you all on the right track, just like surgeons. Okay, so she recovers well. We actually did catheter-based thrombolysis on her, and she recovered well. She's ready for discharge. How long should she be treated with anticoagulation? That's where everyone is, this is where the dilemma is. So 3 to 6 months, I also thought the same, which is not the answer. 6 to, see? Now they're getting better. So answer is indefinitely actually, and I'll come to that in the end because inflammatory bowel disease with DVT is a higher risk for recurrent DVT and PE. Okay, so quickly, we don't want to learn epidemiology. This is, I think everyone knows, it's big, it's bad, it kills, and it kills a lot, okay? Older people get hurt much more, over 70 to 80 years of age, the mortality is super high, okay? And the incidence is super high. So who's at risk? I suggest looking at this big box on the left side, where strongly at risk is lower extremity fracture, major trauma, major orthopedic hip or knee replacement, previous venous thromboembolism, spinal cord injury, or any kind of cancer. The one in the middle is kind of soft, where arthroscopy, autoimmune diseases, congestive heart failure actually, believe it or not, and like Neupogen or erythropoietic stimulating agents, oral contraceptive therapy, and HRT. Weak things are bed rest for 3 days and increasing age, obesity, pregnancy, and long air travel. Please do not discourage anyone from traveling for long distances. They won't get the DVT. People ask me again and again and again. So a simple test when somebody comes to the ER. Remember this, when a clot happens, there is platelet activation, they go into a clot. So then when fibrinogen becomes fibrin, and then plasminogen, which is tissue plasminogen activator, acts on plasminogen to convert that to plasmin, and then plasmin acts on the fibrin to give you D-dimer. That's where this D-dimer comes in. And that's why that D-dimer is a very simple test to know whether there is fibrinolysis or there is breakdown of clot going somewhere in the body. So if you don't have clot, you won't have breakdown. Therefore, if you have a D-dimer, there is a clot somewhere. So there is a high negative predictive value. So if you have a normal D-dimer, there is a very less likelihood of you having DVT or PE. The problem is it's a low positive predictive value, where so if you have it, doesn't mean that you have DVT. It means you could be having cancer or severe infections, or you could have recent surgery. Anything can give rise to high D-dimer. Age adjusted it decreases when the age goes higher and higher because there is some autogenous fibrinolysis that goes on all the time. Okay, so is this a PE or not? So once you have a D-dimer, maybe it's positive, then you look at all these scores. Medicine has come from anecdotal to experimental to observational to database. So all these scores and data, they have to tell us, okay, should you or should you not? The big thing about the Wells score, it gives you the strength to make the decision whether to test the patient more for PE or not. So if you have a low Wells score, I don't want to go into details of all the variables, but if you have a low Wells score, you are relatively safe in saying this patient does not have any more need for further testing for PE. Then there is another Geneva score. So all these scores, what they've done is they've helped us to start our process to get the patient to a diagnosis of PE, and then how bad is the PE. But then remember, the Geneva score was actually prospectively validated only for outpatients. So then the Wells score is the one that we use for inpatients. Somebody comes to the ER, use the Wells score for them. Various imaging techniques, CT angiogram, VQ scan, CT SPECT, or pulmonary arteriogram, and echocardiogram. So I wouldn't go into details of everything, but CT angiogram, everyone gets the CT angiogram, like almost everyone. Even outside ERs have CT angios now, easily available, easily doable, and it's a good diagnosis, gives us good idea about RV-LV ratios and how much is the clot burden on the PE. Also will tell you if there is something else going on, like a big squamous cell cancer causing hypercoagulable state. So a lot of things can be told in this. VQ scan is the benefit of a VQ scan is anybody can get a VQ scan. There is no contraindication. Anybody who fits in that gantry can get it. Problem is, do you know whether everyone has a PE with the VQ scan? No, you just know there is a ventilation and perfusion mismatch. And then you have to correlate to their symptoms. You know, where radiology says correlate clinically. This is where you have to correlate clinically. There is a SPECT scan, which is a little more specific, but not available everywhere. Pulmonary arteriogram used to be the gold standard, where you have to do a pulmonary arteriogram to look at this. But CT angiograms have almost surely, completely taken this away. Much less risk of the procedure as well. Then we have echocardiogram. This is a beautiful study which is bedside, easily done. Almost anyone can do it. And there are so many things that they look at. And here is where the imaging cardiologists are the expert, not me. So I just copied this slide from somewhere. And for the love of God, I cannot remember this. This is a tricuspid annular plane systolic excursion, is how much is the valve excluding or not. And this is actually an important sign when it comes to diagnosing PE in these people. So we won't go into details of echo, but remember echo, the one thing about echo is it can tell you whether the right heart is really good or really bad. It's the one in between which is the problem. That's the gray area where even cardiologists tell us that moderately, mildly depressed function, we don't know for sure. Severely depressed, we can tell you. Normal function, we can tell you. So that's a good aid to know on the extremes. RV failure happens because of many reasons, right? Increased pulmonary arterial pressure, increased RV dilation, so there is decrease in contractility. There is an LV dysfunction because the septum is now bowing into the left ventricle instead of into the right ventricle as it normally happens. And there is some RV ischemia because of myocarditis. So all these signs, that's why you get the troponin leak, you get the BNP levels that are high in the blood. This is mandatory to classify PE now with these new algorithms that are in place so that you know how serious is the patient, what is their risk of mortality, and what is the urgency of intervention. So 4 things are really important. If they have tachycardia, hypotension, which is sustained, not just one episode, sustained hypotension. If they have hypoxia or respiratory insufficiency needing significant amount of supplemental oxygen, and if they have syncope, if they're alone or in combination, it's a bad sign, and they have been associated with a very unfavorable short-term high mortality risk. There are various clinical parameters we look at. There is an echocardiogram, there is a CT angio, and then there are biomarkers. So these 4 will help us risk stratify people into high risk, intermediate risk, and low risk. They used to be called massive, submassive, and not so massive, I guess, normal. But now it is high risk, intermediate risk, and low risk. And we typically see the predominant number of patients we see are usually either low or intermediate risk PE. We don't see the high risk PE all the time. So high risk PE is easy to treat, low risk PE is easy to treat. It's the intermediate one that's where there's a lot of discussion that goes back and forth. Okay, there is something called the PESI score. Everyone asks me, why do you not talk about PESI score? Because it's not that important. The main thing about the PESI score is it lies in the reliable identification of patients with a low risk for 30-day mortality. All it tells us is, okay, does this patient have a high risk of dying from PE or not? And in the short term. In the long term, there's nothing to do with this. So PESI score is good if you want to tell the patient, okay, we have to do this or we don't have to do this because your risk is so high or so low. Otherwise, it doesn't drive our interventions. Management, there is acute management of acute PE and chronic PE. If there is time, we shall go into chronic, but acute, there are 4 big things that we have to look at. Hemodynamic and respiratory support, there is anticoagulation, reperfusion strategies, and the last is IVC filters. And those hemodynamic and respiratory support can be just oxygenation by a mask or then endotracheal intubation, which is actually bad for the right heart. There is pharmacologic treatment, there is ECMO. And for initial anticoagulation, parenteral anticoagulation is the standard of care, and then you can transition to vitamin K antagonists and the NOACs, or the newer oral anticoagulants. Reperfusion strategies is where we are called in for systemic lysis, catheter-based treatment, or for surgical embolectomy. And the last thing is IVC filters, not for treatment of PE, but prevention of recurrent PE. Okay, then we have the initial hemodynamic support. So you can start with supplemental oxygen or a high flow nasal cannula. Remember, there's positive pressure ventilation, which means intubation and placing them on positive pressure ventilation actually decreases venous return to the heart and worsens the cardiac output. So even when we do procedures on these patients, we try not to intubate them in the operating room. We are on sedation monitored by the anesthesia team, and local, of course. Pharmacologic treatment, remember, there is always do cautious volume overloading. You don't want to burden the right heart too much. Vasopressors, norepinephrine is usually preferred. It improves ventricular function without increasing pulmonary vascular resistance. And vasodilators could be used, but they actually worsen the systemic hypoperfusion, so you don't want to use them at all. ECMO is definitely the standard where it comes for cardiac arrest or impending cardiac arrest, where we know the patient is an extremist who needs stabilization before looking at different strategy. There are no randomized controlled trials on ECMO, because who's going to say, hey, I don't want ECMO, let me die? No one's going to say that, right? So clearly you cannot do that. But then there are observational studies and data driven from ECMO. 5 days or more of ECMO, you can start seeing more and more complications. So obviously short-term ECMO is good. Then we have anticoagulation. Parenteral anticoagulation with low molecular weight heparin and fundoparanox is preferred over heparin unfractionated heparin. So somebody comes to the ER with a PE, if you know if you highly suspect it's a PE, or you've had a diagnosis of PE, first thing to do is to give them 1 milligram per kilogram of Lovenox, ideal body weight, not actual body weight, but ideal body weight. It starts their anticoagulation treatment right then and there. To get heparin as a dose, as a bolus, and then a dose, it takes some time for the heparin pharmacokinetics to come up to therapeutic levels. Unfractionated heparin, although is preferred in people with renal impairment, and it could be considered with people who are actually in cardiac arrest who may need urgent surgical intervention right then and there, because low molecular weight heparin will stay in their system, and unfractionated heparin can be reversed immediately if you need it. The vitamin K antagonists and the NOACs, these are all oral anticoagulants are for low-risk PE. The NOAC versus vitamin K antagonists, they have a similar efficacy, but then decrease bleeding risk rate with NOACs. Again, that's only for the first 30 days. In the long term, typically they are the same. So don't be shy of giving somebody Coumadin if they really meet criteria for that. Reperfusion strategies is we do either systemic thrombolysis, catheter-based interventions, or surgical embolectomy. And systemic thrombolysis essentially is a big slug of TPA given IV, usually 100 milligrams as a dose. It leads to decreased pulmonary arterial pressure, decreased pulmonary vascular resistance, decreases RV dilation. The effect is pretty profound and pretty quick. And some people actually this is a life-saving maneuver for people. The greatest benefit is within 48 hours of the onset of PE, because beyond that time, the clot gets more and more organized, so the TPA doesn't act on it that easy. There is a significant reduction in mortality and recurrent PE with giving systemic lysis. And then consider this in people in cardiac arrest or syncope, who have had a right heart thrombus that on echo or CT, or there is a thrombus in transit starting to go from the right ventricle into the PA, or if there is a PFO and there is a clot going across that. The systemic lysis, actually, it's an FDA recommended dose of 100 milligrams over 2 hours. There is a study, the Moffitt trial came up with a reduced dose of 50 milligrams, and that was mainly for low body weight patients or patients more than 60 years of age. So it could be considered a treatment for normal body weight or ideal body weight patients, or who you think may benefit from just a little TPA. But I always say if you meet criteria, you should give the full dose if you can. Lytic therapy in intermediate high-risk PE came from the PYTHO trial, and that prevented hemodynamic decompensation. So there is a definite data set on systemic lysis on these patients as well. The problem is if you give systemic lysis, it lyses that clot and can lyse clot anywhere in the body. So there is a risk for major hemorrhage and stroke with these people. So there is a big list of absolute and relative contraindications for thrombolysis. So anybody who's actively bleeding, he's had any history of intracranial hemorrhage in the past, any ischemic stroke within 3 months, anything that essentially puts them at a risk for bleeding or rebleeding, and especially cavitary rebleeding, which is brain, chest, or belly, you don't want to give them TPA. There are relative contraindications, so anybody with advanced age more than 75, a body weight less than 60 kilos, nobody in Texas has that. Anybody with bleeding diastasis or acquired coagulopathy, anybody with thrombocytopenia. Again, 100,000 is not so big, 50,000 I think is what we go by mainly. So on and on. So there is a big list. So my suggestion is anybody who's wanting to give systemic lysis, you should quickly review that list and make sure that we check off those boxes before the patient is given something. When we do catheter-based thrombolysis, this is for intermediate high-risk PE with risk for clinical deterioration. And there is no absolute contraindication for thrombolysis. So in these people, we can do the thrombolysis with a much lesser dose than a systemic dose. So therefore, we can treat them without giving them a big slug of TPA. And that's why catheter-based treatment is preferred sometimes. Especially people with high-risk PE who have relative contraindication for thrombolysis, for systemic lysis, can benefit from catheter-based treatment. There is the Seattle 2 trial that came out with the actually good landmark trial with the ECOS catheter, which is a thrombolysis catheter with an ultrasound probe to help disperse the TPA within the clot. And it looked at RV diameter, RV-LV ratio, and it saw that pre-procedure and post-procedure at 48 hours, there was a drop in the RV-LV ratio and a drop in the mean PA systolic pressure. So as clinically significant and statistically significant. The Optalize trial actually looked at different doses of TPA and different durations. So there are 4 arms that were here. So one arm had 4 milligrams per lung over 2 hours. That's a lot. That's 2 milligrams per hour. And there is 4 milligrams over 4 hours, over 6 hours, and then 12 milligrams over 6 hours. So essentially, they wanted to see, do you have to give a full 24-hour treatment with TPA, or can you just give initial few hours and then the body will take care of it? And surprisingly, actually nicely, it saw that there was a good reduction of RV-LV ratio over all 3 arms, on all 4 arms. So therefore, short duration of TPA with catheter-based treatment is actually pretty good when it comes to catheter-based management. Now there are so many, there's a buffet of devices we can use, right? We love doing these procedures because in the end, we get this. Let me show you. We get this. These are our favorite cases. These go on Instagram and everywhere. So you have this big clot sitting on both sides, left side and right side. And we go in with the suction-based thrombectomy catheter and we suck these clots out. And then we put them on the back table. This is the tech writing right and left as if it makes a difference. But there is, we know exactly what's coming from where. And in the end, we look at pulmonary arterial pressures before and after, and then we look at this arteriogram. And the arteriogram actually doesn't show that the clot is gone completely, but then you can see that all the arterioles actually are filling well. So that's what we look for. We also look for the pulmonary artery pressures before and after, like I said, and any significant drop of about 10 or 15 is good enough for us. And that tells us the procedure is pretty successful. Surgical embolectomy is actually not very often performed, but life-saving and a really good procedure if the patient is selected well. So there is high-risk PE with absolute contraindication for lytic therapy, or intermediate high-risk PE with absolute contraindication for lytic therapy. So you cannot try any of these lytic catheters on them. Or if somebody has got lytic therapy and they've failed thrombolysis and are clinically still not doing well. There could be cardiogenic shock that can lead to death before thrombolysis can take effect. So they are in the ER, they're about to code, and then you put them on ECMO and take them for surgical embolectomy. Somebody who has a thrombus in transit across a PFO, that's a big risk for stroke, and you want to get to that clot and not try to suck it out because you can fragment and send it across somewhere. And the worst outcomes are in patients with preoperative cardiac arrest. So anybody who arrests in the ER goes to surgical embolectomy, they don't do so well. So this is a right atrial clot, and this is a clot in transit going from right atrium to left atrium across the PFO. And this is my favorite procedure to see on video. So patient is on cardiopulmonary bypass, pulmonary artery is opened up. I don't do this, by the way. I just watch the video. So the pulmonary artery is opened up, and now you'll see the enormous amount of clot that comes out. And you see that white thing, that's like a platelet plug that sits there, and then they're taking out more and more and more, it's never ending. And so we cannot clear all of this with suction thrombectomy or TPA, I don't think so. We don't know, we never study our patients post-thrombectomy, we only look at pulmonary arterial pressures, but I don't think we can get all of this. Also remember, this is magnified 3.5 times, so it does look bigger than it is, but it is pretty big. We'll give it that way. So you see there is still some clot left, and so they have to go into individual segmental, initial segmental arterioles to get these out. And it's like a cast of the femoral vein with like even a tributary that's seen out there. Pretty impressive, isn't it? So then we look at IVC filters. And about 10, 15 years ago, IVC filters was placed for anybody. You have a PE and you sneeze, you get an IVC filter. But not anymore. We know that these filters have been a cause for problems if left in for too long, and the filters are made up of nitinol, which is a very fragile element which you place in the IVC. The IVC is an organ, it's not just a pipe. It moves back and forth, it twists from side to side when I do this, and it also goes up and down when you breathe in and out. So that filter gets a lot of stress on it. So these filters can break, they can embolize, they can break, they can go out of the IVC, and we see all sorts of problems. So we reserve them for absolute contraindications for anticoagulation. So if you have a PE or a DVT, you cannot get anticoagulation. You have to get a filter because you will get a PE or a recurrent PE. And there is if they are on anticoagulation and they get a recurrent VTE, you have to get a filter. Any complications, for example, you put them on anticoagulation and they get a GI bleed, or they get an intracranial small bleed, so then you cannot continue the anticoagulation, you have to stop it. And if there's a large free-floating proximal thrombus, we get called a few times at the ultrasound, there is a lip going like this. I mean, yes, you can actually go after that, but there is a soft indication for placing a filter and then going after the clot. Recommendations are to place retrievable filters. We don't place permanent filters anymore. And these are the types of filters. There's a big buffet. Various companies have come in with filters. All these filters in the green box which have a hook on them, they actually can be retrieved. There is a lasso that we pull it from the neck. All these filters which look benign, they're not. They'll stay in the body, and they're pretty dangerous when they can deform the vena cava. Now, the PERT consortium in 2019 came out with their algorithm. I won't go in a lot of detail, but essentially when you risk stratify the PE, that's where the process starts. You risk stratify them and then start looking at what we can do. So if there is a high risk PE or a massive PE, as we call it, if you have cardiac arrest, you consider mechanical support or ECMO. That's obvious. If you don't have cardiac arrest, then you start looking at can they get lysis or not. If they can get lysis, systemic lysis is the treatment. If there's a relative contraindication, then consider them getting catheter-based treatment. If you have an intermediate risk PE, there could be high risk or low risk. And the intermediate high is where you have both troponin and BNP leak, and you have an RV dysfunction, which is either on echo or on CT. And then you should do interventions for them. And if you have intermediate low risk, which is either the RV is abnormal or you have a troponin or BNP leak, you consider anticoagulation. But if they clinically don't respond, then you can consider treatment for them. For the low risk, anticoagulation is all they recommend. The European Society for Cardiology also has their protocol, also came out in 2019. But essentially, it's all the same. If you have hemodynamic instability, don't think of anything else, consider mechanical support. If you have low risk PE, consider anticoagulation. And everything in between, you have to look at clinical scenario and their possibility of getting lysis, catheter-based or systemic. Management of chronic PE, where pulmonary embolism, initial pulmonary embolism can lead to long-term sequelae. And so there is a duration of treatment, there is assessment of VTE recurrence risk, then you want to see anticoagulation, bleeding risk, and then patient with cancer. So duration of treatment, we'll come to that first few questions we asked earlier. All patients should be given 3 months of treatment. So that 3 to 6 months is typically what people get. And NOACs versus vitamin K antagonists, there is no clear winner. The long-term major bleeding complication is actually as high as 6% with NOAC. So both of them are equally bad. But then you have to tailor them to patient factors. So one thing is, remember, if anybody has antiphospholipid antibody syndrome, they do much better with warfarin than newer oral anticoagulants. If you are concerned about recurrence, then aspirin is not the treatment, NOACs is the treatment. So remember this, NOAC versus vitamin K antagonists, initially NOACs are better, long term both are the same actually. Then this is the recommended treatment. So who needs more anticoagulation? You've given 3 months, now where do you need to increase more? So it's indefinite duration is recommended for people presenting with recurrent VTE. If you have a DVT and you have you have a DVT and you come back with another one, and which is not related to a provoked reason. So you have de novo DVT that happens, you should consider indefinite anticoagulation. And oral anticoagulation for a vitamin K antagonist is for indefinite period recommended for somebody with antiphospholipid antibody syndrome. Somebody who has no risk factor, somebody who has unprovoked DVT, you should consider lifelong anticoagulation, which was not the case many years ago actually, because we don't know whether the next person is going to get a new DVT down the line, especially because this one was unprovoked. So unprovoked DVT, our first case who had an unprovoked DVT came back, although he stopped his Eliquis, he had a recurrent DVT, he should be given lifelong treatment. Management of chronic PE, the assessment of VTE recurrence risk, you have to see whether they can get a recurrent PE. This is interesting. So somebody who comes in with a PE, their venous thromboembolism is likely to recur as a PE. Somebody who comes in with only a DVT, they are more likely to recur only as a DVT and not as a DVT-PE. And so somebody who comes in with a PE, their overall recurrence and mortality is about twice as high. So PE is definitely much more serious than just a DVT. So the recurrence is expected to be the same if the anticoagulants are stopped after 3 to 2 months of treatment compared with longer treatment periods. Extended oral anticoagulant treatment reduces risk for recurrent DVT, but actually this is offset by the risk of bleeding. And so you have to be careful, whom do you want to continue lifelong, right? So going by the previous chart. And anybody with less than 50 years should prompt a thrombophilia workup, so a hypercoagulable workup, and they may need long-term anticoagulation. Now you look at these small things where if you have a low risk for long-term recurrence, anybody who has major surgery or anybody who has general anesthesia, etc., etc. So if they have another procedure, yes, they are likely to get DVT. Should you put them on anticoagulation or should you put a filter? No. Only if they get a DVT should you do that. But somebody who is on oral contraceptive therapy, somebody who is confined to bed for more than 3 days with an acute illness, like in septic shock, you're in the ICU, somebody who has a huge fracture with reduced mobility for more than 3 days, and anybody with inflammatory bowel disease or autoimmune disorders. These are the people where you have to consider long-term or indefinite anticoagulation because their risk of recurrence is high. Anybody obviously with active cancer or multiple VTEs in the past or antiphospholipid antibody syndrome should be given long-term treatment. What's the bleeding risk? So bleeding risk is, like I said, almost the same. Initially, the risk is higher with vitamin K antagonists in the first 1 month, but then after that, it normalizes. And the risk factors are if you're advanced age, if you have prior bleeding, active cancer, the risk is slightly higher, and hepatorenal disease. Special things for patients with cancer. Low molecular weight heparin should be considered for the first 6 months. That is the standard of care. And then for patients with PE and cancer, extended anticoagulation should be given till the treatment of the cancer is finished. So they are at high risk for recurrent DVT and PE. Patients in pregnancy, usually we recommend a VQ scan or a low-dose protocol, CTPE protocol. Again, if in the first trimester, then only VQ scan. If it's in the third trimester, you can get a CTA without a problem. And then low molecular weight is the anticoagulant of choice because unfractionated heparin can cause HIT and bone loss in the kid. And then NOACs are contraindicated in pregnancy because there are no testing done. Warfarin we know crosses the placental barrier and it can cause fetal bleeding in the fetus. Thing that I looked up on is VTE with COVID-19. We saw so many de novo arterial and venous thromboemboli in patients with COVID-19 in the last 2 years. The thing was, there was a trial that came off with therapeutic anticoagulation with heparin in critically ill patients. And there was no difference actually in survival between patients receiving full dose versus prophylaxis. So now consensus is give them prophylactic dose. So to summarize, I think we are within time. So if the suspicion for PE is high, initiate anticoagulation with low molecular weight heparin. And then use validated algorithms for PE. Otherwise, people say, okay, he had a PE, I just sent him home with some Eliquis. No, don't do that. Or Xarelto, don't do that. Try to get an algorithm going for them, risk stratify them, and then treat them accordingly. And somebody who's stable with a confirmed PE, you have to have further risk testing to give them the appropriate treatment and make sure that they get long-term treatment if needed. And in high-risk PE patients, if you see somebody, make some plans for reperfusion strategy because they will need something to be done for them. Consider their risk profile, involve the appropriate specialties immediately. And that's where PERT teams and those teams come into play a lot. Traditionally, we used to give vitamin K antagonists, but actually NOACs are preferred initially. Long-term, you can decide what to do. Recurrence of VTE, the risk of recurrence is actually lifelong unless there is a presence of a strong factor. So if you have an unprovoked DVT, your risk of DVTE is pretty high. PE patients should not be lost to follow-up. One thing I did not touch upon is chronic thromboembolic pulmonary hypertension, which is out of the scope of my topic here, but these are extremely debilitated patients who go to that point. So initial treatment of PE matters, follow-up matters for them, and sending them to a dedicated pulmonary CTEF team is important. This is all I have. I have one request is, I have a little QR code for myself to see how I did if you all have the time. So thank you so much again. Thank you, Dr. Dhalla. Thank you, Dr. Messi.
Thank you, Dr. Bawari. That was a hugely entertaining and brilliant talk. Thank you. Do we have any questions from the audience? Well, I'll just ask, it's that intermediate PE is very nuanced, right? And unless you know the algorithms in and out, it's hard to kind of pinpoint who needs catheter-directed and stuff. So do we have, in the Houston Methodist system, do we have a pulmonary embolism response team?
No, and we don't, and that is my fault. That was my baby about a year and a half ago, and we've dilly-dallied along that. Like I said earlier, because it's no single specialties, I would say problem, but diagnosis, we have to have a lot of people. There are a lot of people who are interested, like Dr. Couturier, she's part of the team. We just have not moved ahead. My hunch is before the end of the year, we should have a good team in place.
Yeah.
And we have the right specialties to do it. We have people who are dedicated, who are interested.
Yeah.
But
and that's why we call you all the time. He said, who do we call, Dr. Bawari? So. Yes. Yeah. Actually, could you come over here? If you don't, Vincent? Thank you.
Thank you for the talk. One of my questions was, in a code situation, whenever you feel like the cause of a code was a pulmonary embolism, what is your take on just administering TPA?
It's a fantastic question because it comes up a lot. Is if you suspect TPA, the thing with TPA people get scared about is, oh, I've given TPA, now what we can do nothing. Actually, no. The half-life of TPA is a few minutes, and so you can give TPA, but I would say that you have to be sure they don't have a bleeding episode that's contributing to this, or they don't have an absolute contraindication for lysis. Because if they do, and you give TPA, yes, you save them from the PE, but then you put them at a huge risk of getting a secondary complication from bleeding. But don't be scared of giving TPA, I would say, for people, because it washes away quickly.
Thank you.
Another question from the audience. How long is systemic anticoagulation after pulmonary embolectomy?
So systemic anticoagulation or systemic thrombolysis? I'm sorry, I didn't.
Anticoagulation.
It depends.
After the embolectomy.
So it depends on their risk factors for recurrence of VTE. So if it's a provoked DVT with a high-risk PE leading to extremis leading to embolectomy, the guidelines remain the same, 3 to 6 months if it is a provoked, indefinite if it is an unprovoked DVT, or if they have persistent risk factors for recurrence.
Thank you, Dr. Bawari. I think from the hemodynamic support you mentioned norepinephrine. What about dobutamine? Is there a role for dobutamine in this patient with RV dysfunction or depressed?
So from my reading, I don't know actually. The article that have talked about vasopressors are more so for systemic vascular resistance, increasing that, and increasing the venous return back to the heart. But I'm not very sure about dobutamine of exactly how much or how long to be given. No, sir.
Okay, because we quite a few times end up using dobutamine. Obviously, be mindful of you want to avoid vasodilatation, but for the RV support, dobutamine is better than Melanon. Let's put it this way for systemic. Okay, yes, all right. If you want to give a take-home message for the critical care team, that as nurses, intensivists, PAPs, or pharmacy, what would like you to summarize for the critical care team?
I would say the index of suspicion should be high, because PE is not a diagnosis we can palpate or auscultate. PE is a diagnosis of predominantly of clinical suspicion and imaging. And in these cases, if you suspect PE, there is nothing wrong in giving one dose of anticoagulant of low molecular weight heparin, and definitely call whoever either the interventionalists that you know, or in our ICU setting, it's the vascular surgeons who respond to PEs. But having an high index of suspicion, initiating anticoagulation, and then making sure that whether they need systemic lysis or not, and appropriately proceeding. So I hope I answered that question somewhere. Thank you.
Thank you.
Thank you very much.
Our next speaker is another scholar and expert, Dr. Xavier Monet. Dr. Xavier Monet is professor of intensive care at the Paris-Saclay University. He works in the medical intensive care unit of the Bicêtre Hospital. Dr. Monet completed his medical studies at the Paris 6 Medical School, and he earned his medical degree with specialty in cardiology and intensive care medicine. He obtained his PhD from the Paris-Saclay University. He's published over 200 peer-reviewed articles in medical journals and is the author of several didactic reviews and book chapters. His main field of research investigations are in acute circulatory failure and its treatment, hemodynamic monitoring, and heart-lung interactions. We're very fortunate to have Dr. Monet today live from Paris, and he's about 7 hours ahead of us, so it's about 4 p.m. in Paris. And he'll be speaking on the topic that's of great interest to me, heart-lung interactions and the effects of positive pressure ventilation, specifically talking about hemodynamic alterations in ARDS. Please welcome Dr. Monet.
Thank you very much. I'm very pleased and honored to be here with you, not really here, but thank you very much for this invitation. Thank you. And I start by disclosing my conflict of interest with Apache Medical Systems, with Baxter, and with Philips, although I will not speak about hemodynamic monitoring today. What are we speaking about when we speak about heart-lung interactions? About the fact that, as you know, the respiratory system and the cardiovascular system stand in the same space, closed space, the thorax, but, and this is the problem, they work with a different pressure regimen, and this creates these interactions we're speaking about. What is the basic physiology? And it's very important to understand that, even though it might be a bit complex, otherwise it is not possible to understand all the clinical applications and consequences of these interactions. In fact, mechanical ventilation may alter the hemodynamics, either decreasing cardiac output or increasing cardiac output, depending on the circumstances. And basically, this is due to the increase in two different pressures, the transpulmonary pressure and the intrathoracic pressure. Let's start with the intrathoracic pressure. As you know, the intrathoracic pressure is the pleural pressure, which means that it is the pressure that is surrounding the cardiac cavity, and especially the thin right atrium. So, mechanical ventilation, positive pressure ventilation, by increasing the intrathoracic pressure, increases the right atrial pressure, which is the downstream pressure of the venous filter, and this tends to decrease cardiac preload. Then if both ventricles are preload responsive, which means that if their cardiac output is dependent on cardiac preload, this may decrease cardiac output. At the same time, this intrathoracic pressure is transmitted to the left ventricle, and it tends to decrease the left ventricular afterload. Why? Because the transmural pressure decreases if the mechanical ventilation helps the contraction of the left ventricle by pushing against the free wall of the left ventricle. And this may, on the contrary, increase cardiac output. The transpulmonary pressure is the pressure difference between the alveolar pressure and the intrathoracic pressure. So it's a pressure difference, which means that you understand that it is the descending pressure of the lung. And the increase in the transpulmonary pressure, because of course, during mechanical ventilation, the alveolar pressure increases more than the intrathoracic pressure. This increase tends to increase the pulmonary vascular resistance to impede the right ventricular ejection, and eventually this may decrease cardiac output. And basically, this increase in pulmonary vascular resistance is due to the stretch of the pulmonary circulation. Nevertheless, here, one must be it's a bit more complex. In fact, the pulmonary circulation might be divided into two different types of vessels. The extra-alveolar vessels that are outside the alveoli, and the intra-alveolar vessels which are in direct contact with the alveoli. And during mechanical ventilation, when the lung volume increases, initially this tends to enlarge the extra-alveolar vessels, to increase their diameter, and so to decrease the pulmonary vascular resistance. And this happens when the lung volume increases through the functional residual capacity, which means that at this time, when the lung volume increases until the FRC, the pulmonary vascular resistance decreases. It means it happens when, for instance, heat recruits the lungs. Nevertheless, if the lung volume increases more above the FRC, then it tends to crush the alveolar vessels, the vessels that are in direct contact with the alveoli. This time, it tends to increase the pulmonary vascular resistance, which means that eventually the relationship between the pulmonary vascular resistance and the lung volume is this U shape, and the bottom of the shape is the FRC. And you understood that in theory, if one recruits the lung with mechanical ventilation, one should decrease or should not change the pulmonary vascular resistance, while if we overextend the lungs, we should increase the pulmonary vascular resistance, at least in theory. In fact, you know this relationship in another way because it resembles the West-Zones graph that we all know, with zones 1, where the alveoli crush the pulmonary circulation, and zones 3, where the circulation is free. It is, in fact, the same relationship. In turn, in any way, this may decrease cardiac output. There is another indirect way for which the increase in right ventricular output may decrease cardiac output, because if the right ventricle dilates, it may crush the left ventricle, which may, of course, aggravate a decrease in cardiac output. So you see that positive pressure ventilation may either decrease or increase cardiac output. And of course, the weight between both depends on the clinical circumstances. And so if we speak about the clinical consequences of these heart-lung interactions, there are 4 important points. Positive pressure ventilation improves, as you know, cardiogenic pulmonary edema. It helps predicting fluid responsiveness. On the contrary, heart-lung interactions have deleterious effects during the weaning of mechanical ventilation, and of course, when we ventilate aortic patients. So, what explains that these clinical circumstances are so different when we speak about heart-lung interaction? Why is positive pressure ventilation so beneficial when we ventilate patients with cardiogenic pulmonary edema? How do we explain in that circumstance the benefits of positive pressure ventilation? In fact, as these patients have pulmonary congestion, we all know, this makes the distension of the pulmonary circulation less efficient, if I may say. And also because the left ventricle is failing, it is much less likely to be preload responsive. And because of these both circumstances, the decrease, the deleterious effects of heart-lung interactions are less likely in this case. And we are left with the positive effects of heart-lung interaction. By decreasing cardiac preload, mechanical ventilation exerts a similar effect as with diuretics. And by decreasing the left ventricular afterload, it's the same effect as the arterial effect of nitrates. Mechanical ventilation is really a true treatment, a hemodynamic treatment of cardiogenic pulmonary edema. And it's very likely that the respiratory effect of mechanical ventilation is less important. Of course, it recruits alveoli, it helps increasing the FiO2, and so it may also improve the lung compliance. All this leads to a respiratory improvement. But again, it's very likely that the hemodynamic treatment, the part of this treatment, is more important. And you know, and it's not my topic today, but you know that it's been very clearly demonstrated that positive pressure ventilation, either with NIV or with pressure support, either with CPAP, is beneficial in this patient with cardiogenic pulmonary edema. And that might be the first message to keep in mind. Positive pressure is a complete hemodynamic treatment of cardiogenic pulmonary edema. The second circumstance is deleterious, and it's during ARDS. And we all know that positive pressure ventilation may impair hemodynamics in these patients when we ventilate them. What are the particularities? There are two ones. The first is that we use, at that time, very high levels of intrathoracic and transpulmonary pressure because of high PEEP levels. And the second particularity is that there are many factors beyond PEEP that contribute to increasing the pulmonary vascular resistance. It means that because we use very high alveolar pressure, the consequences, of course, might be stronger and more deleterious. We all know from the beginning that PEEP is definitely the factor that impairs hemodynamics. We know that it exerts a positive ventilatory effect. You see, in 1970, it was obvious that when you decrease PEEP in this patient, of course, you decrease the airway pressure, you decrease PaO2, but at the same time, you increase cardiac index. There is this balance between the positive respiratory effect and the negative deleterious effect on hemodynamics. In theory, you understand that it's only theory, that all this may especially depend on the recruitment induced by PEEP. And in theory, it's not really well demonstrated. If PEEP recruits the lungs, it should not increase the pulmonary vascular resistance, or at least less than if PEEP overdistance the lungs. Also, we all know that it's especially during ARDS that the right ventricle tends to dilate. You know that the right ventricle is very sensitive to any increase in its afterload, and it's especially during ARDS that we observe this acute core pulmonary. An important message is likely that it's not in all the patients, it's only a minority of these patients. For many years, it was not that clear, but from this publication of Armand de Sapp a few years ago, we know that it occurs in 20% of the patients, 25% of the patients. It's not all the patients. Nevertheless, when it happens, it's definitely a factor that impairs prognosis, as the presence of acute core pulmonary is an independent factor of severity, and you see that it tends to double mortality in this patient. Okay, but in practice, how physiology may help us manage these patients with right ventricular failure? What should we do and not do in practice facing a patient with right ventricular dilation? Let's imagine a patient with ARDS, for instance, on day 3, the PF ratio is 110, and we observe right ventricular dilation with echo. And of course, echo is the gold standard for assessing the right ventricular function. Nevertheless, you will not do echo every hour in your patient. So it's not very good for And that's the point on which I would really like to insist, because a very good way to detect right ventricular failure in this patient is just to observe CVP, which is very easy to measure in this patient. If, for instance, on Wednesday the CVP is at 8, and a day later CVP is at 20, you must suspect, and you easily suspect, that there is right ventricular failure. And I think it's a very good reason for measuring CVP, which is even no more recommended by the Surviving Sepsis Campaign. I think we should measure CVP, not for predicting fluid discomfort, but it's a very good marker of right cardiac preload. And for instance, it might be very useful for detecting LV failure during ARDS. But then more practically, what should we do facing this patient? I think it is a crucial question, because I think that intuitively, many colleagues would tend to reduce PEEP. If PEEP is at 12, they would try to decrease PEEP, expecting that it would improve the right ventricular function. Likely, it might be a solution, but I would like to insist on the fact that it's not only the only solution. Because, of course, we should limit the plateau pressure to reduce the pulmonary vascular resistance. But again, we must bear in mind that during ARDS, many other factors contribute to increasing the pulmonary vascular resistance. And the first of these factors is the microvascular remodeling, the thrombi in this microcirculation. Hypoxemia is also, and on this, of course, we cannot do anything. Hypoxemia is also a factor that contributes to it. And in the study I showed before, the PF ratio was also an independent factor that explains the occurrence of acute cold pulmonary. And so we should try to improve PaO2 if possible, and especially by proning the patient, for instance. Hypercapnia also contributes to increasing the pulmonary vascular resistance. And there have been some studies showing that if you increase the PaCO2, you enlarge the right ventricle. So perhaps that's not only reducing PEEP, but also increasing the minutes ventilation might be a solution in this patient. This volume status is also very important to consider. And this is what we showed in this study more than 10 years ago with Jean-Louis Seboul now. We wanted to observe the hemodynamic effects of PEEP on the pulmonary vascular resistance. And we included patients with severe ARDS, and we increased the PEEP level, from 5 to 13. And at PEEP 13, we performed a passive leg raising in order to have a pseudo-fluid challenge, a reversible fluid challenge. So it means that we increase at the higher PEEP level, at the highest PEEP level, we increase the intrathoracic blood volume. Of course, we observed that when we increased PEEP, and these patients were equipped with a pulmonary artery catheter, the right ventricular absolute increased, the PVR increased. Cardiac index decreased. It's not surprising. But what was more surprising was to observe that in all the patients, the passive leg raising test increased cardiac output, and this was due to a decrease in the pulmonary vascular resistance. Increasing the intrathoracic blood volume of these patients decreased the pulmonary vascular resistance. And we made the hypothesis that it was very likely because by filling the pulmonary vessels, by increasing again the intrathoracic blood volume, we relieve this compression of the pulmonary circulation by the alveoli, and it means that we decrease the proportion of zones 1 and 2 compared to zones 3, the west zones. And perhaps it may explain why we decrease the pulmonary vascular resistance. So it might be another way to reduce the acute cold pulmonary. I do not mean that we should give more and more fluid to these patients, but at least avoid hypovolemia. Finally, a very good way, because in these patients, it's not always possible to decrease PEEP, because when you decrease PEEP, for instance, from 12 to 5, what first decreases is PaO2. Another good way to improve the patient without decreasing the PEEP level is to prone the patient, because today, I do not have time to insist on that, but today it's very clearly demonstrated that when we prone the patient, we unload the right ventricle. This is what we showed in this study again with the pulmonary artery test. Definitely, the pulmonary vascular resistance decreases a lot. And in another study, we showed that prone positioning is really a fluid challenge, because by increasing the abdominal pressure, you increase the mean systemic pressure, the upstream pressure of the venous return or venous return, and in this way, again, you may fill the pulmonary circulation and relieve the compression of the pulmonary circulation. This physiology helps us to understand that facing a patient with ARDS and right ventricular failure, reducing the PEEP level is not always possible, but it's not the only option. Finally, well, not finally, but the third consequence of heart-lung interactions is the cardiac failure during weaning from mechanical ventilation. In fact, the mechanisms are the opposite mechanisms compared to the ones that explain the improvement of patients with cardiogenic pulmonary edema. When we disconnect a patient from the ventilator, or when we decrease the pressure support of this patient, we reverse all the positive effects of mechanical ventilation. We increase cardiac preload. We increase the left ventricular afterload. And it's very important because in patients with left ventricular failure, they are very sensitive to any increase in afterload. And also, you understand that the adrenergic stress and hypertension may contribute to this increase in LV transmural pressure. Finally, the risk factor for this weaning failure from cardiac origin is definitely COPD, because patients with COPD have a ventilation at very high pulmonary volume, as you know, and we have seen that it is definitely a factor that increases the right ventricular afterload. And so from physiology, we know that the two main risk factors of weaning failure from cardiac origin are COPD and the previous failing left ventricle, and indeed, this is what is demonstrated by the study. For many years, it was not that clear what was the incidence of this weaning-induced pulmonary edema. I share with you the results of this study. We just performed the WIPO study, the multi-center study, and we included 500 patients performing a large number of SVTs. And just to show that quickly, the incidence of weaning-induced pulmonary edema was 36%, and it was, and the two main risk factors were again cardiac failure and COPD. At least we may say that some patients are unable to cope with the loading conditions changes during weaning from mechanical ventilation. Finally, this time, a very helpful way we use heart-lung interactions at the bedside is for predicting fluid responsiveness. And this is mainly by using with pulse pressure and stroke volume variations, PPV and SPV. In fact, at each insufflation, we have seen that each insufflation, the right cardiac preload decreases. And it means that a few cardiac cycles later, the left stroke volume will decrease. And this creates a decrease in the arterial pulse pressure. And this amplitude of the pulse pressure changes is a reflection of preload responsiveness. Another easy way to explain that is just to say that during mechanical ventilation, we change the preload, we change cardiac preload at each insufflation, and then it helps us assess the slope of the Frank-Starling curve. If cardiac output changes and stroke volume and pulse pressure changes with mechanical ventilation, if PPV is high, it's very likely that the patient is preload responsive. If mechanical ventilation doesn't change stroke volume, it's very likely the slope is flat and the patient is fluid unresponsive. Another way, another test that helps predicting fluid responsiveness and that uses the heart-lung interactions is this end expiratory occlusion test that we developed years ago now. The principle is the same, but it is much easier to measure and it has less limitations than PPV and SVV. At each insufflation, you agree that we have seen cardiac preload tends to decrease. And so the idea is that if you stop mechanical ventilation for a few seconds, you allow cardiac preload to increase for a few seconds. It is a preload challenge. It must be long enough because you must, the preload bodies must cross the pulmonary circulation. But eventually, if cardiac output increases during this end expiratory occlusion, it is very likely that both ventricles are preload responsive. So again, we perform a preload challenge by using the ventilator, and we have shown, and not only us, but many studies show that it is a very reliable test to assess preload responsiveness. Mechanical ventilation, of these, helps predicting fluid responsiveness through pulse pressure and stroke volume variations, and with the end expiratory occlusion test. And with this last message, I thank you very much for your attention.
Thank you, Dr. Monet. Thank you so much. That was a very animated and brilliant presentation. Thank you. We have one question. Can you hear me, Dr. Monet?
Sure, I can.
Okay, great. One question from the audience. Does proning in a mechanically ventilated patient with ARDS improve the strained RV? And has this been reflected in patient-centered outcomes?
In fact, it's a very good question because prone positioning has definitely a hemodynamic benefit, a certain hemodynamic benefit. And of course, it also improves oxygenation. And in the benefits demonstrated with prone positioning on outcome, decreasing mortality, one does not know whether it is due to the respiratory or the hemodynamic effect. And it's likely to differentiate both. My message is more that in a patient with RV failure, it might be tested to help the right ventricle. If it is this that changes outcome, I'm not sure. But of course, the improvement of mortality with prone positioning has been demonstrated, especially by one large study and some meta-analysis of smaller studies.
There's another question. Thank you, Dr. Monet. In this condition, is there a role for RVAD?
RVAD is the right ventricular assist device, right?
Yes.
Yeah. Definitely not. I think it's not a good indication. As you have seen, it's not all the patients that have this right ventricular failure, first. And second, it might impair hemodynamics, but I have never seen a patient with a refractory shock due to this right ventricular failure, first. And second, the invasiveness of these devices in this very sick patient, I think, makes that it's not a good indication.
Any other questions from the audience? Thank you very much, Dr. Monet. Really appreciate it.
Thank you very much. Thank you.
I think we are a little bit ahead of time, but I think we'll move on and take our break a little earlier. Is that okay? All right. So next, we have another brilliant mind in our midst, Dr. Alex Choi. Dr. Alex Choi is an associate professor and vice chair and Director of the Neurocritical Care at the University of Texas Health Science Center in Houston. He's also part of the editorial board of the Journal of Neurocritical Care. Dr. Choi has done extensive research on the subject of microbiota and microbial dysbiosis for pathologies in neurocritical care setting. Today, he will talk about the microbiome in neurocritical care. I'm really looking forward to this talk. Please welcome Dr. Alex Choi.
Okay, so it's Saturday morning. Thank you for finishing all the earlier talks early. That's incredible, right? I mean, gosh, have you guys been outside? My goodness. Let me tell you, it's a beautiful day outside in Houston. My kids last night, and I'll show you pictures of my kids, wanted to know, Daddy, why can't you go to the park with me this morning? And I told them, well, I'm giving this talk, and they're like, well, why don't you give me this talk? They really wanted to know what I was talking about. So I was like, okay, why not? I sat them down, I gave them this talk, and they thought it was hilarious that I was talking about poop. They were like, oh, giggling. They gave me some tips, so hopefully you guys enjoy my talk as much as they did. My name's Alex Choi, and I am associate professor. I'm director of neurocritical care across the street at Herman, and I am the vice chair of the Department of Neurosurgery for Critical Care. I'll be talking about the microbiome. These are my research disclosures. I'm here this morning to ask you a question. And the question is, who are you? You might have, heard this before, right? It's kind of cliche, but who are you? Who am I? Who are we? Same question, right? Well, if I ask you, who are you, this morning, you're going to say, well, I'm human, right? That's like the basics of who we are. And I think I'm human. I think I'm made of human cells. I think I'm made of human DNA. But I'm here to tell you, you're probably wrong. I know, right? You're wrong. Because in actuality, there are more bacteria in your body right now than there are human cells. In fact, there's 10 to 100 trillion microbes in the human body, which is 10 times the number of human cells in your body. So you're more germs than you are human. When you're looking at the genes encoding the bacteria outnumber the human genes by more than 100 times. It's crazy when you think about it. Absolutely nuts. And, it's okay that you're mostly germs because most of the time in the healthy environment, we live in symbiosis, just like the pictures here, the butterfly and the flower and the shark and the pilot fish here. My kids like that because they play that shark game where they go around and they eat all the little fish, yeah. So we live in symbiosis. So we eat food, right? Like this morning you're eating. You give nutrients to your body, but in actuality, you're just feeding the bacteria in your gut. The bacteria is digesting the things that you can't digest, and then you absorb the nutrients that the bacteria help digest for you. They digest some of the things that we can't digest, and they also make vitamins, and they make amino acids. We'll talk about some of those amino acids and the short-chain fatty acids. They also are your friends. So what they do is they outcompete some of the bad bacteria. There are bad bacteria out there, and we meet them in the ICU. But a lot of these bad bacteria are outcompeted. The good bacteria don't let the bad bacteria grow. They also help create a barrier from the outside world, the lumen, and the inside world, your own cells. So, you guys remember the whole human biome, the human genome project? You remember all that, and all the code, all the genes for the humans, and we all know all that. It took a little longer for the microbiome kind of, DNA to be understood because there's so much more of it. But we have now technology. We use the 16S RNA encoding gene for the bacteria that we can use, but now we just do shotgun genome studies. So we know all of these all the genes in the microbiome. And because of that, in the last 10 to 20 years, I would say, the field has completely exploded. Pun intended. Completely exploded. So there's now, if you look at the PubMed, there's thousands and tens of thousands of studies in microbiome. So I'm not going to be able to review all of that for you, obviously. I'm just going to focus on the neuro aspect, the neurocritical care aspect of what the microbiome and the brain, how they're connected. The two bacteria groups that are the most common are the Bacteroides and the Firmicutes, and they make up over 95% of your normal gut microbiome. And generally, we live in symbiosis, like we talked about before. But when there's disbalance, or what we call dysbiosis, this dysbiosis can cause disease. At first, scientists and clinicians thought, okay, we'll look at the gut diseases, right? Makes sense. Poop, gut, irritable bowel, inflammatory bowel. So we saw that there is dysbiosis in those diseases, which are often obvious. But the further we looked, we found, in fact, there's also dysbiosis in other neurologic diseases, including stroke, neurodegenerative diseases like Alzheimer's. It's just absolutely wild. In fact, there's studies that show that even small AVMs, cavernous malformations, we call them, can be caused because of problems with maternal dysbiosis. So when you look in the common media, and you look on Google, and you talk about microbiome and human disease, you'll see all these things that affect the microbiome and cause dysbiosis. Some of them are good, some of them are bad. Stress causes dysbiosis. Exercise is good, the environment. They talk about even, what type of birth you had and what you eat, if you have pets, what medication you take. But in the critical care setting, in the neurocritical care setting, these things are amplified many, many-fold. We're not talking about just stress like, oh, I'm so stressed today. We're talking about the stress of cardiac arrest. We're talking about stress of a traumatic brain injury. Medications, we're talking about really strong antibiotics, like vancomycin, that absolutely kills a lot of the bacteria, not just in your body, but also in your gut. Forget exercise. I know there's this whole exercise thing, but really most of our patients are on propofol and they're paralyzed. The environment is completely different. This is a picture of I think the cleanest ICU I've ever seen. Look how beautiful that ICU is. Our ICU, it doesn't look like that. Diet. Oh, diet. Come on. They don't have diets. They have this. These pouches of nutrients that we call them that we feed our patients, and pets and things like that. We're talking about nurses, respiratory therapists, and other patients. So you can imagine that the stress in the microbiome is far beyond what we normally think about when we talk about the human microbiome interaction. So this is a busy slide, and I'm going to break it down for you. But basically, this summarizes how I believe that the brain and the microbiome in the neurocritical care setting are connected. So I'll focus on the left side of the slide first. When you have a brain injury, when you have a traumatic brain injury or stroke or anything like that, there's an intense change in your autonomic nervous system. Now, you all know what that is, the fight or flight, rest and digest. What happens is your body gets revved up. Your sympathetics are out of control. And the parasympathetics, correspondingly, are decreased. There's adrenaline and norepinephrine, the stress response, and we've shown that this stress response is associated with increased systemic inflammation. When you have increase in sympathetic adrenaline response, it damages the gut-blood barrier. So this is some data from Dr. Louise McCulloch's lab showing on the left a normal lumen and gut endothelial lining, you see, and there's goblet cells that produce mucus. Kind of gross, but this mucus is really important. It actually allows nutrients to be absorbed and leaves out all the nasty stuff, all the bad bacteria, all the toxins, keeps it out in the lumen, the outside of our body. However, when you have increased sympathetics, the mucus layer dissolves, the goblet cell numbers decreases, and that barrier function is no longer effective. In our lab, we showed that a molecule called citrulline, which is a really important molecule in these cells, are decreased after severe TBI compared to controls, again suggesting that this barrier function is not working properly in severe brain injury. So you can imagine now that barrier that protects you, kind of like your skin on the inside, isn't there. So everything that's going into your gut or that's living in your gut can can freely go into your body. On top of that, and those of you who are ICU, work in the ICU know that this is a common picture, right? The nurses you're rounding, and one of the things that you're supposed to ask about is bowel movements. And then you're like, oh my goodness, this person hasn't had a bowel movement in 4 days or 5 days, right? Imagine that. I can tell you, from my perspective, 4 days of no bowel movement made me very unhappy. These people, like, this is their chest x-ray, their abdominal x-ray. Of course they're going to feel sick. Not only because of discomfort, but also now you have a belly full of microbiome, right? Bacteria. There's no barrier, and it's just sitting there. It's not moving. So of course it only has one place to go, and that's into your body. By the way, in the neurocritical care, obviously you have to make sure they're not obstructed, but we use neostigmine to treat this ileus. So the bacteria that are in your body can sense, hey, there's something going on, right? So we were doing great. You were eating, you were healthy, you were exercising. We were getting the nutrients we needed, living in symbiosis, and suddenly there's something wrong with you. What's wrong with you? How come you're not doing the things that you were doing? And the question is, do they sense that, and suddenly, do they start attacking the host? Just like in humans, if we're not treating our bacteria well, do they decide that they're going to attack the host? And a real famous, a real well-known researcher in this field is Dr. Alverdi. I listened to a talk that he gave probably in 2012 or so, and that's actually when I started thinking about this and thinking that this is really a field that's important for us intensivists to understand better. And he wrote this review paper. I'm going to quote it. Now, I don't like reading, but I will quote it because he puts it so well that I don't think I can say it any better than he did. He said, perhaps the microbiota sense that an ill host cannot feed itself and therefore will undergo a period of inanition, which will necessarily limit their access to nutrients. So the bacteria is like, hey, what's going on? We had a partnership. You're not holding up your part of the deal. If the host does survive, the hibernating microbiota will have properly invested in the host upon whom their survival may depend. So if they're like, okay, well, we've been with this guy for his whole life or her whole life, let's give him a chance, stick around, go into hibernation, maybe he'll get better. If, however, the host dies, the intestinal microbiota can feed off the decomposing body and jump to a new host as predators feed off the dead carcass. Kind of gruesome, but very true. So the bacteria have to make a decision, right? And they very well may decide that this host, he or she was okay for a while, but no longer any good. We're just going to eat the host and then wait for the next person to come by. So why are they thinking that? Why do the bacteria think that? Well, a few things. We talked about the interaction between the autonomic nervous system, but we, in the neurocritical care, also start attacking the microbiome. How do we do that? Well, we give them antibiotics. The first thing they do is get antibiotics, right? And, okay, I'm going to preface this by saying I'm not anti-antibiotics. If you have a pneumonia, if you're septic, you have to give antibiotics. I'm not saying you shouldn't. However, antibiotic stewardship and all that, but I do think that we have to rethink the way we use antibiotics just a little bit. So the healthy microbiome fends off the pathogenic bacteria, But the first thing they do when they come into hospital often, especially in the neurosurgical unit, is get antibiotics for the EVD or whatever it might be. We give them some antibiotics first thing. And what we don't really often think about is that the antibiotics that we're giving will select out for pathogenic bacteria. So, if you give an antibiotic that targets the anaerobes, it's been shown that it will select out for Enterococcus and Klebsiella. Oh my goodness, how many times have you seen Enterococcus and Klebsiella pneumonia in your ICUs, right? And it's a common thing. No wonder, this is something we do. If antibiotics will select out for VRE, we all know what that is, terrible bug. And some studies have shown, and this is controversial, some studies have shown that if you use antibiotics inappropriately, then the chances of them having sepsis later on increases because of the gut dysbiosis. And these are some examples. So vancomycin will reduce the number of intestinal bacteroides you see, and those are good bacteria. Metronidazole, flagyl, increases Enterococcus. Fluoroquinolines increase Proteobacter. Regardless, the antibiotics that we give decrease the variety, the abundance of the bacteria that we have in our gut. And we've shown time and time again that the variety of the abundance of bacteria, if you decrease it, it will decrease your good outcomes. It will worsen outcomes. So the antibiotics in general kill the good bacteria and leads to the growth of bad bacteria. So now that I've talked about, I'm going to summarize how the brain and the microbiome are connected. So when you have a brain injury, there's an increase in the autonomic nervous system imbalance. There's an increase in gut permeability, and the microbiome turns into what's called a pathobiome and starts attacking the host. Then we give antibiotics to select out bad bacteria. And then in a situation where there's no barrier, so the gut and the blood are connected without a barrier. So how about the other side? How is the microbiome going to affect the brain? Well, I have some good news for clinicians and the ICU folk. There are models now of stroke and TBI that show if you give a mouse a stroke or a TBI, you can follow the bacteria in their gut will go to their liver, will go to their lung and cause pneumonia. Now, why do I say that's good news? You guys know why I say that's good news? It's because for years and years and years, we have been blamed for nosocomial infection. Right? It's because you didn't wash your hands. Right? It's because you didn't head of the bed up and you didn't wash the mouth so well. And it's been our fault. Right? Well, maybe some of it is still our fault. However, there's increasing evidence that possibly the patients are bringing in some of these bacteria themselves in their gut, and then they're getting selected out, going through the porous membrane and causing infections in the body. So bacterial translocation. So that's part. The other part is the good bacteria make short-chain fatty acids. And we'll talk about some of these short-chain fatty acids, but they're very, very important for the human body. Without them, we don't function well. They have immunomodulatory roles, and they also protect the blood-brain barrier. And the question of does bacterial dissemination, so if there's translocation into the blood, does that actually cause brain problems? Interesting, right? I mean, I'm a neurointensivist, I'm also a neurologist, so I get consulted for septic encephalopathy all the time, and I say, septic encephalopathy, just treat the UTI in, 92-year-old, patient. Treat that UTI and they'll get better. Well, there's a really controversial study that was published in 2018 showing that in post-mortem patients, when they looked at gut microbiome and they looked at the brain, they found some of the same bacterial DNA. The question is it possible that the bacteria that translocate or that people are bacteremic from or septic, obviously they can see it and get pneumonia, but meningitis, but if they don't get meningitis, is it possible that this septic encephalopathy is that there's small amounts of bacteria that are actually getting into the brain, causing septic encephalopathy and other diseases? And people are looking at this for neurodegenerative diseases. Fascinating topic to follow. I will say that the confirmatory studies need to occur and it's not completely clear if this is true because of contamination issues. However, very interesting to think about. Short-chain fatty acids. People talk about, you can hear about this all the time in the media. They are made by the good bacteria that are in your gut, butyrate, propionate, acetate, and they help stabilize the epithelial barrier. They help make the mucus layers. They modulate cytokine secretions. Before, clinicians didn't really think about the cytokines. Now everyone's like, oh, cytokine storm, right? Cytokine storm, that's like COVID, right? Well, it happens in other diseases. It's been happening forever, even before COVID. And the short-chain fatty acids have been shown to decrease that cytokine storm. Short-chain fatty acids, and I'll show you in a slide later, have been important for blood-brain barrier development. So I've been talking about the gut-blood barrier, but there's also the blood-brain barrier, which is really important. It keeps all the stuff in the blood that you don't want in your brain. So the short-chain fatty acids help develop that blood-brain barrier. It modulates the microglial activity. So microglial cells are the cells in the brain that cause inflammation. And butyrate has a lot of press because it is particularly protective in critical illness as well as neuro diseases. There's a study showing that the microbiome are important for blood-brain barrier development. So in animals, if they don't have a microbiome, they actually don't develop a normal blood-brain barrier, which is fascinating. I'd be remiss if I didn't talk about the liver, right? I think this morning we talked about the lungs and the kidneys, the lungs, and the heart. So I'm rounding it off. I'm going to talk about the brain, the gut, and the liver, right? So the liver is really important for brain functioning. You're like, that's kind of weird, but it is. And remember, the gut, all the blood goes straight to the liver. The liver cleans all the toxins. If you go into liver failure, if you have acute liver failure, then you have brain problems. These patients actually die from cerebral edema. I have an unfortunate patient in the ICU that just passed away 2 days ago, really sad case. She, after pregnancy, she had liver problems, she had cerebral edema, and her brain swelled, and she became brain dead. That just goes to show you how important the liver is to not only the normal things that we think about, but also brain physiology. So if your liver, gut dysbiosis, causes problems in the liver metabolism, and you can imagine that increases ammonia. That's one thing we think about because we measure it easily, but also all the endotoxins that the liver clears out, and those things have problems. That if you can't do that, then your brain will have problems. TMAO is probably one of the best studied metabolites. It's caused by bacteria in your gut that feed off red meat. So when you eat red meat, you have bacteria that grow that cause TMAO to be produced. TMAO causes your platelets to be sticky, and they stick together, and your blood is thicker, if you will, to put it in lay terms, and that causes the incidence of risks and heart attacks are higher in patients who have higher TMAO. There's only one study. I haven't spoken about any studies in their ICU in microbiome because there's only one. And this study is a pretty preliminary study. It's only 98 patients. A study done in China published not too long ago, and they showed that there is the diversity, the amount of bacteria that are in the gut decreases over time in the ICU. Interestingly, they found that this Enterobacter abundance was positively associated with modified ranking. Now, their methods weren't the best, but that's an interesting thing to think about. Imagine being able to look at your patient's poop, look at the bacteria content, and then be able to prognosticate how they're going to do later. That's just like something that I don't think that I thought would be possible in 10, 20 years ago. They found that there's increased, certain bacteria are increased during the first week, and again, that they were associated with, get this, 92% in the risk of 180-day mortality after adjustments. That's crazy. I mean, it's almost unbelievable. So when some things are almost unbelievable, I tend not to believe them, but it's interesting and thought-provoking regardless. So there's some problems with this study, some real problems. The real problems are problems that we're going to have with microbiome studies in the ICU. First, the diagnostic. There's too many different diagnoses, right? I mean, you can't lump people with ischemic stroke and hemorrhage and seizures and hypoxic ischemic encephalopathy together. I mean, they're completely different diagnoses, right? I get it. They're all living in the neuro ICU, but that doesn't mean that they have the same pathophysiologic processes that are occurring. They didn't talk about the antibiotics that they used, the pressors that they used, the feeding that they had, and it's observational, so it's very unclear. So this highlights some of the challenges. So I will tell you, I've been collecting stool samples in our neuro ICU for probably 4 or 5 years, and it is very challenging work. I mean, it is, like Dirty Jobs. You know that show, Dirty Jobs? This is like we should be on Dirty Jobs because, we have our wonderful nurses collect the samples, but we got to allocate them, we got to store them, and it's not pleasant. Besides that, just the science, the heterogeneity of the diseases that we're looking at are immense. The foods and culture, so there's no one good microbiome. Not one good microbiome exists because think about it. We all eat. Actually, in Houston, I mean, it truly is a melting pot. I mean, the number of people here and the different diversity and the food that we eat at home are probably all very, very different. So our microbiomes are probably very different. So you can imagine in the ICU that all kind of we tried to boil all that down into one good microbiome, one bad microbiome. It's not going to work. It's not going to be that simple. In the ICU, we do these things, antibiotics, pressors. And it's going to be hard for us to tease apart if the microbiome changes that we see are from the things that we do to our patients, or is it because of the disease process that is occurring. Challenges that we're going to have to address, challenges that we are addressing, but it's going to be some time before we have some definitive answers. If you're asking how quickly a microbiome changes, and studies have shown that one day you go to the steakhouse and you eat all the steak that you can eat, and you don't have any greens, and your microbiome will change. So keep that in mind. So you can imagine how quickly the microbiome changes in the ICU after the things that we do to patients and how severely ill they are. So more work has to be done. So we got to understand what is a healthy symbiotic. What is this healthy symbiotic relationship? If the host becomes sick with neurologic illnesses, how do the bacteria sense that? And can we modulate the autonomic nervous system? And is it the antibiotics that we're using? The dysbiosis and selection for virulent bacteria is an important topic to study. Imagine we can find a way of protecting the gut barrier. That would be really important, so research has to be in that. Short-chain fatty acids, obviously a very important topic that a lot of people talk about. And how do all these things increase neuroinflammation, and how does that lead to worse outcomes? So this is so much to tackle for us going forward. And people say, well, how about just antibiotics? Why don't we just use antibiotics? Well, we've done that in stroke, and it doesn't work. If you just use antibiotics preemptively in neuro patients, it's not helpful. And now we understand maybe why it's not helpful, because it's probably not killing off the bad bacteria, but in fact just selecting out for them. People are always asking, well, how do we treat it? I'm going to tell you, unlike some of the other the talks previous, I'm going to have absolutely no practical advice for you. So don't ask me about probiotics. I just don't know. I know there's a lot of discussion about it. There's a lot of studies, but I don't think we know. Fecal transplantation. Dr. Alvardi actually has done these studies, incredible. They can treat sepsis in a mouse through fecal transplantation without any antibiotics. Crazy. Saving an animal's life with fecal transplantation. In humans, maybe not. We don't know yet. It's a very challenging clinical trial to do, if you can imagine. Well, it's being used for C. diff, we know that. And it's being tested for all these other diseases, but we don't, I am not aware, maybe someone else is, but I am not aware of a fecal transplantation study being done for acute brain injury patients. Again, maybe probiotic, maybe short-chain fatty acids, maybe. We just don't have enough data for it. I know there's studies looking in the general critical care population and with probiotics and nosocomial infections. I don't know how, when we reviewed the literature, it was not it was not convincing enough for us to change our practice. I don't know if you guys have. Again, we have to understand the modulation of the autonomic nervous system, maintaining the gut-blood barrier, promote maintenance of healthy bacteria, promote production of protective metabolites, protect against the pathologic bacterial spread, and maintain the blood-brain barrier. I think these are the targets for our research endeavors in the future. So this is our group. Of course, I live across the street here. This is my lab members. These are pictures of my group here. On the left top, that's the little boy with the trees on it. That's my boy Kevin. And in the back, way back, you can barely see her. That's my girl Julia. Julia is in 8th grade. So I gave this talk to her last night, like I said. I said, how'd I do, Julia? How'd I do? She's like, Dad, it was okay. She liked the poop thing. She's like, she gave me feedback, and I was like, thank you. She said, you did better than the 7th graders. She's been prepping, she's in 8th grade, and the kids, the 7th grade kids, right? She's in 8th grade. She's like, yeah, you did better than the 7th graders. You'll be fine. So I said, thank you, Julia. Anyway, thank you for your attention. I appreciate it.
That was very excellent and brilliant. Really appreciate it. We have a couple of questions from the audience. I'll go with the first one. Does early enteral nutrition have an effect on dysbiosis?
Oh, good question. Oh boy. So I said I'm not going to have any practical recommendations, but I will say it probably will, probably does. Now, the issue with the enteral, feeding patients early, the studies so far have not really shown a benefit in outcome. So, I hesitate to say it probably does. Yes, the answer is yes. Will it impact on outcomes? I think the jury's out on that.
Thank you. In summary, is there positive impact of selective decontamination and or a probiotic formula to restore the microbiome, and has that been translated to the bedside?
Yeah, again, when I talk about this, everybody wants to know about microbiome, and so I always say, I don't know. But I think in the future, I think especially, in the critical care literature, there seems to be more evidence for probiotic use. I would say in the neurocritical care population, there really is no evidence at all. I suspect that it may in the future, with well planned out experiments and clinical trials. I think there is a possibility that this is going to work. I do think we're still a ways away, and I also think that we don't quite understand the science well enough to say, oh, just give people probiotic. Now, the chances of probiotics hurting, I think, are not very likely. But I do think the jury's still out on that. Question?
Thank you, Dr. Troy. The question, I think the take-home message that, and if you can elaborate on this, that judicious utilization of antibiotics are important. And, the whole stewardship, so either starting antibiotic or stopping, is that fair enough to take away some message from your talk that antibiotics have consequences, whether you start it or stop it?
Yeah, I think that might be the take-home message, one of them. I think one is when you're using, everyone, intensivists, surgeons, and everybody, they're always afraid not to start the antibiotics, right? You're always afraid to oh my gosh, because we're actually conditioned for this. Sepsis alerts and time to antibiotic and things like that. So, and that carries forward to the patients that are not septic, and we feel like we have to use antibiotics all the time. I'm not saying not to use antibiotics, but when you use it, I think we should all think a little bit about all the ramifications, not just the cost for the pharmacists out there, not just the cost, but all the ramifications for your patients. Maybe that antibiotic is actually doing harm through modulation of your microbiome. So just think about it. I think that's all I can say. Mm-hmm.
I have one question. How long after you stop the antibiotic does the pathobiome return back to your your normal gut
Yeah,
flora?
hard to say. I would say that once you start antibiotics, or once you're critically ill, let's say, because again, we're not sure how much of the changes in the gut microbiome in the critical care unit are from the disease itself or because of the things that we're doing to them. These changes can last very, very long. If you think about it, though, our patients aren't up and doing normal things the next day. No, they're still in the hospital. From the bacteria's perspective, the host is still compromised. They're still not sold that this, you're going to survive. So, you're here, you're going to go to rehab. These places, you're not eating your normal food. So, for you to restore that your own microbiome, presumably a healthy one, it's going to take a long time. The chronic inflammation from a systemic perspective for patients after brain injury, stroke, and TBI lasts for months and months and months. So I can only imagine that the microbiome changes are also going to last a very long time. How long, no one knows.
Thank you very much, Dr. Choi. So we're a little bit ahead of time, and this concludes our early morning session. We'll take a break for 30 minutes. So if you can be back at 10:30, please go ahead and get some refreshments, fill up on your coffee. Please visit the exhibitors. And we have about 25 abstracts that are on display. Please visit the abstracts. I think there'll be some presenters there, and you can ask them questions. And I'll see you back at 10:30 Central Standard Time. Thank you. I hope you're feeling refreshed and ready to dive into the next session. We have a bunch of exciting speakers with fascinating topics. But next, we are honored to have a true legend in our field, Dr. K. Guntupalli, a former president of the American College of Chest Physicians, a Master Fellow of Chest, and the recipient of the highest civilian award from the President of India. She has held leadership positions in the Society of Critical Care Medicine, serving as a member of the Critical Care Board, as well as the American Board of Internal Medicine. She's a trailblazer whose accomplishments are a great source of inspiration for many in our field, including me personally. Dr. Guntupalli is an endowed professor in pulmonary critical care and sleep medicine at the Baylor College of Medicine. She has served on the faculty of Pittsburgh and Emory Universities. Her research interests include acute respiratory distress syndrome and medical education. She's the recipient of several grants and has authored over 150 scientific publications. Please welcome Dr. K. Guntupalli.
Thank you so much. I hope you can see me. I'm very vertically challenged, so. Thank you for that very nice introduction. And it's so nice to be back here, and I feel like I'm not clothed fully because I don't have my mask. It's been 2 years wearing this mask. Even now, we are asked to wear when we go to the hospital. And I worked at Methodist, and I was chief of pulmonary critical care here for a long time, almost I think until Baylor took on St. Luke's as their primary affiliate. So I feel like I was here for 20 years. So I feel like this is coming home. New buildings, and a lot of colleagues from Baylor are here as well. So thank you, Faisal, for inviting me. And it's wonderful to have, I forgot how to give a live talk. And I forgot what it is to have an audience that give you energy, you know, when you talk. It's been 2 years. I was tempted to do it on Zoom. Then I said, you know, let me see what it is. Maybe I forgot how to speak to a live audience. My topic is an approach to a critically ill pregnant patient. I will tell you, I've been doing the critical care for like 40 years, but still your heart rate goes up a little bit. Every intensivist, every nurse, when you get this consult or you get this page from a OB-ICU, or you hear overhead that some stat page from OB-ICU, your heart rate will go up. You may be doing it every day, day in and day out, because you know there are 2 lives at stake. There's a lot of young women who are sick. I don't have any disclosures for this presentation, no conflict of interest. So I would like to address this topic by addressing 3 questions. First one is, who is in an OB-ICU bed, globally and locally? What is the approach to a critically ill pregnant patient? And I will discuss 5 conditions that require our attention. 2 of them, the first one, hypertensive disorders, is the most common reason why an OB patient is in an ICU. Second one used to be uncommon, but because of COVID, we have seen a lot more. And 3, 4, and 5 are kind of uncommon, but I'm going to cover them because this is where our OB colleagues depend on us for our expertise. Because hypertensive disorders, they're very good at managing on the floors, and unless they come to the ICU, that's when we get involved. Even then, the MFMs have great expertise. So where they want us to be experts, we need to be really cognizant of those. I just wanted to draw your attention to an op-ed that was written a few years ago about abysmal maternal health statistics. And what they observed is that there's an increased mortality from 12 per 100,000 live births in 1990 to 28 in 2013. While the rate was flat due to preeclampsia and hemorrhage, as you will see, that's the most common reason, but obesity and obesity-related causes like diabetes, hypertension, heart disease have significantly increased. And advanced maternal age, when they are getting pregnant, is also a contributing factors. Very frustrating is that death rate for African American women and uninsured women is 4 times that of their counterparts. There is also an increase in opioid usage from 1990s, and sadly, the state of Texas has one of the higher maternal mortality rates and uninsured status. This is the American College of OBGYN practice bulletin that talks about critical care pregnancy. This practice bulletin is the most downloaded from their association. It talks about 1 to 10 obstetric patients per 1,000 deliveries are admitted to ICU in USA. So if you have 3,000 deliveries, you can calculate how many admissions you have to the ICU. Majority of them are postpartum admissions, and most do not require life-saving interventions, but need intensive monitoring. So majority of them require very close monitoring, and the ICU length of stay, this is something we don't see in adult medical or surgical ICUs, is only 1 to 2 days, especially if they're postpartum, it may be 1 day. However, the mortality rate can be as high as 3.3 to 14%, depending on where the patient is situated. What is very interesting is, of the 5,500 ICUs in USA, only half offer OB services for various reasons, because of liability, lack of expertise, no MFM or whatever, while 1,500 offer neonatal ICU services. So this is something, a very niche practice, and you need to be familiar with an you see a patient sometimes. Globally, who is in the OB ICU bed? As we mentioned, majority, 3/4 of the patient are admitted because of obstetric disorders, and 1/4 are admitted because of medical disorders. Of the obstetric disorders, the 2 most common are hemorrhage and hypertensive disorders. Those are the 2 most common. So what about locally? I'm going to be using a lot of data from Bentop as well as Pavilion for Women, which is a Baylor-affiliated Texas Children's Hospital that was started in 2012 for only OB patients. So these are from PFW, 420 first 4 years. Now we have more than 1,000 patients. I haven't looked at those numbers yet, but I don't think it will be too different. So in obstetric causes in these patients locally, again, it pans out that OB hemorrhage, preeclampsia, and hypertension and hypertensive emergencies are the most common reason they are in the ICU. Of the medical causes, the three systems, pulmonary most common, hematologic or cardiac, and others are like DKA and renal, endocrine, maybe the other reasons patient is there. What kind of interventions these patients have? Most common, they have an arc line, central line. Mechanical ventilation is only like less than 20%. I would like to next share with you a 5-step approach to critical care in pregnancy. I know it's a kind of a busy slide. I hope you can read it. The first step when you get an admission is to ask, is this a medical or is this an obstetric disorder? Why do you need to make this distinction? Because a lot of them may mimic OB and medical conditions, but the treatment is usually very different. And specific treatments may be available for some disorders, and the drugs of choice may be different, and delivery may halt progression of most OB disorders, but very few medical disorders. The second question to ask is there failure of multiple organ systems? If there is, you want to know how to support a failing organ and also how to support the fetus. The third question you want to ask, is there a risk to the mother and the fetus if the pregnancy is continued? So you want to make sure that the maternal outcomes are better if you continue or discontinue the pregnancy. If delivery needs to be hastened, should it be a C-section or vaginal delivery? What kind of anesthesia are you going to use? Again, this is very much a multidisciplinary decision. Then, if you decide to deliver the patient, what needs to be done to optimize the patient? So you need to have timely achievement of targets such as hemodynamics, oxygenation, and so on. Most important is a teamwork. I cannot emphasize more than any other specialty, you want to work with the bedside nurse, respiratory care practitioner, pharmacist, obstetrician, intensivist, anesthesiologist, and neonatologist. In fact, in most good OB ICUs, all ICUs I would say, they would have what they call a board rounds twice a day. So everybody gets together and goes over the board or the patients that are there, what to anticipate. So that's the way to prevent or anticipate any problems. I will tell you, any day I will listen to a bedside OB nurse than my fellow, because they have seen it, they're so confident. You will never see any OB nurse more than a patient advocate, any other nurse. There's so much of patient advocates, they're working with the patients, and you have to listen to them. One of the important things is the airway problems in these patients, because they have increased airway edema due to various reasons. And this is a picture of an eclampsia patient who bit her tongue. This is not uncommon at all. It is estimated that failed intubation occurs in 1 in 224 attempts, which is 8 times that of a general population. So you need to have a failed intubation in place. There is OB anesthesiologist organization that has an algorithm how to approach in difficult intubations. And as you know, majority of these cases are occurring during emergencies when it is suboptimal conditions and after hours. We had a recent case where in the middle of the night, 2 very senior anesthesiologists had difficulty getting an airway in, and critical care had to go in with fiber optic and help secure the airway. So don't give the respect to the intubation of a pregnant patient. Don't ever underestimate the difficulty. And these are some of the medical conditions, the obstetric conditions that may look alike. For example, viral hepatitis or HELP or acute fatty liver of pregnancy, thrombocytopenia, ITP versus HELP, seizures, epilepsy, central venous thrombosis versus eclampsia, and lung, I remember, we are all become specialists, super specialists. If I'm in a sleep clinic, I don't even carry my stethoscope. If it's a cardiologist, he only listens to the center of the chest. If it's a pulmonologist, he'll only listen to the lungs. If you are, I don't want to name any specialties, certain specialties, somebody's listening on one side to inspiration, the other guy's listening to expiration on the other side. So we are so specialized, so we don't even think. I remember a patient, who was being treated as pneumonia, transferred from an outside hospital, young lady with bilateral diffuse infiltrates who happened to have a mitral stenosis, severe stenosis that was never diagnosed. Remember that these patients are young and they may not see the doctor even, as healthcare professionals, we don't see our doctors regularly. We neglect ourselves so much. So these are young patients. Pregnancy is considered normal, so they don't see. So I recall this patient until you really listen to the heart, got an echo. You would have missed why the patient was having pulmonary edema, not pneumonia. So I would like to focus on 5 conditions I said. This is the most common problem you will see is hypertensive disorder of pregnancy. There are 4 types of hypertensive disorders which will go into what are the diagnostic criteria, what medications can you use, and what are the complications. This is a 17-year-old primigravida who woke up at 1 a.m. with headache, vomited, seized, has good prenatal care, has blood pressure 196 over 112 on admission, non-focal neuro exam, platelets are 110, which is low, urinalysis 3+ protein, high liver enzymes. So this patient had a CT scan that shows vasogenic edema in the deep white matter, and the diagnosis on this patient is eclampsia with HELP syndrome, and there was an emergent cesarean section done under general anesthesia. So this is a hypertension in pregnancy is the most common medical problem complicating pregnancy. The way to diagnose is blood pressure more than 140 over 90, 4 hours apart. And hypertensive crisis, because you want to treat them immediately, not wait 4 hours. If the blood pressure is more than 160 systolic, diastolic more than 110, lasting 15 minutes, that's an emergency or crisis. So you need to act immediately. And I think in malpractice suits, they're always looking for this 160 number. So, like lawyers, they're looking for this 160 number. Worldwide, 10 to 15% of maternal deaths are attributed to preeclampsia, eclampsia. So the first disorder, hypertension, is just called gestational hypertension, where you have blood pressure of greater than 140/90 on 2 separate occasions. Very important for all these hypertensive disorders is to say that this occurs more than 20 weeks of gestation. So all these disorders occur more than 20 weeks of gestation. There's no associated proteinuria or end organ dysfunction, and gestational hypertension is actually diagnosed retrospectively when the blood pressure returns to normal on the postpartum visit. So that is gestational hypertension. Second one is preeclampsia. Eclampsia is new onset of hypertension plus proteinuria and or end organ failure or both after 20 weeks of gestation in a previously normotensive woman. The HELP syndrome, I'm sure you're familiar with, is a severe form of preeclampsia, but it can also occur independently. About a fifth of HELP patients do not have hypertension or proteinuria. Eclampsia is same as above, except they have a grand mal seizures with no other cause. So our case that I presented had eclampsia plus HELP. What is chronic hypertension? Chronic hypertension is, as I mentioned, now the maternal age is older. Patients are older when they get pregnant, so they may have predating hypertension, predating pregnancy. Again, hypertension is less than 20 weeks. So in the first visit, maybe they're already hypertensive or on medications. And hypertension does not resolve postpartum. So the fourth is hypertensive syndrome is preeclampsia superimposed on chronic hypertension. See, a lot of times you're seeing them first time when they come for delivery. Then if you see patient is hypertensive before the pregnancy and now also has proteinuria, then you have hypertension plus preeclampsia that's superimposed. Why is this such a big deal, this hypertensive? It's not only the most common reason why the patient is in an ICU, but also associated with higher maternal morbidity and perinatal morbidity and mortality. So acute renal failure, pulmonary edema, placental abruption, DIC, liver failure and subcapsular hemorrhage and maternal death, and of course consequences for the fetus and the child. How do we diagnose this? This is 5 objectives of management. First one is you want to control hypertension, either with PO or IV infusion. And our MFM colleagues and obstetricians are excellent at managing them on the floors. So they can use oral nifedipine, oral or IV labetalol, IV hydralazine, and the times we see them is when they are on IV nicardipine or they are in the ICU, and we can use IV nicardipine, and a lot of times they need an outline for that. Number 2 is prevent seizures with magnesium sulfate. This is very common in the OB practice. 3, if they already have seizures, you give like any other, like lorazepam, monitor the fetus, and very importantly, make delivery decisions, multidisciplinary discussions. So to prevent or control seizures, we use max sulfate at pretty high doses, and you have to measure the serum levels, and you can see that as the serum magnesium levels increases, clinically the nurses are monitoring deep tendon reflexes, hypotension, and various other parameters clinically. But if the levels are high, you have prolonged PR, widened QRS, and I have over the years, in these years, many years ago, I've seen a patient have cardiac arrest because of very high MAG level. So important to give calcium chloride in these patients, or if there's a cardiac arrest, give that empirically if the patient was on magnesium. So number 5 is make delivery decisions, and there are certain conditions that get better when you deliver the baby. And these are severe preeclampsia with organ failure, eclampsia like our patient, acute fatty liver of pregnancy, HELP syndrome, placental abruption, status epilepticus, and cardiac arrest greater than 24 weeks. So these are the 4 patients with hypertension. First one is a 29-year-old young primey, high blood pressure, pre-pregnancy normal blood pressure, yes for proteinuria, low platelets. So this patient has pre-eclampsia. Second patient was a hypertensive before she got pregnant, a little older lady, high blood pressure, and patient also has platelets that are low and proteinuria. So this is chronic hypertension plus pre-eclampsia. Third person had hypertension before, now is hypertensive during pregnancy, no other end organ involvement, no proteinuria. This is just a chronic hypertensive who got pregnant. And finally, gestational hypertension, pre-pregnancy normal blood pressure, during pregnancy hypertension, patient returns to normal postpartum, that's gestational hypertension. Some of the caveats are if the hypertension occurs less than 20 weeks, other than just chronic hypertension, think of molar pregnancy, very important, think of molar pregnancy. If there's sudden hypertension, these preeclampsia or HELP patients, think of liver rupture. I have seen one patient. It may not be, some of these are rare examples, but I just want you to be aware so you don't miss it because you don't want to miss these complications. Think of liver rupture. And reassessment at 12 weeks postpartum necessary for gestational hypertension. And one of the implications is if the patient had gestational hypertension, they have hypertension and cardiovascular disease, most of them later in life. Moving on to acute respiratory failure in pregnancy, causes are ARDS, aspiration, venous air embolism. Some of these are unique to pregnancy, like the ones that are starred here, beta adrenergic or tocolytic therapy, asthma, most common respiratory condition during pregnancy, pulmonary condition, thromboembolism, pneumomediastinum, even just Valsalva can cause that, pulmonary edema, and ovarian hyperstimulation syndrome. These are the causes of ARDS, unique to pregnancy, and these are not so unique to pregnancy. Pneumonia, urosepsis, H1N1, influenza, and varicella. If a pregnant patient gets a chicken pox, they are more susceptible to get pulmonary complications and morbidity, mortality is higher. COVID, 12 to 15% have incidence of ARDS, so we have seen a number of patients, and all others you're quite familiar with. I want to present this case during H1N1 epidemic a few years ago of a 26-year-old lady with 32-week pregnant, referred from outside hospital, not received her flu vaccination, fever, tachycardia, room air saturation 80%. She was given antibiotics, and you can see that this is ARDS, influenza ARDS, 4-quadrant infiltrate. Very promptly she required intubation upon transfer. She required sedation, neuromuscular blockade, and she was on 80% oxygen, PEEP of 18, and she was delivered by cesarean section. So how do we manage these patients? We have to do low volume lung protective ventilation, sedation and paralysis not contraindicated. Important is to aim for pregnancy-specific hypocapnia and blood gases. These are the normal blood gases in a pregnant woman. Pregnant woman has a PCO2s that are low and mild respiratory alkalosis, and the PO2 in the pregnant woman is higher, 105. So you want to aim for a PCO2 of 28 to 32. Permissive hypercapnia, if your pressures are high, and probably okay up to 60, but watch your pH. And normally in ARDS, in ARDSNet protocol, we use a saturation as low as 88%, but here you need to modify it to pregnancy to have a higher saturation. And we also talk about having a P-plat of less than 30 in ARDS patients, which you may not be able to achieve because of the gravid uterus. And sometimes you may use an esophageal balloon, but not common. So this particular lady had all complications, not at all different than any other chronic ARDS patient that you've treated. She had hyperlipidemia from propofol, triglycerides of 560, which caused pancreatitis temporarily, had upper extremity catheter related to DVT, delirium, needed tracheostomy, slow improvement, pneumothorax with a chest tube, and 30 days on mechanical ventilation, severely deconditioned, and went to LTAC for rehabilitation. So nothing very different for you, that you haven't seen. This is on day 10. You already see that patient has a tracheostomy, and you see these are subpleural cysts, which are signs of chronic ARDS and barotrauma. So I don't mean for you to read this, but this is just a suggested ARDS algorithm. In pregnancy, I'll be happy to provide this, but nothing that you don't know. It's not too different than non-pregnant patients. In summary, ARDS treatment in pregnancies, high flow oxygen is a good option. Non-invasive ventilation can be useful. Prone position is possible. Low tidal volume, watch PCO2. Don't drown patients, which is giving a lot of fluids, which we use the same in non-pregnant patients. Treat the cause, deliver the baby. ECMO is an option if it is available. In some of the older ANZIC trials, ECMO trials, there were 9 patients, and 6 out of the 9 survived during the H1N1 epidemic. And ECMO in COVID, of course, I'm sure you have experience here, and we have as well. At Baylor Hospital, we had several hundred patients that were hospitalized with COVID. Many of them are true unrelated. They're just, exposed in the community, and they had COVID but were not even on oxygen, just happened to be COVID positive. But in ICU, I haven't looked at all of the numbers. We probably have more than 100 patients, but the first 67, of course, at Bentab, most were Hispanic patients. 50% in both pavilions had BMI greater than 30. That was an important risk factor. More than half of the patients who were in the ICU presented with severe or critical COVID-19 disease. 17 intubated patients. I think I'll have more when I look at all of the patients, and 9 underwent ECMO. Vaccination status, remember the vaccination wasn't approved until the middle of this for pregnant patients. 91% were not vaccinated. Severity in the ICU patients was moderate to severe, which became worse during ICU stay. Average length of stay, normally, remember I said 1 to 2 days in an OB ICU. Here you see 8.5 days hospital length of stays, although these are younger patients, with COVID. And these are the numbers for ARDS. In fact, it's even higher for COVID ARDS. And this is a publication in Baylor St. Luke's that looked at PFW and St. Luke's. Both of them, 9 patients with COVID had ECMO, and 2 out of the 9 were still pregnant when they did the ECMO, and later on they got better and delivered the baby, and others were peripartum. And they had severe ARDS with mean PF ratio of 62. This is really very severe ARDS. And 6 out of the 9 were prone prior to ECMO. So these are the patients who were prone. Actually, even on the floors, we are just calling soft proning because nobody actually collected a lot of data, but a lot of patients were encouraged to prone even on the floors. But in the ICU, many of them, especially on ventilators, were sedated, paralyzed, and prone because they had very severe ARDS. What was the therapies in the ICU? High flow oxygen, CPAP, mechanical ventilation, and 3% incidence of pneumothorax, which is not too different in non-pregnant ARDS. There was a question initially when we were preparing for this pandemic that can you actually prone these patients who are pregnant? And so this was a publication. It has a very nice video and a how-to type of video with this. You can actually prone. We have prone in both pavilions. And this I don't mean for you to read, but this is a protocol for proning pregnant patients that takes into consideration various other issues. I want to move on to ovarian hyperstimulation syndrome. I don't know how many of you are familiar with it, but it is an iatrogenic complication occurring in the luteal phase of menstrual cycle because of ovarian hyperstimulation, because either you're trying to get the patient pregnant in assisted reproduction, or very uncommonly, it may be a donor. Maybe the woman is trying to donate her eggs for somebody who cannot have babies. So this is a 27-year-old female I saw many years ago who came in with abdominal distension, abdominal pain, right shoulder pain, shortness of breath, nausea, and vomiting. The patient was on HCG. She had 40 eggs removed. She was a donor. She wasn't trying to get pregnant. She was just a donor. Heart rate 150, massive ascites, vulvar edema. She needed paracentesis of 1.5 liters just to breathe. She was very thin, asthenic lady, but were very severely short of breath. Sodium is low, 127. BUN creatinine 19 over 1.6, which is very high for a pregnant, she's not pregnant, but somebody in that state. Hemoglobin hematocrit 18.356, white count 32. So this was considered hypovolemic hyponatremia. This is quite classic in these patients. There's cystic enlargement of the ovaries. There's fluid shifts from intravascular to third space and increased capillary permeability. Hemoconcentration, electrolyte abnormalities, and thromboembolic sequelae. There's mild, moderate, severe. Mild is abdominal distension, all of these with enlarged ovaries. Moderate is this plus ascites. Severe is other organs such as hydrothorax and viscosity issues, hemoconcentration, and renal involvement. This is how the ovaries look like, huge, massive, weigh a lot. All of these are cysts. And you can see that there's something called a necklace sign, which is very classic, where you have an ultrasound, you have more than 10 cysts in a single plane ultrasound. These are all because of the stimulation, so this is pretty classic. So risk factors are young age, thin patient, very asthenic habitus, polycystic ovary. Most of them are trying to pregnant, so they already got pregnant with all these cysts that are there. So that can be, and there's more hormone production. And the clinical features are, most of them will have shortness of breath and ascites in severe disease. Moving on to, and I will tell you the reason I'm mentioning that is I remember I was rounding at some other place and the woman was brought in with severe shortness of breath to the ICU, a very young lady, and they're giving oxygen and all this, and they're talking about pneumonia, and this woman says, hey, I'm on hormones to get pregnant, and she's telling them. And this was several years ago, and the intensivist was not familiar with it. So when they get admitted to you and you don't know, this is an entity, you need to know, number one. OBGYN and assisted reproduction people, they know it, but they may not be involved, or you may not have that expertise in your hospital. They may come from somewhere else. Okay, moving on to brain death and somatic support and resuscitation in pregnancy. There's something called MUSE, or maternal early warning criteria. These are the criteria, just like your sepsis criteria or whatever, that are gathered by the bedside clinician who escalates it to the next level if they meet certain criteria. Very, very important. All OB units use it. Again, I don't mean for you to see it. If a patient has a cardiac arrest, important things I have highlighted here: place IV above the diaphragm because of the uterus, IVC may be compressed. And if the patient is on magnesium, stop it and give calcium gluconate. And this part is not, we are not used to it. Have the MFM there and provide continuous uterine displacement, very important. One person should be doing that continuously. prepare for perimortem cesarean delivery. If no return of spontaneous circulation in 5 minutes, consider immediate perimortem cesarean delivery. In pregnancy, difficulty airways. Common energy requirements for shocking is no different, but these are the potential etiology of maternal cardiac arrest. Anesthetic complications, bleeding, cardiovascular, drugs, embolic, fever, general other causes. Remember your H's and T's may happen, and hypertension, very, very important. So we talked about MUSE. We always have maternal rapid response team drills and every often arrest simulations. And this is how you do a displacement, and somebody should be doing continuously. Why is it important? Because there's a clear benefit to the mother that up to 60% of patients will have return of spontaneous circulation after you deliver the fetus. Talking about somatic support, it's a non-neurological care provided after brain death of the mother for fetal survival and growth. And there are some ethical issues. Longest reported is 107 days, but I just saw one with 120 with more than this. There are 2 accepted conditions where you declare a patient brain dead and you still want to support instead of withdrawing. Legally, patient is dead if you say brain dead. One is pregnancy with a viable fetus, and second is organ donor. If the woman, if you can get them to 32 weeks, 98% survival of the fetus. Some of the problems in supporting is that you have endocrine, like any other brain dead patient, endocrine problems like pan-hypopit, central diabetes insipidus, hypothyroidism, hypoadrenalism, and cardiovascular, you have a lot of time problem maintaining because of hypotension. And remember where the blood gases should be. So these are just some of the cases I thought I'll share with you. Most common cause of brain death in a pregnant woman is intracranial hemorrhage. Intracranial hemorrhage. So this is a baby grandmother is holding. This mother was kept alive for I think 107 days or 7 weeks, and she was brain dead because of subarachnoid hemorrhage. A lot of times the baby is the only thing that the husband or the parents are hanging on to. This is a more recent one from Brazil where 123 days, and there were twins, and they saw that they thought the twins will die after the mother had a brain death from subarachnoid hemorrhage, but looks like the twins were hanging on, and then they just supported, and after 123 days, the twins were delivered. And last condition I want to spend few minutes is called NMDA encephalitis. It is an autoimmune encephalitis, anti-N-methyl D-aspartate receptor encephalitis, a mouthful to pronounce. Why is it important? Because 2/3 of them are women. And more than 25%, sometimes up to 50% are associated with ovarian teratomas. And these don't have to be big. They can be microscopic, so you may not even see them. Importantly, they present with neuropsychiatric symptoms and refractory seizures and autonomic instability. I have seen patients where the patient was admitted to psych hospital for 2 weeks or 3 weeks prior to transferring because they were the very first patient that we missed for many years ago for a few weeks was a teacher, and the police was called because she was behaving inappropriately in the class. They thought she was on drugs. And she was, after 30 days, she walks out normal and, gorgeous looking lady. And, so you need to be aware of this condition. And this was our experience with, I think, the 7 patients that we had in the ICU. What are the challenges in providing care in the ICU? Unless you know, you're going to miss it, unless you know how to pick this up. These patients have dramatic, unusual movement disorders, uniquely characterize this disorder, including oral, lingual, facial, and limb dyskinesias. I remember one high school student who was admitted. He was so thin that he will have almost opisthotonus. I mean, we knew he had limbic encephalitis or this one, but I thought he had tetanus or something because I've never seen somebody posture like, and he fell off the bed. That's how he was. And they would have seizures that are so transient that by the time you grab your Ativan, they're kind of, already resolved. So they're kind of seizures and dysautonomia, hypotension, hypertension, they're on pressors, they're on all kinds of stuff, and hyperthermia. So very, very interesting. Unless you think of it, you're going to miss it. So does it happen in pregnancy? Yes, it can happen in pregnancy. And this is a clinical features of patients. For example, this was one series of 11 patients and 21 from the literature that was gathered. As you can imagine, young patients, encephalitis during pregnancy was here 21 and here 6 patients. Teratomas, look at this, 36% here and 48%, they were associated with teratomas. Clinical presentation, some of them already had diagnosis of encephalitis, they recovered, but they got pregnant, some of them first time diagnosis. Look at the psychotic symptoms, 100%, 81%. And this, no, I'm going the other way. Okay, this particular case report, I was just talking and say, do you see this because you're OB? And I said, oh, we don't see this or something like that. That's and then he called me a few weeks later. Guess what? We have a case. This lady was in the ICU, some other place, refractory seizures, 4th pregnancy, transferred to the hospital, and they diagnosed it, and now patient is ready for delivery. And the patient had cesarean delivery of the 4th pregnancy, and the husband said, I just want my wife back. I got, I'm going to have 4 kids. Just do whatever you need to do. So the patient had a oophorectomy because they couldn't really image the uterus, the ovaries because of the big uterus. They did oophorectomy, although she was only like 27 or something. But next day I got a call. Guess what? This lady's texting on a ventilator, post-delivery. So sometimes it can be, microscopic teratomas. So this is something I'm very fond of because I've seen 7, 8, 9 patients, and sometimes the younger neurologists may not even have seen the combination of this. So something you need to remember. And I just want to share with you, this is a lady, I have her permission to share, that was, had a delivery a few weeks before, was kind of depressed, and then, was having all these, we had diagnosed already by the time she was in the ICU. And this is, just look at the, remember that oral facial thing, she was doing this so much that when she was intubated, she would bite on the tube that I can't ventilate the patient. She would bite on the tube so hard. Then we ended up doing a trach, and she would do this so vigorously and so continuously that I thought she'll have a tracheoinnominate fistula or something because of the traction on the trachea. So she was on, when she had a teratoma that was removed, and she was actually recovered after prolonged illness, all kinds of complications of prolonged ventilator and all this, and this is her almost, brought her baby a few years later that we kind of honored her. So I think this is the kind of outcome you want for your pregnant patient, right? So I think I'm good with my time, and thank you for your attention.
Thank you so much, Dr. Kuntavali. Very relevant, and we learned a lot. Any questions from the audience? I guess I'll start off with my first question then. Proning in a pregnant woman. They already have this increased intra-abdominal pressures, and then when we prone them, do you need a special bed, or can it be done on a regular ICU bed?
Yeah, the publication that it has a very nice video. I didn't put all of them because of lack of time. It talks about, because remember in COVID, how overwhelmed we were with the number of patients. It's not just pregnant. We are like expanding ICUs and ICU teams, and we can't, there are proning beds, right? But they're very expensive. We don't even use them for, because there's not enough beds. In H1N1, we had not even enough beds to prone, even non-pregnant. So this one is just with pillows. And there are certain ones you can find, like, some foam things with a cut in the center. You don't even need them. These are all, it's very explicitly shown how you do it. And you just, only thing is like post-op, like cesarean section or something, most of them get delivered. The severe respiratory failure, unless their PO2 is like on the floor and you can't even do a surgery or something. But post-op, first 2 days, maybe because of incisional issues, they may hesitate, but otherwise you can do them just with pillows. You just have to support, because the breasts are big and the stomach is big, and you just want to make sure that you're not compressing the IVC even further.
Yeah. The reason I asked is because we have a lot of people here from the liver transplant unit, and we deal with a type of pregnancy called ascites, related to the. Thank you so much for answering that. And did anybody else have any there?
A related question: can you turn on both sides? Does it matter which side when you're proning?
I mean, if the patient cannot really, especially self-proning, you tell them to go like a semi-prone, left or right. Yeah.
Thank you, Dr. Guntapalli. Really appreciate you.
Thank you. We are so honored you came. Thank you. Oh, thank you.
I have a distinct pleasure of introducing my friend, Dr. Diego Martin. Actually, I got to know Dr. Martin during COVID when he was in Montreal, and Dr. Sossman connected me to him because he was doing very innovative stuff with imaging technology, and we got to start talking, and lo and behold, we landed up in Houston Methodist, so we're very happy to have him. Dr. Martin is a professor at Houston Methodist Academic Institute and the chair of Radiology Department and the director of Houston Methodist Research Institute Translational Imaging Center. He took me a tour to our Tesla 7, MRI. That was like a wow tour. His buddy, you have to show your ID, you have to scan, you have to gown, so it was like visiting a very secretive place. His main objectives are to establish new institution-level initiatives in translational biomedical imaging, computational sciences, including imaging-focused programs in cardiopulmonary, cancer, transplantation, and metabolic disorders. Dr. Martin has over 160 peer-reviewed publications, 2 textbooks, 18 book chapters, and has numerous sponsored grants supporting research interest in MRI technology innovation. I am very excited to have Diego Martin on the topic of imaging technology in critical care. Please welcome Diego.
Well, thanks very much for that kind introduction. It's a great pleasure to be here, and thanks to the organizers, Drs. Dalla Faisal Masood, Masood Faisal, sorry, for putting together this annual meeting. I think this is terrific, and I am extremely pleased to be here. Just looking for my controller. This is it? Yes. Excellent. Green for go. Thanks. Disclosures. So I'll confess my overarching objective for being here is to continue to build imaging sciences through collaborations with important members of our organization, particularly in critical care, which I hope to show has tremendous overlap with things that relate to advances in the technologies I work in. So I'm going to focus on describing the Translational Imaging Center cores and the science, advancing technologies in computational imaging, and in the key modalities of X-ray systems, ultrasound, CT, and MR. And then end on what is one of the main pillar areas of development here, one of the main reasons I came here, which is in developing within an integrative imaging context, molecular imaging theranostics in acute tissue injury, which then becomes apparent as to why there's so much overlap with critical care medicine. With that, then I'll start with the imaging center. And there are 4 cores. Oh, do I have a pointer? Let's see. Yes. So we have 4 main cores defined by the MRI systems, the molecular imaging core, preclinical imaging core, and the cyclotron radiopharmacy core, which associates with a team of chemists and a radiopharmacology lab, which is world-class. These are the things that really were very compelling for me to come here, because now bringing all of these technologies together and adding a layer of science will give us unique opportunities. And we've been green-lighted to develop a 5th core in advanced computational imaging. We're playing with the name, but something like ICFAR, imaging computation facilitated by AI in radiology. But nonetheless, I think intuitively, AI is important and is extremely important in my discipline. Also, we're just in the process of ordering a new array of scanning technologies to promote preclinical imaging, which is vitally important. And I hope to explain more about that with my science partners later. But know that this is going to also be a unique system. No other center in this country will have that capability that includes PET MRI in a 20 centimeter bore system, SPECT CT and ultrasound all combined in a multimodality framework. A lot of people are involved. We're a small, moderate-sized group right now and moving toward building a critical mass of technical expertise and scientists. And no, the core means that these are service-oriented cores. And the objective is not to be hidden and secretive. And in fact, I would point out everybody who came up the stairs here should have seen the entrance into the imaging center. It's intended to be inviting and easily accessible. We're here to support all the scientists and things like clinical trials and so on, and we're continuing to build those capabilities. So with that, a main vision, if you will, or thematic focus is the concept of being able to use imaging systems to describe things at the molecular, even submolecular level, and then build that model all the way so that you can have the more traditional sort of representation in anatomic space, and so the concept of molecules to man, and applied to major areas of programmatic areas of focus in cancer, in organ transplant, as we have transplant members here, the brain, vascular system, and all tied together with a common interest in things that relate to active tissue injury and the response to that injury. And hence the one common theme in all of these organ systems is inflammation and things related to the downstream effects of that inflammatory path, or those inflammatory pathways. So moving into the technology domain, starting with computational systems, note that we have several domains where computational systems are important for us, including controlling the machine itself, where machine intelligence has a major role to play. Reconstructing the information that we're gathering as we image a patient or tissues within the patient, and then things that relate to what I think most people intuitively think about AI is replacing the radiologist, and that's the domain really that is interpretation. But there's a lot of more information beyond what is seen or viewable that can be extracted from the data that we acquire. And that advanced analytics is another domain. that we're applying computational systems. So I'm just going to go through each of the modalities and touch on where the technology is evolving so you can appreciate where the utility is in your patients. So X-rays, the lowly X-ray is actually continuing to show value to a degree that I think we need to illuminate further. So note that it's getting smaller and lighter, and the current and next evolving generation of X-ray systems, which are now digital, are really very minimalistic plates with portable, very light units that can be moved around easily in your units, and then coupled with like an iPad device to control all of it. And you get immediacy. There's something very attractive about X-rays because you can get an immediate response and immediate connectivity to people outside the unit with our network systems. These are now all wireless. You don't have to wait for something to go to a PACS. It can be immediately distributed to your colleagues, like someone like myself or whoever, if you want another opinion. And so with that, coupled with computational systems, we're extracting a lot more information. Here's an example of the replacing the radiologist concept, where in fact these are two examples from this publication or series of publications showing on the left side are the if you will the native scans, and on the right the computer has analyzed and colorized the scan. The native scans were read by radiologists, didn't recognize anything concerning. The computer recognized that there were abnormalities and attributed a score in terms of probability of a cancer. And the computer was found to be right in these cases, but overall, the computational systems are matching, even if the computational systems aren't better than a radiologist, if they're consistently matching the best radiologists, we actually have an opportunity to improve the service delivery. Because ultimately that's the goal of these computational systems, to at least match the best that a radiologist can do, and then provide you precision, always giving you the same performance. And so what about in acute care situations? Well, there's an increasing data set results of data sets looking at ARDS, and I'm going to focus a lot more on lung and ARDS in this presentation. And so there's a growing evidence to show those were colorized images by the computer AI modeling. And like the cancer case, giving a probability of it being COVID. And it did very well. And there are a growing number of examples where AI systems do very well. And here you can see the ROC curve, so that's true positive over false positive ratio. And you can see in red, that's the ROC curve for COVID. So being able to differentiate COVID from non-COVID causes of abnormal chest X-rays. And then ultrasound. So we have the lowly chest X-ray, which isn't that lowly, and the ultrasound, which it also has that attractiveness of being so portable. It also is advancing, but it's interesting within your domain. You do things that, as radiologists, we don't actually spend a lot of time looking at, but I think we should, which is, looking at the so-called A lines and B lines when you scan a chest. And there's a dynamic element that is important with ultrasound, right? It's like an extension of a physical exam, but truly becoming internal. So it's a very attractive technology, and you can see patient breathing can manifest a change so that you can differentiate normal pleural echo lines from pneumothorax, where it's not going to move. And then on the top left. And then you have also gravity, the anti-dependent dependent changes. So anti-dependent gas will rise and dependent fluid will fall. So you can see where effusions are collecting, for example, in the bottom right corner. And so the utility of ultrasound, I think, is also going to be enhanced with advanced computational systems and some improvements in that ultrasound technology. So, I think this is something we should be looking at, and we have some evidence. We're just about to publish one of my close collaborators, which many of you know. He was here lecturing recently at Skip Garcia at University of Arizona, where I came from, has an ARDS model systems, and we've been finding actually that the chest x-rays and the ultrasound features actually map with molecular and clinical manifestations of ARDS and can be quantitatively useful as we apply advanced computational analytics. So I think there's more to be done there. CT scan, very exciting, is we are right now about to witness a transformational step forward in CT technology, which I want to make you aware of. It is now FDA approved, and we need to bring that technology here. I could use your help, and we should discuss this. And it's for your patients. So, I'm here as part of the team, not, this isn't for selfish interests. Or at least it shouldn't be. So on the left is, this may not mean much, so I'll just maybe use words and say that the CT has gone through a number of important generational evolutions. The current technology has a fixed ring detector system and then a fan beam. It's like flashing a light, but it's X-ray light, so X-ray photons. And that spins around. That's what you hear, that mechanical loud sound that CTs make. That's because all this electronics is spinning at high speed. And that's the fan beam. So what I'm showing you here is the detector system. On the left is the current latest gen, and on the right is new generation. And the difference is the new generation, this is a technology that's been evolving over many years, and one manufacturer has come first to market, and others are chasing, as fast as they can to catch up. But the point is that it's come now to market, and what it is basically a new kind of detector system that can measure single photons, single X-rays. Not only can it detect a single X-ray or photon and count those, it can detect or measure the energy. So the current generation detectors cannot do that. The other thing is they're built in a way that the spaces between each of the detector elements is closer together. So for a number of reasons, the radiation dose can go down and the spatial resolution can go up significantly. Plus we get new information because we get quantized data, and it's now proportional data. It's not clusters of data. It's individual photon energies that are being measured. So what can that look like? So higher resolution images, you can see standard and photon counting CT in the top left. This is a reconstruction of CT scan with photon counting, and so lower noise. There's no noise generated from these detectors. It's a remarkable piece of engineering, and that allows you to bring down the dose. It's faster. You get a new array of information of the soft tissues that was not possible before. And so there's a lot of discovery that's going to happen now. And that's why, we want to be at the cutting edge. This is cutting edge. That's why we need it. Calcification, stent, vessel lumen, plaque, all these things that were before difficult to separate one from the other now can be separated. And, for example, this image in the bottom right, there's a stent. You can get beautiful angiograms. You can see plaques and differentiate stents and look inside the stents in a way that CT was challenged before. And actually looking at internal plaque structure and differentiating the soft tissue elements in a way that wasn't possible before. And then a new realm of lung functional imaging is going to become possible, still in early phase discovery. But let's not be readers of these innovations. Let's us write the papers and then get the grants and so on. And then MRI, which is my own area. But notice I've been very fair and not showing any bias, I don't think. I gave equal time to all the other modalities, as you'll see. But MRI is, I consider it one of the wonders of human creativity. It is such a complex and beautiful and refined piece of engineering that's continuing to evolve and still can offer a lot more in terms of what it can yield, in terms of precision care, precision medicine, and extracting information to build that concept from molecule to man or person. And so some of the elements that deal with computation, one of the areas I've worked in for over 20 years is building machine intelligence, even before it was a hot topic. And the ability of the scan has increased in the latest iteration tremendously and will continue to do so in terms of being able to scan multiple body parts and replicate what we do with CT scan. You know, when we started CT scans, it would take us 15 minutes to do a liver, for example. And we would get an order, can you do an abdomen and pelvis? And no, I mean, on 2 days, you don't have to split up the scan. But now you think nothing of getting a chest through pelvis, and you see a lot of utility in that in patients who have sepsis and patients of unknown origin, and patients with metastatic disease, for example. And we can do that in just a handful of seconds. MRI is following suit. We have the ability to do full scans and to do it efficiently, but extract a lot more information about the soft tissues than any other modality. And so that's where the machine intelligence comes in, to be able to do this in a way that's precisely defined by the patient's anatomy and structure and their moving, breathing patterns and so on, and to adapt and to acquire those images efficiently. And so I'll just go through some of the areas that my colleagues and I have worked on, including quantitative MRI. So the ability to move from just qualitative generation of images to actually quantize that information. There's a lot of value in that, because that quantitative information relates to molecular changes that can be related to disease processes or functional states of the tissue. And the challenge in the past has been to do this kind of imaging fast enough to be clinically useful and with high enough resolution and without artifacts. And all of those things have been advanced through improved computational signal processing, computational applications also in image reconstruction. And so this is just one example where scans that would take upwards of a half hour can now be done in a minute or a few minutes, and it is nothing more than just to represent that there's a lot of computational work that happens between the acquisition of the information and the reconstruction, and that's where AI neural networks are having a transformative impact in enhancing our ability to do these kind of images, and then moving this into the machine intelligence aspect. We've done a lot of work where complex array of acquisitions are all automated, and so the technologist becomes less of a variable, because the MR scanner, it remains too complicated, and that drives variability and drives down its value. The way we drive up value is to democratize the technology. It shouldn't be a technology that's elitist, that only a handful of us can do well, and the rest just kind of fumble along, which is, frankly, the current state. Our objective is to work with the manufacturers to build a system that we drive it to the tip of the edge of, if you will, of its capabilities, and then everybody can replicate what we're doing. And that's going to happen through engineering, not through, we've tried teaching people. That will never solve the problem, not on its own. It has to be coupled with better user interfaces and better intelligence in the system. So that's all that slide is referring to. And then other elements, you know, we've had a number of other weak links in MR. It's very sensitive to motion and generates a bunch of artifacts that can destroy the diagnostic value. So I can tell you we're moving toward bringing the technology here where a patient could be sleeping through the exam, for example, on drugs. They could be on a ventilator. They could be moving freely. And that image in the middle was acquired in a patient who's just breathing, completely immune to motion. Crisp, high resolution, high contrast images consistently, even in moving patients. And so, with regards to motion, it brings us to lung. and some of the challenges in scanning lung with MR has also been the gas. Gas soft tissue interfaces causes degradation of the signal, and motion is a problem. I'll just show you some work that started when I was at Emory 15 years ago, and show you what direction it could take if you're interested in pursuing this further. So as you know, spirometry has been a mainstay for looking at functional, if you're moving states of the lung, the dynamic evaluation of the lung and airways. But ultimately, it's an aggregate composite assessment of both lungs, right? And ideally, it's about, yeah, good. We have video, so it's like NASA. We have contact. Anyway, so ideally, you'd be able to look at the lungs and be able to look at even sub-regions of the lungs and look at their motion states. So can we do that with imaging? So let me show you some examples. So this is tidal volume. Here's vital capacity. And I'm acquiring these using what's called TrueFIS, balanced fast field echo. It's very motion intensive, high speed acquisitions. It was initially developed for cardiac imaging and can be used also for looking at dynamic lung imaging. And this is work from Emory. Here's a forced expiration. And from that, we publish, we can do all the derivative measures, but with advantages. So this is an acquisition that takes 15 seconds. It's a full volumetric analysis of the chest and lungs. And what we can then do is a elastic registration between the 2D dynamic acquisitions and these static 3D images. And in so doing, render 3D volumetric dynamic imaging, from which we showed we can look at displacement magnitudes and derivatives related to elasticity and compliance. And we were showing, and I left Emory just at this time. I was working with the transplant team. This is an example of a pre-transplant assessment with MR. These are MR-generated images. And the left lung was small volume and highly fibrotic, stiff, and the right lung had predominance of COPD and was very compliant. So this patient was actually selected for a single lung transplant, which, as you know, they don't do as well, but our hypothesis is with superior selectivity, you could find patients who would do better with a single lung transplant. And this patient did very well with a right lung transplant, because the argument was that the stiff left lung would expand the single lung. And the other thing is that we were able to show flow characteristics, and there was negligible flow to the stiff, small left lung. So almost all the flow was going to go to the transplant lung because of the pulmonary vasculature. And the thing is, to move forward with current generation acquisitions, we now can directly do 3D imaging with motion, and with more advanced computational methods, render images of surface maps and then peel away surfaces and look at the lungs, and further look at flow characteristics using dynamic flow in what's called 4D flow to look at the cardiopulmonary circulation. In this case, it's just a heart example. I think there's tremendous potential here. And while I know some of you will be saying, well, we can't send our sickest patients to the MR, there are also chronic changes, or let's say subacute to chronic changes and manifestations that we want to follow up in those patients who leave your units. And, right? And so there's tremendous opportunities here. As well, I want you to be aware of hyperpolarized gas imaging, which, again, we do not have that capability here, but with our pulmonary people, I think it's something we should look at. And why? So, this looks big and complex, but it's remarkable how there are only a handful of centers around the world who have this capability, and they have shown that you can actually do clinical use of this technology. It takes a center with experience just a few minutes to do, in terms of room turnaround time. They can have patients in and off the scanner in about 10 minutes for hyperpolarized gas imaging. And so why do you want to do that? So there's a lot of detailed molecular and functional information that you can extract, which includes exchange of the molecular species of these hyperpolarized gas elements as it perfuses through the septa, through the alveolar wall, and into the microvasculature. And so derivative calculations include alveolar space volume, and this is resolved, imaging resolved. So it's not just total lung measures. It's mapped to as small as you can resolve. These are in, say, a few millimeters resolution. And so, build up that information regionally for the lung. That's tremendous information. And septal changes and microvasculature changes can be monitored with this technology. And then other advances in MR. Here, there has been a tremendous excitement about going bigger, right? So the 70 tera got a lot of attention. Some, maybe all of you know that we have that technology here. There's tremendous interest in going the other way. How low can we go? With the advances in computational systems and some improvements in the hardware, advantages of low field systems, which we abandoned many years ago, are now coming back because this technology is feasible. Things like the gas dephasing in lung is less of a problem as we go to lower field. You can get better lung imaging at lower field than at higher field. And there are other things. So, for example, this is a just released technology at 0.55 Tesla. It also has much less cost. It's 1/3 the cost of a 1.5 Tesla. It's less expensive than our current generation CT scanners. It's very easy to install because you don't have the same shielding requirements, and it doesn't require a chimney, helium supercools our magnets, our electromagnets. It has much less requirement. It's self-sealed. We don't need to blow off chimneys and other things that are very much advantageous. In addition, this system is an 80 centimeter bore, which is the same as a CT scanner. So no longer do we have a problem with big patients or claustrophobia. And you can do lung imaging. And so, for example, vascular changes in the brain and strokes, we use a technique called DWI. Doesn't really matter what that is right now. Just know that this imaging is important in vascular disease, microvascular disease, and stroke, and it's actually better at low field than at high field. So definitely also a technology we should be looking at getting here as a front edge technology. And how low can you go? That's a lower field MR. This is a minimal field. This is a company that has come forward with a system, and they've gone to an extremely low magnetic field strength of 0.064 Tesla. And this system, you notice this picture? You just plug it into the wall. It runs off. It is such a weak magnet that my ID badge could be put here and it won't get oh, I guess you can't see that, but there. And it won't demagnetize my card. You could wheel this into your ICU. It's bedside MRI. So does it generate an image? Well, shockingly, it does. And they're not bad, and there's a lot of room for advancement with more of those computational systems I was alluding to. And so that in the blue box was generated from this ultra-low field, and in the rest of the images were generated from 3T. And as a radiologist, I see a big difference between them, but there's some, those are readable images. So the question is, and by the way, we submitted to get this equipment in here so that we can then work with you and put it up in the unit. And that's something we need to talk about, because that agreement has been circulating for over 15 months and we still don't know where it is. And I think some of you know what I'm talking about. We need, I know we have a number of leaders here. Come on, guys. We've got to get our administrators, right? They've got to get into gear. We can't be leaders. We just can't. When we have opportunities like this, that's what we're investing in. We need to move fast. Otherwise we're not leaders. So molecular theranostics, I'll just finish on this topic. And here's some of my collaborators within the organization and from other organizations, so that I'll touch on the work that they're doing. And note that molecular imaging theranostics means basically developing designer seeker molecules that go after specific targets that we then can couple with a signaling agent, like an agent that we can see with PET imaging. And we're also moving forward to create seeker molecules that can have signal that we can detect on MRI, which has never been achieved before, but we believe we have the tools to do that here. And this is a summary slide of work coming from Zheng Li's lab, where she's developed amazing technology for, in particular, atomic force microscopy, which is a bedrock for being able to create these designer molecules. And she's shown her lab has the ability to take a molecule that maybe another lab has developed, but then we redevelop it so that it has much better performance than the original molecule, with thousands-fold increased binding affinity. And so with that, we're going after certain targets that deal with active tissue injury and response to injury. And two prime examples are, that I'm going to just say a few more words about it, in particular is ENAMT, which those of you who met with or heard Dr. Garcia's presentations will have learned about. And I'll just summarize here briefly. Another is a downstream response to active tissue injury is fibroblast activation protein. These were initially identified, FAP rather was initially identified in cancer, but we're finding that it's actually involved in non-cancerous active tissue injury response mechanisms. And so the ENAMT, or extracellular nicotinamide phosphotransferase, note that that's a molecule that exists intracellularly and it's involved with energetics. But it has a totally different effect and role when it's in the extracellular form, where it's involved in the so-called DAMP, or damage-associated molecular pattern protein pathway in the TOL4 receptor. And what we've done is, and it's critically involved in ARDS of any mechanism, of any trigger. And we've taken that, and with Zhang manufactured a tracer, which we've published on, and shown that we can use it for in vivo imaging of active tissue injury. This is an ear injury model, and so you can see the right ear and the left ear, or the right ear rather than the left ear. The right ear, this is with tagged non-specific IgG, and this is with the monoclonal against ENAMT, showing significantly increased signal on the imaging. Similarly, in ARDS model, we've shown in the control and then the animal with ARDS that we can track the ARDS, and it tracks with molecular and other clinical markers of disease. So now we have a way to longitudinally in vivo monitor at a molecular level the DAMP pathway. And this is the basis of the molecular imaging component, and then the theranostic component is that these same molecules that, in terms of the family of molecules we're working to build, also can have therapeutic effect by interfering with the function of the target. And the example here is control lung. This is an ARDS lung with lipopolysaccharide, and that's ventilator-induced lung injury model. And you can see a lot of inflammatory, there's a basically consolidated picture with a lot of inflammatory cells. This is the animals now with the same trigger, if you will, or trauma, LPS villi stimulus, but given the monoclonal against ENaP 2 hours after and then 6 hours after, and then all of these tissues were taken 24 hours after the trigger. So you can see marked improvement, even 6 hours after the initiation. And I think you guys can tell me, a lot of putative therapeutics have come forward, but none have really played out. There's a really growing solid body of evidence that this might be something that will work. And as you know, Dr. Garcia is looking at multi-center trials. It'd be great if we could be one of those centers. In any event, other similar approaches are of interest to us. This is with a colleague of mine from Arizona, Evan Unger, who developed Definity, which is the first ultrasound contrast agent, a microbubble based on a dodecafluoropentane agent. And this is just to show how it works in ultrasounds. This is an ultrasound image, and this is a perfusion ultrasound image with the microbubble showing an infarct in this wedge-shaped defect. Now, what's interesting about this agent is this, that if you make it into an emulsion, it's a solid at room temperature, it's a gas at body temperature. And when injected, it can increase oxygenation of tissues. And this is from a pig pneumonia model, just showing that the oxygenation state was elevated when this agent is infused. What we've done is shown that in a cardiac myocardial ischemia reperfusion injury infarct model, that in the acute stage, I'll just focus on the right side of this figure. So this is control volume of infarcted tissue and treated with this emulsion rather, that's infused after the ischemic injury. So it's like a clinical model where the event occurs and then we infuse the agent. And we've shown that it protects the myocardium. We've, in process of publication, is long-term, multiple weeks after, we show also that the fibrosis is attenuated. So we believe this emulsion is actually having an attenuation effect on the active injury response pathways. And this is in a stroke model. The same agent is showing a protective effect for the cerebrum. This is the control. White is stroke tissue. This animal had standard of care, TPA. And then on the right, you can see pretty good preservation of the brain tissue. They received TPA and the emulsion. So we believe this is also a very interesting agent for us to look at, and also evidence that it has protective mechanisms in ARDS, similar to what I just showed with the monoclonal against ENaP. You can see this is the control. This is normal. This is the control ARDS lung, and this is ARDS, but given the emulsion. So actually, I'll how are we for time? I think I'll wrap up. Yeah, so I'll wrap. This is just looking at another molecular agent with a VEGFR inhibitory molecule for which we have built a tracer. It's very interesting in terms of being able to protect the lung against pulmonary hypertension from chronic injury. And so again, another molecule of interest. So I'll just wrap up and point out that imaging technologies have undergone a lot of advances, but are actively advancing in applications useful for acute lung injury imaging and molecular therapeutics, and that's an area that we're focusing on here. And that there's a transformative impact that's happening with advanced computational systems in AI, and we should consider the untapped potential of the simple things. X-rays, I have things that I'm really hoping we can speak about further, and that's really in terms of future directions. I'd love to propose, let's form a work group and roll up our sleeves and start doing some programmatic projects together beyond even what we've started to discuss. And so thank you for this terrific opportunity.
Thanks, Dr. Martin. That was a truly mind-blowing talk, and I'm looking forward to what the future is going to hold for all of us. Here's a question from the audience. Is there as much efficiency in a portable CT machine as a fixed CT machine in critical care patients? Is this technology that we could use, could see at Methodist and would in the future?
Well, absolutely. CT is another, so all of these technologies have been minimized, if you will, to become portable. Not unlike what I showed you with MR, there's some trade-offs. And the portable CT is not really gained general acceptance because of those trade-offs. Could it be improved? Absolutely. The question is if even this new detector technology is translated along with some of the AI methods, portable CT could now pass that threshold where it could become a very useful instrument. Currently, it's not considered widely as a useful instrument.
And how far away are we from getting a PET MRI or an MRI to do maybe a PE protocol? Is there something like that in the?
We can do PE, so that published on that, that's over 10 years old. We can do PE MRI today. I think it's more about access. In my former organization, we built a pathway so that there was 24/7 emergency access to MR. We don't have those pathways built here fluidly. Could we, should we? I think so, absolutely. There's MRI is being underutilized, just global statement, is underutilized in acute management. It has a lot of added value, and in cases where you don't want to use a CT or can't use a CT, and potentially MR could, in some instances, replace CT. If we look at that new low field system with automation, I think it has the potential to be used instead of CT and in a number of acute settings.
And PET MRI too, coming up?
Well, PET MRI. So we are getting a PET MRI system for the preclinical area, and that's a conversation we should have. It takes more. We have to unpack some more discussion around that in terms of what can you do with an MR and a PET CT versus what can you do with a PET MR, and is it enough to warrant the investment? There are people who fall on both sides of that. I actually am with you. I think we should look at PET MR, but I know there's more to consider, and it's about prioritizing. What do we do first? Since there's always going to be some level of balance against what we can do in terms of space and capital.
Okay. I have one last question. For artificial intelligence, let's say we study something on one generation of a machine, let's say a 5 Tesla MRI, and now we've all advanced and all our machines are 7T, let's say. Do we have to reteach or redo that algorithm for the new generation?
So there's an exponential growth in cost and complexity. So 7T, we have one 7T system, and it costs about $12 million. The 0.55 Tesla is about 850,000. The cost of installation, maintenance, accessibility, all those things are enhanced with lower field. I think lower field is something that should hold a lot of interest for us.
This is not a question, more of a comment. And I think traditionally, critical care and imaging departments really have not partnered. We just order a CT scan, X-rays, and then we yell at them if you don't give us a report immediately. That's the relationship we had. But I think as you saw these images, I would challenge ourselves, including myself, to have more partnerships in a lot of things we do, whether interventions, whether evaluations, whether all of things, and that includes nurses. I mean, because we have to see how we can make it portability feasible, whether it's MRI, whether how do we study things of intervention we do. And I would strongly encourage these trial group, and we will reach out for, and you're more than welcome to email me or people who want to partner. And I think Dr. Martin has been very enthusiastic. So I think we really need to take it a very different level. I'm not aware of many critical care departments and radiology departments who have a potential of great partnership. So let's build up on that. So thank you, Dr. Martin.
Thank you so much.
Our next speaker, Dr. Mila Sprouse, is the current Vice President of Critical Care Patient Services at Baylor St. Luke's Medical Center in Houston, Texas. She has over 3 decades of combined experience in critical care at the bedside, education, training, leadership, and healthcare administration. Dr. Sprouse has a demonstrated ability to integrate business, financial, and technology interests into cohesive, driven, and focused operations. She has also received multiple safety, innovation, quality care, and leadership awards from different organizations and associations, including the annual Houston Chronicle Top 150 Nurses and the Good Samaritan Nursing Excellence Awards. Additionally, she is the incoming president of the Philippine Nurses Association, North Houston chapter. Beyond her accomplishments and the accolades, she embodies hope, resiliency, and joy. Please help me welcome the unstoppable Dr. Mila Sprouse.
Well, good morning. Actually, it's good afternoon, right? Yes. First of all, thank you for having me here today. And I'd like to ask one question to all of you, nurses, our APPs, as well as our physicians. Is there a nursing shortage across the U.S.? No, don't answer it. All right, so I recognize that I am between you and lunch. And my favorite husband has been texting me, make sure you get here because we have to catch a flight. And I said, yes, we will be there. So I want to share a little personal note about what's happening. After almost 8 months of finishing my doctoral degree, I finally will be able to walk the stage Monday. Yay! All right, so daring to change nursing practice in the 21st century is one thing that I always love to talk about because we are in a different situation, way beyond what we have imagined. And then the pandemic came. So I will start with this quote. It's about change. And of course, Theodore Roosevelt actually shared this information to us, and he says, we must dare to be great, and we must realize that greatness is the fruit of toil and sacrifice and high courage. And he further said that we are face to face with our destiny, and we must meet it with a high and resolute courage. End quote. Your destiny, our destiny, nurses' destiny, our medical partners' destiny, because without nursing strong and sustainable, we will not be able to take care of our patients. And thus, I so believe that we need to talk beyond the talks. We need to execute the things that we have talked over the years. I know that a lot of work has been done from American Nurses Association, ANCC, American Critical Care Nurses, Texas Nurses Association, but we have to stop. We have to say we need to have actions. So that's what I'm going to cover today. My objectives is I will be delivering a high-level historical background of the state of nursing practice, and then what changed and why it will not pay off in the future. And then we're going to talk about the future state, because this is very important for us to actually survive the 21st century. So when we talk about basically the historical background, we have to talk about the experience complexity gaps. So what does that mean? What that means is that the experience, there is a gap. Here's why. We know the baby boomers, right? I belong to the baby boomers. A lot of my friends actually have retired, either because it is time to retire or because they want self-preservation, because it's been tough out there. Now we have an influx of new nurses in an environment that actually is very complex. Our patients are very sick, and we now have this experience gap. So how do we resolve that? And that's what I'm going to share with you all. The second piece of this is it's so easy for us to talk about the pandemic has done so much in our healthcare landscape, but if you look back way before the pandemic, there actually has been a shortage in nursing already. The pandemic uncovered it, and the pandemic actually told us we have to do something. So that is from a historical background. So what changed and why it will not pay off in the future? I'll be discussing the organizational commitment. Is it still there? And I will talk about contract laborers. You all have agencies, don't you? Yes. And some of you work as agency nurses. And the care models, is that still working? Is there something that we could do that actually would help nursing in the future? So when you talk about organizational commitment, I go to this poll, and you don't have to get in your phone. I'm going to ask you, what is the most difficult to retain as far as bedside RNs in the workforce market? Is it the critical care nurses? Is it the medical surgical, or what we call acute care nurses, or ED, or RNs? Being that we are in a critical care symposium, I bet you'll say critical care. Well, actually, studies show that nursing executives says 42% report medical surgical RNs are in shortage supply, followed by critical care nurses, and then the nursing executives report emergency department RNs in shortage supply. But that doesn't discount where we are in critical care. If you think about it, we have to have nurses at the bedside to take care of all the things that we need to do, all the things that we all heard today that we need to apply to our patients. So at the core of what we do and at the core of what I'm going to share with you all is actually about our patients. How are we going to sustain taking care of these patients? So why not organizational commitment? First and foremost, organizations are now a stepping stone, not a destination. Do you all agree with that? There's some truth to that. It may not be across the board, but it is happening. And we do not actually blame anyone for that to happen. Until leaders actually accept that fact, we're not able to actually create a plan and execute it and make sure we mitigate that statement right there. So we have nurses that want to be a nurse practitioner or an anesthetist, or maybe they want to be a leader, and therefore we need to support that. And when our nurses in the future see that, then they will start thinking, this is the organization I want to be, because they really are looking at where I need to be as far as professional growth. Why not organizational commitment? It is hard to be a nurse at the bedside. I know, as a vice president, when I put on my scrubs, I go in and help just to make sure they all see the support all the way to the executive level. I ask, I still can set up an A-line. And then, of course, I had all the saline showering everyone. But you know what? It still is hard, though. I cannot do what our nurses are doing at the bedside. RNs pursue lucrative travel contracts. We cannot compete with that. We will never be able to compete with that. And guess what? It is okay, because it's an opportunity for them to actually get paid more and pay their bills and their student loans. But what we need to do is support that, because what we want to do is for them to actually see that there is home to go back to. And when someone gives me their resignation, you know what my conversation is with them? I am happy for you. You have the courage to actually make this decision, and I know that it is not easy because you love working with your team. But I also know that you make this decision for yourself alone as well as your family. And so I'm happy for you. That is what we need to do as leaders. Contract labor, the elephant in the room. It's not sustainable. And we cannot have that for a long period of time. Over-reliance on premium staffing is unsustainable, and it increased up to 284% in 2021. That's a staggering number. And then the healthcare industry actually lost over 500,000 workers since February 2020. And finally, the number one reason that they have reported why 96% of nursing executives actually shared said that it's the compensation. So all the organizations are scrambling. We need to pay more. We need to pay more. And so all the salaries are going up. But where does that stop? And that's what organizations need to actually resolve with what is happening. So contract labor, look at this graph. It came from the New York Stock Exchange. I'm not asking you to buy stocks, by the way, okay? This is AMN, the largest travel agency in the country. Look at where they were at less than $50, and look at where they were December 31, 2021. It is so aligned with what is happening across the country, and it will continue to go up. So what about the care models? We have primary and total patient models, unsustainable. But by the way, I'm not advocating team nursing, nor I'm saying primary and total patient care models should be out of the window. It's one of the best nursing care models that actually has been in there, but we need to do something. Growing RN shortage is not going to sustain this model. What about the licensed and unlicensed patient care assistant roles? We need to exploit that. The problem is it's a low-paying job and it's labor-intensive. This group of ancillary personnel can actually get work at McDonald's without lifting a patient, and they have a free meal from McDonald's. So how do we exploit this? These are the things that we need to continue to dig down. And the reason why is that if we don't, our future state is pretty dismal. Look at these information right here. Increased vacancy, safety goes down. Longer overtime, I know there are organizations out there that they limit overtime because we know medical errors go up. Increased novice RN staff, if we don't support them intentionally, we're going to have medical errors. And finally, increased travel agency use, there will be increased labor costs. We are paying millions of dollars in each of the organizations every month. If you guys want to sit down with your CFO, look at the numbers. It is unbelievable. So what are we going to do? Now is the time to do something. We need to reduce reliance on RNs. Oh, by the way, it's not about getting rid of RNs. It's about getting rid of the things that's wasting the RN work. Right? Yes. Do you guys know there's this organization, I'm not going to mention where it's at, that they actually plotted out what nurses do during the shift. 22% of the work is looking for medications. Do you guys see that? Mixing drugs. Another high percentage is looking for supplies. So what if we actually take that and add it to what they're doing and taking care of our patients rather than running around like chickens without heads? So licensed and unlicensed PCAs, let's bring them in. Then, okay, everyone gets a little seizure in here. Bring back LVNs. Wow. We have tasks for them. They can never replace RNs. But here's the other piece. Oh, ANCC will not allow us to have that. For magnet, associate degrees, higher mix. If you define them and actually provide that information to them, they're open to that. Here's the conflict for them. You want us to take care of our patients? We need help. Or we'll sacrifice magnet maybe just to take care of our patients. They'll approve it. I'm going to bet you. I know it happened. Pharmacists, redesigning that. So there's this organization that actually is using pharmacists to give medications, mix drugs, hang drugs. You'll never have an empty nor epi drip. They will do that. Supply chain. We need an unlicensed personnel to run around and get our stuff. So do I have a CFO here? No, thank God. Because you know what? They're going to say, Mila, those are FTEs, whether they're licensed or not. Okay, that's fine. Let's sit down and quantify them. Because the amount of check that you send out to the agency, is going to compensate for all these things that we are mentioning here. There's one organization, I think, believe in their vice president, and they actually are working through this. Not telling you which one is that. Lab techs, we need to continue to expand. So here's another thing. Augment staffing with virtual ICU. A lot of y'all already have hardwired your virtual ICU. So maybe we can use virtual ICU for other things like reporting lab works. I know some of our nurses and our physicians, we have that kind of territory, right? But we need to let go. Let it go, let it go. Because otherwise, we will never gonna be able to actually reduce reliance on RNs. Scribes, hello? How many incremental overtimes are you guys getting asked? We need to get rid of incremental overtime. And our justification is that we were tripled, so we had to do documentation, finish our documentation, and it's beyond the time, and we couldn't clock out. Scribes are used in other departments. We can have scribes. Do you guys like that? You're just saying everything, and someone is putting it on Epic. Transporters. How many of you go to MRI and CAT scan for more than an hour? Yeah. You like disappear for 1 hour and 2 hours. We need licensed, experienced nurses to actually go with the patient so that you can stay and take care of your other patients. And then, respiratory therapists, they help us quite a bit, but we can do more. We can still expand their role. And, oh, by the way, do you guys know what the Holy Grail is in critical care and other places in the organization? Length of stay. So, we have our directors running around chasing our physicians. Here's the list of the patients that we need to downgrade. Why cannot I have my social worker or case managers do that work so that my directors can support their staff at the bedside? And we put that all together. We need to create processes, and we discuss these things in huddles, debriefs, as well as we need to create escalation workflows. If someone is not doing what they're supposed to do to help us, we need to escalate it gently. Okay, we're not going to yell. So other things that we can do is to decrease premium labor, build a sustainable entry-level workforce strategy, examine your onboarding process for experienced nurses and graduate nurses. You have to have leaders that have a vision. There's one organization that the leader actually walked in with over 50% vacancy rate. And probably that leader said, oh my gosh, what did I do to myself? And of course, when you change, there's usually about 10% added to that. But we have to create something to actually resolve this. How many of you leaders here have gotten critical care, experienced critical care nurses application on your desk? You have not a whole lot. That is not sustainable. We're going to continue to have a discrepancy on the supply and demand. So we need to look at other ways, and I will give you a little bit of information in here. Oh, by the way, virtual ICU leveraging. What do I mean by that? There's this one leader that actually is in the middle of virtual preceptor in ICU. Pretty awesome, isn't it? And by the way, it works. And here's why. Let's say if you have a 16-bed ICU and you have 8 nurses, 4 of them are preceptors, the other 4 are not. That means you have 4 new nurses in there, and one of your preceptors actually called in. Now you have 2 preceptees with 1 preceptor. That virtual preceptor is not going to take over precepting. She will augment the process. An example, a preceptor is busy taking care of the other patient, and there is something going on in the other bed, in the patient, that preceptee will ping the virtual ICU preceptor, and that preceptor will come on and ask, what can I do and how can I help you? What an innovative way to do it. And a lot of you, especially Methodist, has hardwired their virtual ICU. So take advantage of it. Don't settle for buddies, by the way. Yes, we're short of nurses, but we still need quality nurses. Yes, they're new graduates. We still need to hire for attitude. I will hire any day for attitude, because I'm always concerned when I hear, Mila is a great nurse, but that but thing is a red flag. And create a pipeline. So there's this organization with that example of more than 50%, basically vacancy rate. What did that organization do? Hire GMs. Yes, in my entire nursing career as a leader, I would hire 5 or 6 GMs. Never have I heard hiring 52 GMs in a critical care. And guess what? It doesn't stop there. The next cohort, 3 months down the road, hiring over 100. The next cohort in October, close the gap. That leads us to a less than 10% vacancy rate. And how do we do it? We, our physicians, our APPs, and our nurses will have to work together to take this group of nurses, young ones, to become one of the best critical care nurses there is, because we will support them. It takes a village to do that. So a buddy system at the executive level and physician level, it has to happen. And this organization, their vice president meets with their GNs lunch every week on a Wednesday, and they talk about what are the 3 things that you see that's really good, and what are the 3 things that you see that's really bad, and the top of the list, staffing. Then we talk about how do we actually help that staffing. And that person tells those GNs, you are a part of the solution. That's why you are here, and you are needed here. Do you know what that does for them? It's an amazing feeling that they belong to the organization. That takes us to our organizational commitment. Our leaders at the bedside should be our chief retention officer instead of the length of stay person. And revitalize professional development. You have to take time to sit down with each and every one of your staff and plot out professional growth for them. You take them where they want to go. Do they want to be a leader? You give them every tool. Be comfortable that you're going to lose them, but while they're with you, they will give everything that they have. So that's why you have to create a pipeline. Conduct state interviews, and I think that is happening, and ensure safe environment. This particular organization, the vice president actually created a shared governance for their GNs. It's a huge team, and they need to have a voice. They need to have a place to actually talk about the things that they're scared of. That is creating a safe environment. And that also applies to our experienced nurses. And oh, by the way, the rule when I'm conducting that is that it's okay to discuss challenges. I need solutions. And here's number one rule. We're going to be respectful with each other, not tolerating disrespect. Because if that is the case, you don't belong here. Yes, we're short of nurses, but I still need those kinds of nurses that will make the world move. Hardwire strategies on strengthening well-being and resiliency. I know we gave them EAPs, lavender carts during pandemic. It just is not applicable during pandemic. We have to take care of who we have every day and provide them that information. Practice routine, meaningful recognition. American Association of Critical Care Nurses support healthy work environment. And redesign RN total rewards, and everyone says, okay, bonus, bonus, bonus. And that's good. I like that. I always love when I see $500 turkey bonus. Yes. But again, sometimes other organizations do not have that. So what can we do? We leverage our clinical ladders, our DPMs, to be able to actually support our nurses. Flexible schedule and role options. We do that. A lot of us work in a magnet facility, and so part of that shared governance is basically have autonomy as far as scheduling. But there's a caveat to that. It's all about, again, patient safety. We cannot give everyone off on the weekends, on holidays. We have, as leaders, actually have to spread the wealth on that one. Commit and ask for commitment. I feel very strongly about that. We're committed to make you grow, but I need commitment from you. And everyone's like, always look at me, and they said, what do you mean by that? I said, I don't need you to be here 7 days a week, but the commitment is about be involved. What committee do I need to write you in? And when you are involved in a committee, I need you to be there 80% of the time. Those are commitments that I'm asking for anyone to join my team. So, last but not the least, you guys are familiar with jeepneys in the Philippines? They're very colorful. So I'm gonna ask you, how many passengers do you think can this jeepney carry? I'm gonna say 5. Oh, right now, 1, 2, 3, 4, 5, 6. There's 6. 8, 10, 15, 20. All right, so let's look. So this actually is my inspiration. I have this printed. It actually is a source of opportunities for me. I said, if these people can do it to get home, there has to be a workaround on everything that we do. Everything. Everything. You know why? If there were ever a time to dare to make a difference, to embark on something worth doing, it is now. And guess what? Theodore Roosevelt shared this quote, "Far better it is to dare mighty things, to win glorious triumphs, even though checkered by failure, than to take rank with those poor spirits who neither enjoy much nor suffer much, because they live in the great twilight that knows not victory nor defeat." So thank you, everyone.
Wow, that was brilliant. Thank you so much. And let's see if you have any questions from the audience. I hope you're not taking our whole team with you now to St. Luke's.
Dr. Dahl, I did not say that organization's name.
You've surpassed all expectations, Mila. Thank you so much.
I can't believe you guys agreed with me. No questions.
Now we've come to the end of the presentations, but we have a lot of interesting things to happen, so stay tuned. Before we break, I have a couple of announcements. One is a very exciting announcement, our abstract winners. This year we had 25 abstracts that were submitted. We had 2 reviewers, and actually, what ended up happening is that we have a tie for the first place. So we have 2 first-place winners. The first one is Ryan Logue. And the topic, implementation of a clinical decision support tool in improving adherence to lung protective ventilation strategies. And he wrote me a couple of lines, so I'll read those to you. This QI initiative required input from multiple disciplines, including coordination via the virtual ICU nursing, using informatics software and implementation by the providers in the ICU. Implementation of this clinical decision support tool showed statistically significant improvement in the provider's recognition and documentation of ARDS, as well as improved adherence to the lung protective mechanical ventilation strategy. So congratulations, Ryan. You actually get a prize, Ryan. It's a surprise.
They get a nice financial support for an educational activity also. So I think this will help them to attend any conference and everything. And we want to support, everybody who works in critical care. So again, this is really not about how much. It's a pretty good amount, but but it's really to really encourage and supervise. So thank you, Ryan, and all of your team members. Good job. The check will clear if more bounce.
In tie for the first place, Judy Kizelwarda. And the title of the abstract, Effectiveness of Nursing Education in Timely Organ Referral. And brief description, timely referral for organ donation largely depends on bedside nurses. Abstract investigated the referral time of organ donation before and after nursing education without any alerts by the EMR. So organ donation referral time highly improved after nursing education. Congratulations. And then for the first runner-up, and the only runner-up, Anza Zahid, Dr. Anza Zahid. And the title of her abstract was Using a Novel AI-Based Approach to Analyze the Consequential Rise in Non-COVID Mortality During the Pandemic. So they created a digital twin through artificial intelligence. It's a new and novel way of data analysis in healthcare. A prototype average patient known as the twin, created considering age, gender, race, Medicare category, community dwelling status, and other risk factors. Congratulations. So I just need to make a couple more announcements before the break. So when you registered, you selected a breakout session or an in-person workshop that you wanted to attend. So on your badge, in the back, you'll find a color that's associated with your breakout session or your in-person workshop, okay? So don't worry, you won't get lost. And I don't want to go through the real details of everything. Just suffice it to say that whoever is going to the breakout sessions, please come back here, okay? And for those that are going for the POCUS workshops, that'll be in Mighty, okay? And those that are doing the other workshops, they'll be in the Dunn buildings and Dunn conference rooms. So we'll guide you. There are plenty of people here to assist you. And now I wanted to thank so many people. So I'm going to start by thanking all the speakers, the volunteers, Houston Methodist audiovisual team, the academic team at Mighty, Mighty's video production team, and of course, all of you. And obviously a special thanks to all the exhibitors and sponsors for making this event possible. A very special thank you to Dr. Faisal Masood for his unwavering support and leadership through the Houston Methodist Center for Critical Care. Another very special thank you to the organizing committee, in particular Janet Fabugay, Marco Hernandez, Cicely Simon, Rachel White, Juanita Young, and Chris Rawls. Bravo, you guys. It was flawless, okay? Bravo. Dr. Deepa Gatur played a major role. She organized all the abstracts and also helped me moderate the questions throughout. This has been a truly collaborative effort, and contribution of every single person has been critical to the success of this symposium. So now I'll let you go for lunch, and we'll come back here at, what I mean is come back for workshops, breakout sessions at 1:30 p.m. Thank you so very much.
Welcome to the neuro portion, the workshop. My name is Dr. Kevin Emanuel. I serve as the medical director of the neuro ICU here at Houston Methodist. I would like to introduce our panelists who are going to be giving you short talks talking about some neurologic illnesses that we particularly face, not just in the neuro ICU, but even in our community hospitals. So first, I'd like to introduce our first fellow, Dr. Brad Daniels. He's our fifth-year fellow. He's going to be talking about cold stroke. And next to him is Dr. An Nguyen, who serves as our fellowship director for the Neurocritical Care Fellowship. And next to him is Dr. Michael Zorman, who is also one of my esteemed colleagues who I have had the pleasure to work with for almost 7 or 8 years now. So we're going to be hopefully creating a scenario for how to approach neurologic illnesses. And don't be afraid, we're going to just share some caveats to how you can manage things like stroke, things like intracranial hemorrhage, traumatic brain injury, and we will wrap it up with status epilepticus. All right, Dr. Daniels?
You want to solve that one?
It's up to y'all, yeah.
Good afternoon, everyone. My name is Dr. Daniels. I'm the fellow in the neuro ICU here at Methodist. I was asked to present on stroke, acute ischemic stroke, and sort of the basics of management and how we manage them in our neuro ICU and some complications that can arise in the critical care setting. So I thought I would first start with just a case, kind of an illustrative case. This is an actual case with a few modifications to create talking points for the discussion. So this was a 82-year-old female. She had aortic stenosis that was symptomatic. She came in and underwent an elective aortic valve replacement. She's also got a history of severe vasculopathy. She's a smoker, has COPD, has CAD, has had a CABG and stents, as well as peripheral artery disease, as well as carotid artery stenosis. So following the procedure, it was an uncomplicated procedure. She was extubated at 12:05 in the PACU and doing well until 1:30 when PACU nurses noticed that she developed an acute left-sided hemiplegia as well as a right gaze deviation. So they called a code stroke. The neurologist came and evaluated and calculated her NIH stroke scale to be 24. The patient went for a CT CTA as is protocol for code stroke, as well as a CT perfusion. Okay, so just starting with some imaging. So this is a CT on the left and a CTA on the right, axial cut of the brain. So the CT on the left looks fairly unremarkable at first glance, which is typical of acute stroke. If you look closely, kind of to maybe window it a little bit, you can see some area here with kind of loss of the sulci and gyri that you see over here, for example. And you also see a loss of the gray-white differentiation that you see here, for example. So there you can see the clear lighter and darker shades here. Here you don't see that, so that's suspicious for a stroke. The CTA, also done per protocol, showed this area here that was suspicious for a right M1, M2 occlusion, distal M1 occlusion. So this is a CT perfusion. So this is a special CT scan that's done. It can be done pretty rapidly, which is why it's favored. Some centers use MR perfusion. Here we use CT perfusion. So the CT perfusion basically is a way to calculate the penumbra, which is the area that's hypoperfused and at risk for stroke. So you can see here on the left, there's this pink area, which is infarcted brain, and on the right, there's this green area, which is the at-risk area, the ischemic area. So they calculate this mismatch ratio, which is basically the area that's at risk, so the area of penumbra. So if it's above 1.8, that's typically the level that they're more likely to go for a mechanical thrombectomy, which we'll talk about. So she's not a candidate for TPA because she just had aortic valve replacement, right? So major surgery. We'll talk about the eligibility for TPA in shortly. And then, as I mentioned, her mismatch ratio was favorable for a mechanical thrombectomy. So she went for the mechanical thrombectomy and they achieved a TICI 2A. The TICI score is a way that we kind of grade the amount of reperfusion that we get during the mechanical thrombectomy. So the higher the score, the more reperfusion that was achieved. It's a score of 0 to 3 with the grade of 2 subdivided into 2A and 2B. So then after the mechanical thrombectomy, our patients come to the neuro ICU. She remained intubated, and we monitored closely after her procedure. Okay, so let's talk about TPA. So TPA is tissue plasminogen activator. It's one of the cornerstones for treatment of acute stroke, as I'm sure everyone knows. Just some history and kind of how TPA came to be. In the 90s, they started doing trials on TPA used for acute stroke. Some of the landmark trials are the NINS trial, done in 1995, which basically led to the approval of TPA for acute stroke within 3 hours of last known well. LKW stands for last known well, typically. This study also established the eligibility criteria for TPA exclusion, so I'll talk about that in the next slide. But the way that it established this is by using this study's exclusion criteria. The other landmark trial for TPA was ECAS. It's a multi-part trial. ECAS 3 was done in 2008, and this is the study that is responsible for extending the window of last known well from 3 hours to 4.5 hours. So this is kind of how we use TPA within 4.5 hours with the exclusion criteria in mind. So some of the exclusion criteria, so these are the main ones. Obviously, if there's an ICH, an intracranial hemorrhage, which is why we get the CT for an acute stroke. If you don't know the time of onset, because that 4.5 window is very important, as shown in the studies. If the symptoms are rapidly improving, or if the NIH stroke scale is low, typically the risks outweigh the benefit for TPA at that time. If the stroke is so bad that the thought of giving TPA it puts them at risk for intracranial hemorrhage, then that's also an exclusion criteria. If they have a seizure, head trauma, or another stroke within the previous 3 months. So some of these are pretty obvious. I think the ones that typically come into play for us are the, are the blood pressure parameters. So systolic blood pressure 185, diastolic pressure 110. So you want to get the patient below those parameters before administering TPA. The thought behind that is because you minimize the risk of post-reperfusion ICH. Also the platelet count and the anticoagulants. If they are on anticoagulant, that's an absolute contraindication if their platelet count is less than 100 as well. And then also any history of intracranial hemorrhage is also it's contraindication. So mechanical thrombectomy is one of the other treatments that we use for stroke. This patient, our illustrative patient, went for mechanical thrombectomy. So just to kind of break down some of the trials for mechanical thrombectomy. So Mr. Clean was the first trial that really established mechanical thrombectomy as a adequate treatment for stroke within 6 hours of stroke onset. That was done in 2015. Diffuse was a multi-part trial. The Diffuse 3 was done in 2018, and it extended the window from 6 to 16 hours in certain patients. This is where that 1.8 mismatch ratio comes from. So this trial basically showed that if the penumbra was large enough, then you could extend the window from 6 to 16 hours, which is why oftentimes we get a CT perfusion for these patients. So the Dawn trial is the most recent trial, also done in 2018. So this is kind of the cutting edge that we're practicing now is the extended window elbows. Our elbows that come in, elbow stands for large vessel occlusion. So our elbows that come in within 24 hours that have this mismatch of deficit to infarct. So if their deficit is high but their infarct is low, studies have shown, the Dawn studies showed that those patients have benefit of mechanical thrombectomy up to 24 hours after stroke. So blood pressure control is obviously a big thing to keep in mind with these post-thrombectomy patients. It's something that we very rigorously do for our patients in the neuro ICU that have undergone mechanical thrombectomy. The idea is that lowering blood pressure in patients that have had reperfusion decreases their risk for post-reperfusion ICH. So the more reperfusion that has been achieved, typically the lower the blood pressure parameters are. So some clinical trials. So this is kind of an area of study right now. People are going through and trying to determine what the best blood pressure parameters are. The BEST study came out recently, as well as some of these other studies. And then BP Target came out last month. This study basically established that the lower the blood pressure parameters are, it showed no benefit in comparison to higher blood pressure parameters of 130 to 185. So here at Methodist, this is typically the framework we use. So the lower the TICI score means the lower the amount of perfusion. So a TICI 0 is no flow. So that's going to be your patients that need permissive hypertension, so up to 220, systolic blood pressure. Then the higher you go, the lower your blood pressure parameters get. So up to a TICI 3 where your systolic blood pressure parameters are less than 140. These systolic blood pressure parameters are typically set by the neurology service, the vascular neurology service, and we typically use infusions of nicardipine to achieve these in our critically ill patients. So continuing with our case, so patient remains in critical condition after this mechanical thrombectomy. On day 3, the exam of the patient, pupils were equal. She was withdrawing the left side and spontaneously moving the right. Then that night, the ICU physician is called to the bedside. He finds the patient to be decerebrate and anesocoric. So the right pupil is 6 and fixed, and the left pupil is 2 and reactive. So acute neurological change. So the patient, of course, was taken for an emergent CT. And you see this is a real scan of that patient. So you see here the area of stroke is fairly large. The area of stroke is so large that it's actually creating edema that's pushing the brain to the other side, and you have this midline shift. So a shift of the midline structures to the other side of the brain. And then if you look down low, you can see, so this is the temporal lobe here. The medial temporal lobe is it's called the uncus. And the uncus is herniating. You can see it kind of pushing out and pushing on that midbrain there. So that's called uncal herniation. That's what gives you your pupil dilation on that side, because the nerve that goes to the pupil arises from in this area. So this is something called malignant cerebral edema, which happens in patients with large territory strokes, can happen in patients with large territory strokes. So typically this post-stroke period at highest risk for malignant cerebral edema is 3 to 5 days. So our patients that are 3 to 5 days, we keep a close eye on, the ones that have had large territory strokes. Many times, those that have had large territory strokes, we wait to extubate them until they're out of this period, just because we know that in this period they're at highest risk for neurological deterioration, and we want to minimize our rates of reintubation. So herniation syndromes, the ones that are relevant in this case. So uncal herniation is what this patient's exhibiting. So it's kind of the earliest form of herniation in this case. So you have this acute change in mental status, ipsilateral pupil dilation, so like a blown pupil. Contralateral weakness, which is a phenomenon called Kernahan's notch. You have pushing, I guess I can go back to the last slide to kind of illustrate this. It's easiest to do. So, oh shoot. So you have this midbrain, the corticospinal tract runs along this area of the midbrain. And if you're pushing this way, the brainstem shifts, and you have this corticospinal tract that's impacting along the tentorium, which is basically a type of leaflet of the meninges that's right here. If this cerebral crus is impacting upon that tentorial leaflet, it causes impact of the contralateral corticospinal tract, and so you get contralateral weakness. And then an ipsilateral PCA stroke, because the PCA runs along that territory as well, and you can impact that as well. Then you get central herniation, which is a later form of herniation. This is where you get your Cushing's triad. So the Cushing's triad is going to be so sudden hypertension with bradycardia, so widened pulse pressure with slowing of the heart rate. It's a reflex of the brain, initiates to try to maintain cerebral perfusion pressure. And then you have, in non-intubated patients, you can have irregular breathing. Okay, So ICP crisis in patients with malignant cerebral edema. So ways that we can decrease our ICP, maintain that cerebral perfusion pressure, which is the MAP minus the ICP, right? The mean arterial pressure minus the intracranial pressure. So in order to maintain that cerebral perfusion pressure in someone with a high ICP, we try to lower it. So easy things you can do, just at the bedside, you can elevate the head of the bed to 30 degrees. If they're intubated, you can increase their respiratory rate to try to drive down their PCO2, but keep in mind here that if you drive down their PCO2 too severely or for too long, you can actually cause worsening of their ischemia. So we typically target a PCO2 of 30 to 35 for a period of 15 to 30 minutes, but no longer than that. And then you can keep their head midline, try to make sure the patient is completely neutral, no kinking on the jugulars, no cervical, Dr. Zolman will talk about this in his trauma lecture, but no cervical collars, things like that. Hypertonic and hyperosmolar therapy is another method to decrease the ICP to maintain the CPP. So we use a lot of hypertonic saline just as a continuous drip. You can go to rates from 15 to 45 sometimes. Typically, we like to infuse this, or the regulation is to infuse this through a central line. If you don't have central access, it's okay to infuse it through a peripheral line, but only for at most 24 hours. You need central access to administer this medicine. And our goal sodium is usually 145 to 155, and we measure it every 6 hours. You can give these salt bombs, colloquially known as salt bombs, these 23% hypertonic saline, also infused through a central line. This is effective at acutely reducing ICP. It's kind of like mannitol. So mannitol requires that the patient have renal function and can produce urine because it's a diuretic. It's an osmotic diuretic. It's basically a very large sugar that takes fluid from the brain and makes the kidneys excrete it. So dosing of the mannitol is typically the easiest is to do 1 gram per kg. But you can go up to 1.5 gram per kg. And then for mannitol, you follow the serum osms, so you also get those every 6 hours, and you try to keep it below 320. And then the final kind of method to decrease refractory ICP, or one of the final methods, is to do a decompressive hemicranie. So ICP monitoring, ICP monitoring in stroke is kind of not typically practiced. ICP monitoring is reserved mostly for TBI. It's kind of a controversial, still studied thing in stroke, but we do not use ICP monitoring typically in our strokes. But there's different types of ICP monitors, which you'll see here. The most common type is going to be your EVD, the intraventricular ICP monitor, which is commonly used because you can also be therapeutic. You can also use it to drain off fluid to decrease the pressure. And then the bolt, which you can see probably would be here. This is a subarachnoid bolt. This would be the intraparenchymal bolt, which is a way to monitor ICP without that added benefit of being able to drain CSF. So decompressive hemicranie. So we do these. We consult neurosurgery for our patients with large territory strokes that have malignant cerebral edema that are not responding to the traditional therapies. Neurosurgery can take them for a hemicranie. There's been several studies done over the past few years. The Hamlet study, the Destiny study, and the Decimal study are the 3 that a lot of people refer to. Basically, a meta-analysis of these 3 studies showed that the best outcomes are achieved when the decompressive hemicranie is done 48 hours after stroke. So you can see, So the bigger the better with these decompressive hemicranies. Typically the neurosurgeon tries to achieve a dimension of 15 centimeters at the widest dimension, and then decompress all the way into the floor of the middle fossa, which you can see here. So this is a coronal view of the brain. This is the middle fossa here, which is kind of like the cup that the temporal lobe sits in. So the goal is to drill all the bone all the way down so that's kind of like flat there. And so that way the temporal lobe can swell out. The temporal lobe is what is responsible for uncal herniation. So that's the goal there. And with that, the next presenter is going to be talking about what can happen in stroke if there's hemorrhagic conversion, spontaneous intracranial hemorrhage. Hello, Dr. Emmanuel.
Thank you, Dr. Daniels. All right, so I'm going to be discussing, if you don't mind putting thank you, spontaneous intracerebral hemorrhages. I'm going to be building on what Dr. Daniels just discussed, and I will do my best not to speak at 2 times the speed so that everybody can kind of follow. All right, so I have no disclosures. My objectives are threefold. Number one, I'm going to give you an overview of how to assess these patients. Typically, the patients sometimes come in with different things. You get a CT scan, and then you notice that they have a bleed in their brain. What do you do? Well, besides consulting a neurosurgeon and bringing them my way. And also some of the early benefits of some of the assessments that can actually be done by bedside. I'll kind of give some strategies. And then at the very end, I will probably just leave this as part of the slide to kind of give an algorithmic approach, at least my approach, to managing intracranial pressure, which Dr. Daniels spent a good bit of time discussing. All right, so what's one of the first things you see here is that this is a non-contrasted axial CT scan, and you see the hyperdense sign, like Dr. Daniels mentioned. Fine, we give them TPA, we take them for mechanical thrombectomy, everything goes spectacularly, but then you get the repeat scan and you see this. That right there is showing you that there is a stroke, but within that stroke bed, you actually see bleed. The hyperdensity. This is bleed. Now, patient got TPA. There's several things that we can do depending on the timing, keep things like cryoprecipitate. But as part of the larger talk, I want to discuss what happens if a patient comes in with a different kind of stroke, which is not just the ischemic portion, but the hemorrhagic. All right, so this is a hemorrhagic stroke. This is in the basal ganglia. This is a deep bleed. And I'm going to kind of just talk a little bit about the usual suspects, which each one of them kind of have in their personality. Now we have primary etiologies, things like hypertension, for example, which is why hypertension is such an important part. But there are also aspects that we can't really change, things like having cerebral amyloid. Typically, most of the spontaneous intracranial bleeds are usually deep versus lobar. But even the way that you address these really depends on the underlying etiology, which is why doing a workup to try and understand what you're dealing with, like I said, they all have different personalities, and they all kind of have a different outcome. Now, I'm going to read every single line in this slide. I'm joking. This is really just for your benefit, but this is kind of the guidelines, some of the class 1 recommendations. All right, so how do we evaluate a patient that comes in with ICH? Well, usually the usual things. For me, the most important part that kind of separates neuro from some of the other critical care specialties is the neuro examination and the way that you kind of approach it. So for me, when I see a patient, comatose or something is going on, I look at their eyes first, because the eyes to me are the window to the soul and the brain, not the heart. That's a joke for my cardiac colleagues. All right, so we typically use most of these modalities to help us try and understand, number one, what the underlying etiology is, and that can help us kind of tailor the management of these patients. We cannot prevent the bleed, but we can do our best to minimize the damage and the secondary injury that can happen as a result. All right, so what are some things that are bad, contribute to the bad outcome? If the hematoma gets bigger, if there's more mass effect, if there's intraventricular extension, edema, inflammation, ineffective reversal of patients' underlying coagulopathy. Everybody's on either an antiplatelet or an anticoagulant these days. And then there are also some systemic things that we should not neglect if a patient has acute brain injury, things like hypoxia. Make sure that these patients are not, having fevers. A lot of the CT scans that we get is because the patient has a fever and their neuroexamination is poor. And also management of seizures. As my colleague, Dr. Wynn, will talk about, seizures do play a pretty significant role in the outcome of these patients. All right, so I'm just going to talk a little bit about how we score a bleed. Now, this is a ICH score. This is really a 30-day predictor of mortality. Now, one of the things that I do want to show you is that although you can, use a lot of the variables here, the GCS, the volume, if there's IVH, if it's, infratentorial and the patient's age as well, these scores are meant to kind of act as a guideline. They're not meant to, if a patient, for example, presents with a 5, which really correlates with 100% mortality, on day number 1, you should not be using that to tell the family, like, hey, this is a 5. In some cases, that's true, but the thing is that if you use the scores that way, it becomes a self-fulfilling prophecy. So that's the one caution I will say. Now, what can you do by bedside as a non-neurointensivist? Well, hematoma expansion. You do not want your bleed at 2 hours to go from this to this. And I'll kind of explain a little bit. We'll go through looking at the ICH scores. Now, what can I do to prevent that expansion? We know that hematoma growth is an independent contributor to patients' overall mortality and even the decrease in their function, because I don't want them to just survive. I want to make sure that they're able to do the things that they used to love or minimize the deficits. But a lot of this expansion actually occurs pretty early on. While you're waiting for that neuro-ICU bed or transfer to a neurocritical care bed is where most of the fight actually happens. So what you can really do is focus on deploying strategies to manage hematoma expansion. So what can you do? Number 1, blood pressure. Uncontrolled hypertension, we know it's a poor function. Now, there's been a lot of studies that have been done about, what the target is, how quickly you should reduce the blood pressure, and then the choice of anti-hypertensives. And also one of the other important things too is not to neglect the patient's pain, because most of these patients are going to present with headaches. So that's going to contribute to your blood pressure being difficult to manage. And then minimize blood pressure variability. For me, I love to use drips. Cardin drip is typically my favorite. These are just 2 studies, the INTERACT-2 and the ATAC-2 trial, that really were trying to figure out, what blood pressure parameters should we use, and really there was no change, there was no real difference. So there are a lot of reasons why that could happen. Is it the blood pressure itself, or is it that we need to find a range, or is there a lot of variability that we need to control, which is why I like drips, so that I kind of have a steady state rather than pushes, with the blood pressure kind of going up and down. All right, and then reversal of coagulopathy. With our patients being on NOACs, for example, you want to make sure that you are reversing these patients effectively. Now, this is a slide. It's a good slide that just kind of tells you what to do. But use your pharmacist. They are a very, very good resource so that you don't only have to know what to give, but how much. And then rapid hematoma expansion. Let's kind of go through this. So these are the components that make up the ICH score. This patient, which is the exact same patient that we talked about earlier, this shows a ICH score of really 13% for their mortality. That's not bad, relatively concerned. But look what happens 6.5 hours later, just 4.5 hours later. Look at what their score actually looks like. A 4, which is a 97. So you go from 13 to 97%. So really attacking the underlying issues that can minimize the hematoma growth is something that's very important. And I've just shown you just 2 tools, which is the blood pressure, but even with the blood pressure, how you use it and the variability. So this is just a summary slide of kind of most of what we do in the first, 12 to 24 hours or so. All right, now surgery. Of course, surgeons are going to see this, and what they want to do is we want to take it out. Now, there have been a lot of studies, and this is my summary. Surgery will save people's lives because it will remove that hematoma that's causing a lot of mass effect and everything else that comes with it. But improvement of functional outcome is not something that has been shown in a lot of the studies, except for, if the patient is in refractory ICP crisis. These are patients that will typically, die if you do not do something, which is why doing a decompressive hemicranie with or without hematoma evacuation is important. And there is a lot of studies, including like MISTI-3 studies, that are talking about, minimally invasive surgery. It sounds very, very nice, but so far really has not shown benefits. I'm not sure if this is a timing issue, if we're not just doing it ultra early, or the damage has already been done. Now, the one caveat that I will add is that for patients who have cerebellar ICH, these are patients that once you see that, certainly control their blood pressure, but the next call should be made to the neurosurgeon because there's just not a lot of room in the posterior fossa. And these patients can deteriorate pretty rapidly. All right, one of the other things too that I was going to point out is that the approach to really taking care of these patients is a collaborative, multidisciplinary, and we want you to bring it to a high volume center such as ours, where we have dedicated neurointensivists. Yes, that's a way to protect my job, and neurosurgeons as well as neurointerventionalists, but it's really a team approach to caring for these patients because the care doesn't just end with arresting the hematoma, it also continues throughout the entire process, including rehab, which is a very important part of any neurologic damaged patients. All right, so neuromonitoring. Neuromonitoring is just a way for us to get into the black box. When people say that, the skull is really thick, it's because we don't understand a lot of what's going on there. There's quite a bit with autoregulation. All right, I'm going to move through some of these slides pretty quickly because these are slides that were also shown by Dr. Daniels about what an EVD, for example, looks like, an extraventricular drain, which for me is the gold standard because it not only gives me a number for the ICP, but it also helps me do something, such as draining the CSF. And this is kind of what a ICP waveform looks like. What I want you to recall is this: if the P1 is greater than P2, your brain's compliant. P2 greater than P1, bad. That's all you need to remember. And if that's the case, someone like myself would be, to kind of help rescue that because a lot is going on. And the way that you actually manage this depends a lot on the patient's brain autoregulation. All right, so this is what it looks like, the ICP number, but you actually have to stop the cap so that you can actually transduce. And this is the waveform. Remember I told you there was a P1, P2, P3, so this is a compliant brain. All right, so signs of elevated ICP. Like I said, I always look at their eyes because if I see blown pupils, for example, that tells me that this may be a patient that may be having potential herniation syndrome. So ICP crisis for me is an emergency, and just like we do, ACLS course, to us, it's a brain code. So we actually practice these scenarios so that when it does happen, which is usually 2 or 3 a.m. in the morning for whatever reason, we can actually be effective enough. So this is my algorithm. I think Dr. Daniels kind of discussed it. For what you do, some of the interventions that nurses, even anybody by the bedside can do, things like elevating the head of bed to at least 30 degrees, making sure that, if the patient has a traumatic brain injury, for example, which my colleague would discuss, you don't tighten the C-collar too tight and there's no, way for the venous blood to be drained, and then hyperventilating these patients. Now, the thing about hyperventilation is that this is a temporary measure, because I have had patients who were sent to us who have been hyperventilated for 48 hours, and it actually becomes effective during those moments. All right, I will yield the rest of my time, and I think we will be doing questions at the end of all the talks. In case you have any questions, please begin to formulate them and put them in the chat. So next, I am going to introduce my colleague, Dr. Michael Zuhlman. He's going to be talking about traumatic brain injury.
Thank you very much. Okay. Now I push the button several times. Okay. Mike Zuhlman, I'm in the Department of Neurosurgery. I'm in the Neurosurgical Intensive Care Unit. We're going to talk about traumatic brain injury. I have no disclosures. And our objectives is to illustrate the primary and secondary mechanisms of brain injury, to highlight the value of the GCS score, Glasgow Coma score, to illustrate management strategies for severe traumatic brain injury. And we're going to start off with a case. This is an 85-year-old female with a past medical history of Alzheimer's dementia, essential hypertension, hyperlipidemia, prior stroke, who's on aspirin and Plavix, has cataracts, a pneumonia secondary to COVID, PE, and presents to our sister emergency department after witness falls without loss of consciousness. She's had fallen at least twice in the last few weeks, and the patient's family report progressive left side weakness starting 5 days prior to presentation. Bear that in mind. What would you like to know if this person comes to you? Okay, what's this? Take a guess. You bet. Perfect. So there's a couple of things to take note. One, that this bright white is the skull. And the skull is a rigid box that does not expand. And if there's increased pressure inside the brain, surrounding the brain does not like it. Not only do you have a large volume of blood here, and it's bright white, so it's acute, and it's causing pressure on this side, or the coup side, but you also have pressure on the other side, the counter coup side. There's subdural and brain compression and midline shift. That red arrow should line up right on the midline. Subdural. This is the CT scan of the case I showed you. Again, nice white skull, no evidence of fracture. But we have the blood accumulation, which is darker than in the previous one, which means that it's chronic or subacute, and then there is some subacute blood there. And we have midline shift. What was the difference between these two contrast CT scans? And we went over it. One is an acute event that needs emergent intervention. The other, our 85-year-old, depending upon our neurologic exam, may allow for deferred surgical intervention and allowing that blood to liquefy, and as opposed to having a craniotomy, she may just need a simple burr hole with a drain. Does it change management? Yes, it does. What's this? Okay. If the one was subdural, what do you think this is? Try again. Epidural. Look at the difference in shape. Now the color is the same, but it looks like these have these little points here. That's because the epidural is limited by the sutures of the skull. So you'll see definite ending of where the blood can go. The majority of these are in the temporal region, and the majority are caused by direct trauma to the skull, lacerating the middle meningeal artery. These are surgical emergencies. Yes, it's true that it can be venous as well, but the majority are arterial, and these have to be dealt with right away. And again, we have brain compression and midline shift. And there's a little hematoma on the outside of the skull, which is consistent with probably someone getting whacked there or falling. Any thoughts as to what this is? Take a shot. No pun intended. Okay, these are just great contusion. This is a frontal contusion. The majority of these are in the frontal region or in temporal parietal region. And these are just brain bruises, but these can swell.
Like from a football injury?
Possibly. And this is, as you rightly pointed out before, a subarachnoid. This is a traumatic subarachnoid. Much different from a aneurysmal subarachnoid. Primary injury. The mechanical injury at the time of trauma. Get whacked in the head. That's it. Different mechanisms of injury. You can have acceleration or deceleration injuries, like motor vehicle accidents or falls. You have crush injuries, rotational falls, rotational or falls, projectiles, diffuse injury, such as a subarachnoid hemorrhage, more so a more pronounced than the one we saw. Diffuse axonal injury, and their focal lesion, the epidural subdural hematomas and the cerebral contusions. Wear your helmets. Wear your seatbelts. Prevention is the primary way to avoid impact of primary brain injury. Okay, now we've fallen because we weren't wearing our helmet. Now what are we going to do? Now we have to worry about secondary brain injury. This is the physiologic response caused by the initial insult, which is resulting in decreased cerebral blood flow. There are different mechanisms of injury. There's hypoxia ischemia, which immediate post-injury resuscitation, including systemic hypotension and hypoxia, which I'll talk about later. Intracranial hypertension, which you've heard about from my colleagues. Cerebral blood flow disorder regulation, likewise. It can be diffuse or focal. And there's cerebral inflammation and cerebral edema. Impaired cerebral metabolism due to cellular and mitochondrial injury. And these are more biochemical dysregulation secondary to rupture of the blood-brain barrier, increasing in excitatory amino acids, neurotransmitters, and so on. The first thing, ATLS, airway, breathing, circulation, and disability. What is our Glasgow Coma Scale? What is our neurologic exam? What brain systemic imaging do we need or do we have? And do we manage them locally or do we get them out of Dodge and send them to a level 1 center? Okay, Glasgow Coma Scale. I'm sure that all of you have heard of this, but it's really worth going through. So in 1974, Drs. Teasdale and Genet at the University of Glasgow needed an objective manner in which they could assess consciousness. And so they came up with the Glasgow Coma Scale. And there's 3 parameters that they looked at. They look at eyes, and verbal, and motor. And they assigned a score to various responses that they could elicit or not elicit. And they came up with point totals that are 15 is the best you can do, and 3 is the worst. I don't think they had the heart to give people 0, so they gave them a 3. So the mild injury is 14 to 15, moderate 9 to 13, and severe is 3 to 8. The initial assessment, you should use a Glasgow Coma Scale because it gives you an idea of what's going on. But after you resuscitate the patient, redo your Glasgow evaluation because if someone's hypotensive, this may not be accurate. The other major benefit is that it gives a language that all of us can understand. So when you're transferring the patient or signing out, you can give the referring hospital or you can give your colleague a number that they can wrap their head around, so to speak. But for me, the most important thing about this is that you can say, you can quantify a change in status. The person you got on the trauma bay at 6 o'clock was GCS 12, and at 8:15, they are a 4. That doesn't take you got my attention. Likewise, if you're picking up the phone to transfer a patient, and it doesn't have to be done for trauma, It could be an ischemic stroke, intracerebral hemorrhage. The idea was to have an objective monitor or get objective measurement of consciousness. And that's what the beauty of the Glasgow Coma Scale. And it's been vetted over the years and is used in other neurologic assessments. So it's a really good tool to have. Prevention of secondary injury. Again, you've heard it from my colleagues, elevate the head of the bed to 30 degrees. You can always elevate the head of the bed to 30 degrees. Person has a cervical collar on. Just like you want to rotate the pregnant woman to get her fetus off her IVC so you get venous return, you can elevate the entire bed. And this increases the venous drainage and avoid overly tightened seat collars. I should have mentioned, and I didn't mention it, if someone comes to with a head injury, please get a cervical spine as well. You can do it while you're there. It's not major league taxing. And the best way to test for the cervical collar is if you can fit 2 fingers in, then it's tight enough. You don't want to be garroting your patient, but by the same token, you don't want their neck flopping up and down. Decrease intracranial pressure, cerebral edema, brain compression, and herniation. The tools that we use were just described. You can use your mannitol, 0.5 to 1 gram per kilo. You can use hypertonic saline, either the sodium bomb or 3% or 23%. Your target is 155 serum and a serum osmolarity of 320. No corticosteroids, none. They have no value. Okay, this is the most important one. Prevent hypotension. The previous recommended blood pressures were greater than 90, but now there's significant evidence that reduces morbidity and mortality of blood pressures that are greater than 100 to 100 millimeters of mercury. One more time. Prevent hypotension, prevent hypotension. Again, prevent hypoxia. Maintain your PaO2 greater than 60 or SaO2 greater than 90%. Hypoxia has shown to increase mortality and increase morbidity. These are items that you can easily avoid. Please do so. And it doesn't matter where you are. It could be in Fallujah, it could be at Bagram Air Force Base, it could be on Alcac 7. Easy to do. And hyperosmolar therapy. Mannitol and hypertonic saline. Prevention of secondary brain injury. Seizure prophylaxis, typically for 7 days, usually with phentoin or Keppra. My colleague, Dr. Wynn, will talk about this in detail shortly. Euthermia. Maintain the patient's blood temperature within normal limits. You want to minimize the metabolic energy that the brain has to do. And this is new to me as well. So attain basal caloric replacement by at least day 5 to 7 post-traumatic brain injury. It has been associated with decreased mortality. And early surgical intervention if warranted. This is our patient who, in fact, required a craniotomy, but you can see, well, sorry about that, that the septum pellucidum right here moved closer to the midline. And although there's some residual blood there, that craniotomy did its job. In conclusion, resuscitative measures and management in level 1 trauma center is vital. GCS score is predictive. Lower scores have higher probability of poor outcomes. ICP management is an important aspect of minimizing secondary injury. This being said, you need a ventricular drain or you need a bolt in place. But if you maintain your blood pressures, you optimize these. And I have references, just that I didn't make this stuff up, and that if you want to read it, you can on your own time. Our patient, unfortunately, calm down. Our patient, even though we did exactly what I said, went to the operating room, had a successful evacuation of her subdural, GCS score declined. And we really couldn't have explained why. So the suspicion was that she went into status. And with that, Dr. Wayne.
All right, thank you, Dr. Zolman, for that. So if we can just have the status slides up. Okay, so I am An Nguyen. I'm one of the critical care fellow attendings here, the fellowship director here. So I have no disclosures. So talking about status, though, you actually have to go through some definitions. Some of it's a little dry at first, so bear with me. So a seizure, so everyone knows what a seizure is, but if someone were to ask you to actually describe it, it's a little bit harder. So a seizure is just a sign or symptom that occurs because you have excessive neuronal activity. So you think about it, if you were to throw, let's say, 10 coins up in the air, normally you would expect maybe 5 to land one way, 5 to land the other way. So 5 heads, 5 tails, something like that. So you think about it, that's kind of how your brain's supposed to work. If all of a sudden you're throwing 10 coins up and all of a sudden they're all 10 heads, there's something wrong. So that's exactly what a seizure is, though. When your brain cells, your neurons, they are hypersynchronous and they're not supposed to be. So that's the definition of a seizure. Then what is the definition of status? So this is actually the most useful definition. So convulsive status, convulsive means they're having some kind of generalized movements that you can see. So this is defined as having seizures that last at least 5 minutes, or having 2 seizures that you don't recover between them. So this was coined by Dr. Lowenstein back in 1999. So before that, the reason why it's important to credit him for this is, before that, the International League Against Epilepsy, they defined it as, and I quote, "a condition characterized by an epileptic seizure that's sufficiently prolonged or repeated as to produce an enduring epileptic condition." I have no idea what that means. And no one really does, right? So clinically, 5 minutes as a seizure lasting, or 2 seizures without regaining consciousness between the 2. So if you have convulsive status, then of course you're gonna have non-convulsive status as well. So for non-convulsive status, the only way that you're gonna be able to recognize this is of course with a continuous EEG or having EEG monitoring on. And we'll actually touch base a little bit, and by the end of this, at least you'll be able to recognize some of the EEG patterns and what it actually means. So we'll try to demystify it, if you will. So this is an ICU lecture, not a neurology lecture, but I just wanted to point out there's different types of non-convulsive status. So simple, complex, absence, de novo absence, secondary generalized. The interesting thing here, though, is when we hear about absence seizures, so this is usually the child in elementary, 2nd, 3rd grade that doesn't pay attention in class so much and that stares off the wall and gets sent to a pediatric neurologist. They work the child up and they find that all this time he or she's actually having seizures. So that's the absence part. The de novo absence is actually found in adults. And the reason I want to spend a little time on this is, so when I was a fellow during my epilepsy year, we actually diagnosed a patient with de novo absence, and he was a pilot. As it turned out, he kept getting lost driving to and fro work, never on the airplane, at least what we were told, but we couldn't figure out why. They did all kinds of work up, and they sent him to us, and we monitored him in the epilepsy monitoring unit, and sure enough, he had absence status. So this slide seems very simple, but if we're able to understand this slide, this is basically all we need to know about seizures and their treatments as well. So I mentioned during the first slide, seizures, it's nothing but hypersynchrony of your neurons. So you can imagine on the left side here, so the EPSP, that stands for excitatory postsynaptic potentials. So something that would excite the membrane, excite the neurons, whether that be sodium influx, calcium influx, these things will actually lead to a seizure. And then conversely, on the other side, chloride going in, influx into the cells, low pH. So this is how you actually treat seizures then. So we see how seizures can be started, and then how our mechanisms, how we can actually control these seizures. So we talked a little bit already about the convulsive and non-convulsive status. In our ICUs, and actually I shouldn't say just our ICUs, it turns out they did studies in the medical ICU as well. The seizures that are found in the ICUs, actually about 90% of them are non-convulsive. So again, it goes back to the importance of having an EEG on these patients. And a couple other terminology. So we define seizure, we define status, so there's something called refractory status as well. So this is a status patient that's not responding to first-line benzodiazepine and a second-line agent, which we'll talk about in a second. And there's actually also something called super refractory status. So again, this is everything from above that hasn't responded, of course, and then the patient's requiring anesthetic agents like Versed, propofol, etc. So in terms of the workup, for evaluating all the patients, it starts off the same. So of course you want to make sure your ABCs are taken care of just like anything else. And at the bedside, you want to make sure the patient's not hypoglycemic. Hyperglycemia can rarely cause seizures as well, but generally it's going to be hypoglycemia. So important things that you can quickly correct first. So make sure that's done. And then in most cases, you should get some kind of brain imaging. So of course, if a patient, for instance, comes in and has a known history of seizures and has a known history of non-compliance as well, you may be able to skip this, the imaging part, but for most patients, if you don't know the history, they need some form of imaging. Of course, your basic lab tests as well. And then, depending on the clinical situation, do you need to proceed with an MRI, with a lumbar puncture and those things? And at this point, you should really have your neurology colleagues involved as well. I wanted to make a point with the MRIs next to this. So A and B, the difference in terms of A and B is when we're doing MRIs, what we want to see is, hey, is there any abnormal enhancement? So for a seizure patient, if you're working this up, it's a new onset seizure that you're really working up, you ought to do the MRI before the lumbar puncture. The reason is because, as you can see in B, this right here, the pachymeningeal enhancement here, you can get that, yes, if someone has some kind of underlying inflammatory infectious process, or as a result of hypotension resulting from a lumbar puncture. So if you can, try to do the image before the lumbar puncture. And then these are just other labs that you would do as well. So we're gonna try to make this a little interactive. So this is a gimme, okay? So what is more concerning? A patient with a generalized tonic-clonic seizure, or do you think a patient with a focal seizure that generalizes and then, of course, has secondary generalization? So it was on the previous slide, and I didn't mention it on purpose. Yeah, so very good. Of course, it's B, because when you have a generalized seizure, the causes could be anything, metabolic, hypoglycemia. But if you have a focal seizure, you can imagine there's probably a lesion or something in the brain that's going wrong, and that's why you're seizing from that area. You have the focal manifestations, and then generalize from that. So very good. I wanted to just add one slide about NORSE evaluation. So NORSE stands for New Onset Refractory Status Epilepticus. So in the past maybe 8 to 10 years, it's gotten a lot of media attention as well. So these are the patients, for instance, back maybe 10, 15 years ago. You would think they're young, 20s, 30s, and they've been normal their whole life. And then all of a sudden they have issues with psychosis, they have issues with concentration, and they just can't function anymore. And a lot of these patients, unfortunately, get treated as a psychiatric patient. They even get admitted sometimes as well. And so what it turns out is they have encephalitis. And I'm not saying that every psych patient needs a workup for this, but in the history, if they have been normal their whole life, no issues, nothing that would concern you, and all of a sudden there's a behavioral change, make sure this is in your differential. And again, a lot of times the seizures, it may not just be generalized, it may not be convulsive, I should say, it could be just non-convulsive as well. So to work this up, a lot of times they have underlying malignancy that we don't know about yet. So that's why the CT chest, abdomen, pelvis, of course, in males, you look for the testicular ultrasound or ovarian ultrasound with females to make sure there's not a teratoma. As it turns out, when I was a resident, one of our Texans players, and this was all over the Chronicle, but he was actually diagnosed with NMDA encephalitis in the medical center. And with treatment, with steroids, with other physical therapy, those things, he was actually back to playing after 2 years off in the NFL. So that was a very good story for that. In terms of treatment for status epilepticus, then, the treatment goal, of course, is to stop the seizures, and you want to do it as soon as possible. The idea here is, while you're working up the A, B, and C's to make sure everything's secured, you want to abort the seizures with medications. As the seizures actually start and last longer, it's going to be harder actually to stop. It's like a ball or a snowball going down. If you stop it early, there's a better chance of it stopping before it builds up momentum. And in terms of first-line therapy, we kind of talked about a couple slides ago, but it's going to be benzodiazepines. So it's going to be Versed that you can use IV or IM. You can use Valium sometimes as well. So what I find interesting, so it's 2022 now, so just a little more than 20 years ago, there was actually a trial, a randomized double-blinded trial to assess whether benzos were actually the right thing to do for patients with seizures. I know we look at that and we say, of course it is, right? But this, the pre-hospital treatment for status epilepticus trial was done in San Francisco. And what they did was actually, it was saline versus benzos. And what do you think the results of that is, right? But it's just amazing that seizures have been around so long, but it was just 20 years ago. We didn't know what the right thing really was to do. Furthermore, the Rampart trial just kind of showed that IM Versed was just as useful as IV formulations. And really the reason here is some patients are just difficult IVs to get, and so you can try IM as well. In general, we try not to do diazepam so much. The reason for that, it works great, but it's very, very fat soluble, meaning that it gets into your body very quick. It'll stop the seizure, but it'll diffuse right out as well. And one thing, if you're going to take anything from this slide, is if you're going to treat seizures, be very aggressive with it. Most studies actually show that it's underdosing of benzodiazepines that get you more in trouble than overdosing. So, of course, everyone's concerned when there's not a secured airway. When we give benzos, what happens is you cause respiratory depression, but it's actually underdosing that gets you into issues. So then after adequate benzos, and it's usually 0.1 mg per kg, up to about 4 milligrams, what is the second line AED? So is it A, Keppra, B, fosphenytoin or phenytoin, C, valproic acid, or D, any of the above? So it's kind of split between the first two. So this is actually interesting. There was a trial done maybe 2.5 years ago, it was published, that served to answer this question, because back when I was in training, the first line was going to be fosphenytoin that we would use, or valproic acid, and Keppra was kind of shunned upon. But let me see if I can forward the slide. Okay. So the trial that was done about 2.5 years ago is called the ESET trial, and they looked exactly at that. So once we given enough benzos, what do we give? So they looked at fosphenytoin, valproic acid, and Keppra. The doses used in the trial were pretty significant. For fosphenytoin, it was 20 mg per kg. For valproic acid, 40 mg a kg, 40 milligrams per kilogram. And for Keppra, it was actually 60 milligrams per kilogram. So pretty high doses. I think the Keppra was up to 4.5 grams. When they looked at this, all were equivocal. So from now, you just pick one of the three, it should be good enough after your benzos. The reason we use fosphenytoin over phenytoin is you can actually give it faster without concern of hypotension, without concerns of limb infiltration as well, which has happened, unfortunately, in the past. And all patients that receive second-line therapy, if the seizure, even though the seizure aborts, should be on some kind of maintenance as well after the initial load. I know that's a no-brainer, but it's really important to stress as well. So this is just the ESET trial, which I touched upon. And then third-line therapy. So this is refractory status that we're dealing with. So this is where we're talking about Versed, propofol, so drips. So patients should be intubated or have their airways secured at this point. And really, all of them are equivocal. You just choose them based on side effects. So if a patient's already hypotensive, maybe propofol is not your best agent. Maybe Versed would be a better option for that case. Or if you think a patient will likely get out of this status situation because he or she was just non-compliant with his or her medications, maybe propofol would be a better choice. When you turn it off, they should be okay after the original AEDs have been enough in their system. And of course, when we're doing this, EEG monitoring should be in place already. And this is super refractory. So when we get to super refractory, of course, the neurology team should be helping us already throughout this, but you can use both Versed, both propofol. You can sometimes use the barbiturates as well, ketamine as well. So on the right side, what's interesting is I mentioned that first initial slide where you have the balance between seizures and basically not seizures. So you can try ketogenic diet to basically decrease the pH. You can have vagal nerve stimulators, of course, epilepsy surgery as well. And this question is going to be a little bit tricky, but let's see if we can do it. What is this EEG pattern that you can see? Let me see if I can go back a little bit. To show the EEG pattern. There we go. So what is this EEG pattern? And here are our choices. So is it status epilepticus? Is it EKG artifact? Is it muscle or EMG artifact? Or do you think those could be psychogenic or pseudo-seizures there? Yeah, so, so everyone chose psychogenic or pseudo-seizures. So it's good that we recognize it's not true seizures, okay? But in this case, it was actually just artifact. And I told you that we're going to look into EEGs a little bit. And this isn't a fellowship, so this isn't a fellowship, so we won't go through the whole thing, but just a brief idea, okay? So this is your EEG primer, if you will. So when we're doing this, if you remember that the odd numbers are on the left side of your brain, and the even numbers are on the right side. So FP stands for frontal polar, F7 is frontal, but it's really anterior temporal, and then T3 is your temporal, mid-temporal, T5 is posterior temporal. So that's the basic take-home from that, and this is actually one of our EEGs placed looking down. So you can kind of see here, so all the odd numbers on the left side, if you're looking down, all the evens on the right side. So all this, what you're doing with an EEG, there's nothing fancy. You're just taking one area and comparing it to the next. So the voltage between one to the next one. And with this, you can make different montages or different ways to connect the different EEGs. Out of really the most common way that people do this is something called a double banana montage. You can kind of follow the pointer here. You can see one banana and then the other banana here. And I'll show you what that means. So on the right here, this is actually the one that if you look at most EEGs here, you can kind of see this, okay? And this is what it's on there as default already. People generally don't change this. So then understanding that, so EEGs, you can have different types of morphology. You can have spikes, you can have polyspikes, and I won't go through the rest. But the idea is nothing in your body in terms of neurons can be that fast from that EEG that I showed you. That is for sure artifact. And as it turns out, we'll just skip this part, most of EEG, about 85% of the EEG is actually artifact. You have to actually tease out what's important. So let's see if we can try a few, and this we'll just kind of go over together. So of course, this is the left side, the right side, left side, right side. Where do we think the seizure is? So is it left or right? So it's actually this right here, correct? This pattern you see here? So this is right, it's even. So this is maximally, it's occurring where T4 is, so that's temporal. So this is a focal seizure that you see here. So, and then you kind of see this kind of everywhere, right? So this is a generalized seizure, is what you're looking at. And then people have thrown out the term burst suppression as well, and this is kind of what it looks like. So you have your burst of activity, and then you see this flattening, so that's what burst suppression really means, okay? I want to spend just the next 2 or 3 minutes just talking about seizure prophylaxis in terms of cases where we actually use seizure medications, even if they didn't have a seizure. So, for instance, I think Dr. Zolman talked about this, but for TBI patients, there's decent data that we ought to use seizure prophylaxis. What was actually studied was actually Dilantin and was done by Dr. Tenpin back in 1990. Now with Keppra being used, and it's a little bit less toxic as well. Most places have used Keppra over Dilantin, and there's some studies to back that up. But it's done just for 7 days. The idea is if we do it longer, patients may actually do worse. If they're gonna have a seizure, they're gonna have it early on. So for TBI patients, subdural, the contusions, epidurals that Dr. Zolman showed you, you should be on seizure prophylaxis even if you didn't have a seizure at the onset. In terms of subarachnoids, so this is aneurysmal subarachnoids I'm speaking about. So this is a little bit more controversial. As it turns out, half of the country probably says that you don't need seizure prophylaxis at all. And then the other half would say, you know, if you need it, just early on. At Methodist, our practice is to do it 7 days. But if you were to poll the country, even the people that say you need seizure prophylaxis, either they do it for 3 days or 7. So that's a little bit up in the air still. And then I didn't have a slide on this here, but in terms of intracranial hemorrhages, so the hemorrhages that Dr. Emanuel and Dr. Daniels were alluding to, generally there's no data to say that you should prophylax these patients with seizure medications. And with that, the status talk is complete, and we'll have some time for questions.
So thank you. Thank you to my colleagues for the talks that they gave. These are kind of the bread and butter things that we deal with in the neuro ICU pretty much day in, day out. Let's have some questions. Will I be getting the questions on this? Yeah, go ahead.
I have one, and I'm not sure who it goes to, but do you use any hypothermia any today? That, because we used to, right?
So, go ahead, Michael.
Okay, so in the Eurotherm trauma, the Eurotherm study was for trauma, for head trauma, was stopped early for futility. Now, while it is true, and we have seen it here, that hypothermia will decrease ICP, that the 6-month mortality is unchanged. So to answer your question, no.
Yeah, we still use that for cardiac arrest patients. But as far as neuroprotective, I think when I was a resident, I was very excited about that, and I pretty much put everybody on hypothermia because it was wonderful to know that I could cool somebody down to 33 degrees and still keep them alive. But unfortunately, there's not much benefit yet. Go ahead.
For the TPA many years ago, age was usually an exclusionary criteria, but lately I've been seeing it's been given to anyone, and if it was given to, I will just put a number out there, over 70 or maybe 80. And if it's given to them, have you seen a lot of complications like rebleeding from the TPA for our elderly patients?
Would anyone from the panel like to take this before I jump in?
Yeah, so before, you're right, there was an age cutoff in the original NINDS trial, but there's newer trials actually that tell us if you're over 80, and there's some criteria with that as well. For instance, if you're on some kind of anticoagulant, no matter the INR, you're not eligible anymore. But based on the new trials, there's actually benefit, and that's why we've been doing that though.
Yeah, and to add to that, we've actually, I think it was a 97-year-old that we gave TPA to, and yes, really, if the patient's functional status coming in, TPA is effective, and I have not noticed that there's any additional complications like bleeds, for example, in those older patients. I think it's really about the underlying condition. And that particular patient, I think they did well.
Yeah, and that trial, it's called the ECAS-3 trial.
Well, related to that, so many people now are on Eliquis and all these different types of medications. And I know you had, the exclusion rate. Can those, you don't always know all the meds people are on when they come into the hospital. Can they still have that for like an acute stroke? Still have TPA for an acute stroke?
So oral anticoagulants are a contraindication, one of the exclusion criteria. We typically get things like INR or the Eliquis level, like with the anti-10A level, just to inform our decision in cases where we don't know whether, a person has taken Eliquis. Also, the timing of the Eliquis matters.
I mean, just Eliquis, Plavix, all,
Right, yeah. Also, the timing of when the medication was taken, whether it was taken that morning or the previous evening matters. But typically, we get things like the anti-10A, the P2Y12 for the Plavix.
Yeah, so Plavix isn't a contraindication itself, but no. So aspirin, Plavix is free range, but when we talk about anticoagulants, of course, your warfarin and then your DOACs, right? Unfortunately, at this time, it's still just based on history. When the last dose was taken would guide us.
And you can have aspirin.
Yes, aspirin or Plavix, that's fine. There's no contraindication for that.
All right, so we have a question from some of our virtual participants. I think this one is for Dr. Nguyen, but anyone can jump in. The question is, what are the most efficient way to detect pseudo and non-convulsive status epilepticus in critically ill patients?
So I think this just comes with just the clinical exam as well. So for instance, if the patient is in the ICU and you feel that their exams is out of proportion to what they came in with. For instance, the patient came in with, let's say, DKA. The gap is closed, they are getting better, numbers-wise, but for some reason, they're just not responding from a neurologic standpoint. From those patients, I would just have a low threshold to order an EEG. And unfortunately, as I mentioned, with non-convulsive seizures, the only way you would know is with an EEG.
So to add to that, the caveat is you certainly want to do an EEG, but most of the time the spot EEGs that we do are for 30, 45 minutes. And if those are the period of times that your patient is not seizing, you may not actually capture it. So for us, if we're going to put a patient on EEG, we do it for at least 24 hours. Any other additional questions?
Thank you all. We appreciate it.
Our pleasure. Thank you.
Hi, good afternoon. We are moving on to our very exciting second breakout session with Dr. Malik. Dr. Malik is an associate professor of medicine and medical ethics at Baylor College of Medicine Center for Medical Ethics and Health Policy, and she's a clinical ethicist at Houston Methodist Hospital. She earned her PhD in philosophy and bioethics from Rice University in 2004 and now teaches healthcare ethics and professionalism for medical students, residents, and faculty. Dr. Malik also conducts research on the implementation of genomic sequencing into clinical practice and serves as an ethics consultant at Houston Methodist, a national leader in clinical ethics consultation practice and training. She serves on the ASBH's Core Competencies 3rd Edition Task Force and is the past chair of the Board of Directors of the Academy of Professionalism in Healthcare. Her research focuses on issues related to clinical ethics, genomic and reproductive ethics, and professional education. Please welcome Dr. Janet Malik.
Thank you very much, Dr. Dalla, for the opportunity to be here today. So my plan for this session was to really make it more of a conversation. My approach is always, the least I talk, the more successful the session has been. As you heard, my training is in philosophy, and I think that is really one of the most interesting pieces of this whole puzzle, is just being able to have a dialogue back and forth about the ideas and thoughts. So for those of you who are here, thank you for being in person, and please feel free to jump in as much as possible. I believe we were also going to have the ability for those of you who are at home to answer and jump in by iPad. So virtually, so I have the iPad here, and please feel free to jump in, okay? All right, let me see. Oh, that's what I'm looking for. All right, so our plan for the next hour and a half is that by the end of this session, you will have a better sense of sort of why effective communication is important in an intensive care setting, have some kind of big overarching general strategies for how these kinds of conversations can go better. And then finally, we're going to spend the second half of the session talking about really specific guidance, specific words and language that we can use to help make these conversations go better. All right, so what's at stake? Why is communication, obviously communication with patients and families is always important, but why is it particularly relevant in the ICU setting? One thing to note is that a lot of, I've put some data in here from various studies that have been done, and the vast majority of data has not been done with patients in the ICU setting, obviously because a lot of patients are sedated and not able to participate, but there's almost no data out there referring to actual patient experiences in the ICU that I was able to find, at least with respect to communication. So a lot of times we're going to be talking about families here, but just try to keep in the back of your mind that if the patient is able to participate, we obviously want them to be engaged in these conversations as well. So what's at stake with good communication? Have you had any experiences where you've seen particularly good communication, and what have been the results, and or particularly bad communication? And you have seen both? Okay, are there any examples that come to mind?
I'll never forget, years ago, this is, I don't know why I'm smiling, a physician was telling a family someone had passed away and never used the word that they had died. They just kept going, I'm so sorry. That was the communication, and I had to interpret what that meant to them, because
Yeah, so
that's an example of bad. And then I think we see a lot of really effective communication with our palliative care team with patients and families. But
Great.
still, some people, their perception is they don't like the approach because they don't like the message.
Right, it's hard for clinicians to go in and tell somebody that a patient has died, and they say a lot of things oftentimes that mean that to them, but the family might not realize that. We're going to talk about a lot of examples of that later. Great. Okay, very good. And for those of you who are virtual, the comment was that palliative care often does a really nice job of having these conversations. Any other examples or reflections?
I guess I'll say one more thing. I think one of our challenges is the conflicting communication. So we're maybe a consultant. Sorry, like a consultant might come in and say the patient may be not awake at all and not sedated and not doing well, but a service might come in, like let's say renal, and say, well, they're doing better because their creatinine dropped some, or when we talk about one particular focus of their condition and not look at it holistically and give false hope. And that those conflicting communication it's confusing for us. I'm a nurse, but clearly it's confusing with the family, and they have typically are going to connect with the person that has the best message, meaning the most positive message.
Yes, that's absolutely right. Very good. Any other thoughts? So I think, intuitively, we've all seen anecdotes of families who have had a hard time making decisions because they didn't get clear information, or cases in which they've had a hard time making decisions because they were just not prepared for the type of information they were getting or the way that it was explained. We also know that good patient care requires good communication. You can't have good informed consent, good decision making without good communication. So those are a couple basic sort of clear pieces, but we also have some good evidence that even well after leaving the ICU, good communication can make a huge difference in terms of how families continue to process and how they continue to grieve. So this is a relatively new study that said, I think this happened maybe 9 months after discharge from, or after a patient died in the ICU. They interviewed these families and found that long, complicated grief was often associated with unsatisfactory communication. And this was another study that was done in 2007, but published in the New England Journal, basically saying that they found, again, this was I think 6 months after the patient had died in the ICU, finding still higher levels of anxiety and depression when good communication didn't happen in the ICU. So there's there's also a related set of data about PTSD and surrogate decision making and how there are very many long-term effects related to having to make those kinds of decisions, especially about end-of-life situations in an ICU. And here, I think these are similarly related ideas about anxiety, depression, potentially post-traumatic stress disorder. So here's that chart. You can see here the size effects and the p-values are pretty significant in terms of the whole scale as well as individual anxiety and depression scales. All right, so let's think a little bit about the big picture. How do we set ourselves up for success to have these kinds of conversations, this communication go well? There was a study that talked a little bit about what families say they needed. And again, here we didn't talk to patients in this situation, they just talked to the families. But I thought this is pretty informative. So talking to the same nurse every day, talking to the doctor every day. Farther down here, you'll see to receive information about the patient once a day. So they're really saying we need regular contact. And I think that, at least in my experience at Methodist, is in line with what most of the clinicians do. One potential challenge with that is if there is a need for a translator or an interpreter, sometimes that communication can fall down. So we really want to make sure that even when communication can be challenging, we see here that this is really important to families to get that regular communication. Here, again, we'll talk about this a little bit later, but to be honest and open about the possibility of a patient's death and to be clear about that early on is something that families explicitly said was important to them. Of course, to be called at home about changes in the patient's condition, I think that's pretty standard. This idea about knowing which staff members could give which type of information. I've had lots of conversations with families where they talk to the bedside nurse on a regular basis, and they are so grateful for those daily updates. But sometimes they don't know when they should be talking to which members of the team, right? In the ICU setting, there's so many members of the team. How do they know which one they should be talking to? And so to be very clear about that. When we do, family meetings and things, we go around and introduce ourselves and try to make sure that the families understand there are so many names and so many doctors calling, and when you get that phone call, right, the first thing you're not writing down is the name of the doctor. You're thinking, what do they have to tell me? So it's easy for families and patients to get confused about who is playing which role. And so they noted here that they really want that sort of information. All right, so just a couple of broad strategies. First of all, I think it is incredibly important to plan ahead. when you're planning for a conversation. Now, I understand that in many situations, you sort of have an accidental run-in with the family or the patient. You walk into the room or just happen to be in the hallway and run in. So you can't always plan ahead, but for the most part, if you know you're going to have a conversation with a patient or family, make sure you have your ducks in a row before doing that. So make sure to have the relevant information. I walked into a family meeting one time where the intensivist came in and sat down and started saying something about I think the patient's neurologic status or something, and they were like, I don't think you're talking about my mother. And she realized that that was not the correct patient, which undermined trust dramatically, right? How are you going to recover from that? So make sure to have all of the relevant information and have the correct patient in mind. As you already noted, communication with other team members before going in and talk to a family to make sure that everybody is on the same page can be incredibly important to prevent those sort of conflicting information. Keeping the big picture in mind is one thing that I think is sometimes challenging in the critical care setting, because you do focus so much on the individual numbers, right? Oh, like the creatinine's better. Oh, we turned down the settings on the ventilator. This is good. One part of our regular family meeting protocol, especially with our ECMO patients, and we'll talk a little bit more about that later, is to try to set benchmarks for the next meeting, which will happen like a week or 2 weeks later, to say what are the numbers, and what are we looking for that will let us know that we are over time improving, rather than just the individual like clinical values day to day. So always trying to keep that in mind and making sure that the messaging about the individual day's progress is consistent with that big picture. Knowing your message ahead of time. What is it that you want to communicate? Sort of about the prognosis, about the options that are available. Just don't walk in and just kind of find yourself in the middle. And then when you start winging things, that's often when the conversation kind of unravels. So knowing what you intend to say and what you intend to communicate before you go in there is very important. I always, if at all possible, and I know in a clinical setting this isn't always possible, but to ask the family or the patient, if they're there, if this is a good time. It really shows respect for them. And if it's not a good time, you need to know that, right? Effective communication can be really difficult if it's not the right time for a patient or family. If possible, try to ask them if this is a good time to have a conversation or give an update. And finally, asking if there are others who need to participate, whether it's the family or the patient. The patient may have, want their loved ones to be there if they're going to get bad news or get any news at all, or they might trust somebody else in their family to be the one who's kind of tracking these, any decisions, the information about how they're doing. So we want to make sure we're considerate and include whoever needs to be included in those conversations. All of these are certainly true for sort of like big major updates for any family meetings that you might have. However, I think it's a good rule of thumb, pretty much any time there's going to be a conversation, to do the best that you can to try to meet these goals. Okay, so planning ahead, one big piece of the puzzle. Another big piece of the puzzle is the importance of listening. Obviously, as we know, communication is a two-way street. There's several different studies, this is a fairly recent one, to show that physicians interrupt patients after an average of 11 seconds in an outpatient setting. So they might say, what brings you in here today? And it's only 11 seconds until they start jumping in and asking questions. So it seems like an obvious thing to say, but again, in the daily grind of being in the ICU in that setting, sometimes it's easy to kind of forget the importance of listening. This is just a reminder, I'm sure many of you are familiar with this idea, but the importance of active listening. It doesn't mean just being quiet and letting somebody else talk. It is an active process. So hearing what somebody else has to say and understanding that, asking questions if you don't understand, Evaluating, so kind of analyzing what they're having to say and connecting it with other pieces of information that you have. Remembering the information sounds obvious, but it's a very important part of active listening. And then finally, responding. Usually people, when they're having a conversation, they're more concerned about what is the next thing I'm going to say than hearing what that person is trying to say to you. So as a clinical ethics consultant, I think that is one of the things that I do most actively and probably solves the most problems in clinical, when there's conflicts, is going in and just really listening to the patient or family, whatever they have going on. When I can really understand where they're coming from, almost half the time that solves the problem, right? Just coming back to the clinical team and saying, this is what they're concerned about and this is why. And then that helps us to find a compromise, something that will work for everybody. All right. Another very sort of consensus area of guidance is to use some sort of framework. There's not one clear framework. I'm going to give one that has been recommended by some literature. But basically this SCCM guideline that came out a few years ago, they make a lot of different recommendations, but the one related to communication that has the highest level of confidence, or one of the highest levels of confidence in their recommendation, is the importance of using structured approaches to communication. So as I said, there's several different versions of that. The one that is recommended in this sort of seminal article by Lautrette in the New England Journal of Medicine says talk about using the value framework. So valuing and appreciating what family members say. What are some examples of this? How are some ways that you might talk to patients or families and make sure that you're valuing and appreciating what they're saying? Do you have any sort of stock phrases that you tend to use?
Are you asking about scenarios like that, or are you talking about actually the words we use?
I was actually asking about the words you use. Like, what would you say in the course of a conversation?
Things that I'm an intensivist, and I've worked in intensive care medicine for 30+ years. And one of the biggest problems I find is for myself when talking to patients is when there are multiple family members and most of them are understanding, but one is not. And you can tell that, and you have limited amount of time to discuss. So sometimes I found myself in a situation where there was one family member that was just not ready for hearing anything. They were like, let's just keep going. And the patient was not going to make it, and the patient didn't. So, the best way I found was to tell the other person who was very dominant that I understand that you agree with me, but I have somebody that doesn't, and it would be important for them to understand. So that's just one example of where, but it was still very difficult because all of the other family members was, but I'm telling you, I have the power of attorney.
Mm-hmm.
So that's something that's very recent that came to my mind.
Mm-hmm. Great, thank you. Other ideas?
If they are really distraught, before I even say something, I can just acknowledge that, I'm just gonna come in the room, and then if I'm looking for hints that I can say something, then I will say something, not to push my agenda, but I can offer that I am here, I'm the charge nurse. If you're ready to talk to me, just let me know. And then I'll wait for their response.
Yeah, great. So open the door and say, I'm here for you. I want to hear what you have to say. Yeah, great. Good. I think other ways that we can sort of show family members that we're sort of appreciating what they have to say is just to be explicit about it, right? To say, thank you for sharing that, or that must be hard to put that out there. I appreciate that. Other ways that we do that is to sort of summarize. So say, what I hear you saying is that your mother, was a really active person and this is important to her. And when you can summarize back to them, it shows that you have listened to them and that you're taking seriously what they have to say. Those are a couple strategies I use. Yeah?
I work night shift, so usually when the family member calls, like at the end of the whole conversation, I always ask them that, is there a message you want me to relay to your like dad or mom? That when she's awake, I can send that message. Then I always end the conversation with thank you for calling.
Yeah. Great. Yeah, I'm sure they appreciate that. Thanks. Any other thoughts? All right, so acknowledge the family member's emotions. This is something that is pretty hard, and a lot of times we see, I think it comes more naturally maybe to palliative care folks, might come more naturally to social workers, but for those of us who are not trained in like therapy and emotional, sort of responding to these, it can be awkward. What are some ways in which when you see a patient or family member being really emotional, how do you recognize that or acknowledge it? Mm-hmm. Yeah, just naming that it's hard. I'm just repeating so that the folks can hear in case they can't.
Or I see
Yeah.
that you're crying, do you want to talk about it? Or a lot depends on if people are alone or in a group.
Mm-hmm.
Those dynamics change things.
Yeah, asking if they want to talk about it. I think that's yep, that's great. I try to keep tissues with me if at all possible, and then like that can be a way to bridge that gap and sort of acknowledge where they're coming from. Any other suggestions? We often ask if they want to speak with a chaplain. As I said, I'm not trained in that, but the chaplains are. They know how to help manage those situations, so those are some ways we can acknowledge without necessarily trying to, you don't necessarily have the time to sit there, right, for an hour and talk to them, but there are people who do. We've already kind of talked a lot about listening to their concerns and their perspectives. My role as a clinical ethicist, oftentimes what I will go in and say is like, I've read a little bit about what's going on in the chart and I've talked with the medical team, but can you just tell me in your own words what's going on here? Now, I have the advantage of doing that, right, because I'm not a clinician. But asking that kind of like wide open question, I can find out whatever it is that's on the top of their mind. And oftentimes it's not related to what it might be. I need to find a way to pay for my parking. It might be like, my dog is at home and I need to get back. It might be related to the patient, it might not. But understanding what is on the top of their mind is going to really make a big difference in terms of being able to sort out whatever the situation is. All right, understanding who the patient was in active life. I always find this hard because you don't want to talk about patients in the past tense. I like this phrasing, in active life, before they were in the hospital. What are some suggestions about how you might be able to elucidate that, that perspective, get a sense of who the patient was before they came in the hospital? Mm-hmm. Yeah, do you mind using the mic just so that the people can?
Spoken, I'm sorry about that.
Thank you.
Maybe it's just the end of the day. No, I'm just saying that normally I try to ask them what they were working as, and I find that question really opens up because, one time there was a patient that was in congestive heart failure, EF of 10%, and he looked like he was just not, when I found out who he was, that he just perked up, and I asked for him. He just perked up and started talking, and he actually was a flight pilot, and he had a lot of good experiences that he started telling me about. So that sort of, I think it also helps the relationship a lot when you ask, what did you do before you, retired or something like that.
Mm-hmm. Great. So ask about their work. Yeah.
I was going to say really along the same lines of trying to find out, you know, what they were doing before they were in the hospital, because it helps us know, were they sitting in a chair and not awake? Or, because we don't have really a perspective. And so, but what they did for a living, or if they're retired, what hobbies, just trying to find out what their activity level was before they came, and cognitive too. I'm trying to figure out those two things primarily in that kind of dialogue, whether it's with the patient or the family.
Great.
I asked a family, a wife before, to bring a picture of the patient. We have a patient who was in a rotoprone bed, and we could not see how he looked, so I told her, bring a picture so that the staff will see how he looks.
Yeah.
And she did.
I love that. Yeah. Bring a picture in, or at least just ask to see, do you have any photos on your, you know, on your phone? Like these days, people often have them with them. Yeah, that's great. Then you can ask about what's in the picture, where was it, you know, just trying to get conversation started. That's great. Any other suggestions?
For the most part, if you ask them, they will tell you. Most of the patients, they do. But we usually start to ask them, like, if you don't mind me asking you, at this time, what do you usually do?
Yeah.
That's what we, you know, that's how we start. The patient, they start opening up.
Yeah,
And
that's
telling you
great.
all his life.
And I like that you said, if you don't mind my asking, because it recognizes that maybe they do have some preferences for privacy, but I bet most of them are really happy to have a conversation. Yeah, great. One of my colleagues always uses the phrase with a family member, not with the patient themselves. Well, actually, no, that's not true. Sometimes with the patient themselves. He'll say, what did a good day look like before you ended up in the hospital? That's when I guess you could ask that directly to the patient. I think it's most commonly when we talk about the family, but just trying to get an understanding, what do they do day to day, especially with a lot of older patients who are not working anymore. That can be a really good, helpful question. I had one person answer to that was, I fly to Vegas and gamble every time I can. And I was like, that was not what I was expecting you to say. That gives me some insight into you and what's important to you. All right, and then the E is elicit questions from family members. So giving people an opportunity to ask questions, and we're going to talk a little bit more about that a little bit later. So like I said, there's a couple of other ones in the literature. I think this one is pretty helpful. It has a fairly nice acronym, or a mnemonic, to help remember it by, but there's others. Essentially, the idea here is just to be intentional and to make sure that you're paying attention to all of these things. I know a lot of times they have, like for palliative care conversations, right, there's the SPIKES protocol, which is kind of similar to it. It's like a formula for managing these kinds of conversations. And I think it's the kind of checklist where you're not going to sit there and say, like, okay, VAL, but once you kind of practice it and think it through a few times, it'll become sort of more second nature. All right, is anyone familiar with the 3 F's of successful communication in the ICU? No, that's because I made them up. They are family meetings, and family meetings. Okay. I just made that up, but yes. In other words, family meetings are, in my view, like the crux of good communication in the ICU. It solves it can solve many of the challenges you all have talked about bringing people together, having different members of the team, different family members present. I'm a huge advocate of family meetings. So what are some reasons that we would, and so is the SCCM guideline. Routine interdisciplinary family conferences should be used in the ICU to improve family satisfaction with communication and trust in clinicians, to reduce conflict between clinicians and family members. And this is that same guidance statement that is pretty well known and respected. So what are some reasons that we would hold a family meeting? Goals of care, when we think a goals of care conversation is required. Good. Other times?
Sometimes it's just treatment options.
Mm-hmm. So when there's a treatment decision that needs to be made, yeah, and when there's different options available and you need to really think through which path you're going to take. Perfect.
Changing the status, patient status from what when they came in to what happened then. Changing the patient status.
Yes, so when there is a dramatic change in what, or it doesn't even have to be that dramatic, but a relevant change in what's going on with the patient, some complication, unanticipated outcome, yeah, great. Or maybe they get much better than expected, but unfortunately that doesn't happen as often.
Families don't ask, they just know it then.
Yes, yeah, they're always expecting that, yeah, good. Other potential reasons? To alleviate anxiety, absolutely, good. Yeah, back there. Yeah, good. So if the family says they feel like they're not getting information or sufficient information or haven't been able to talk to enough of the specialists, right, that would be a great time. Mm-hmm. Anything else? If we have sort of concerns about conflicts between different family members, that's another time that we will try to organize a family meeting. My favorite time for a family meeting is for no reason at all, just to have one. I think that ICU care is so complex that really we should be having regular family meetings for one of these reasons, or if we haven't had one for a long time, we should just be having one. This is how we run our ECMO patients here. So our ethics consultation service is consulted anytime a patient is put on ECMO, and we kind of drive this cycle of family meetings that within 2 or 3 days of the patient being put on ECMO, we'll go in and introduce ourselves and let them know that we're going to be participating in their care, that we will be calling family meetings on a regular basis, and it doesn't mean that there's any big decision to be made. It doesn't necessarily mean that things aren't going well. It just means we think that there's a lot of value in keeping people in the same loop or on the same page. And then we plan, as I said, before the family meeting, what is our message? What are the benchmarks that we want to set for our next week or two? And then as things progress, and if, hopefully the patient does well and ends up, being taken off of ECMO. But because patients can be on ECMO for so long, and it's very easy to they don't change very much day to day. So it's really easy to just kind of say, everything's the same as it was yesterday. But can you imagine from the family's perspective to have a loved one in the ICU for 1, 2, 3 months and to not get enough sort of, everything's pretty much the same, right? That can be pretty discouraging. This Kentish Barnes here has published a recent article where she says that every patient where there is concern about that they won't make it should go through a series of 3 meetings. This is separate from ECMO, right? This is just any critically ill patient. There should be an interdisciplinary meeting to any time that there's a recommendation to change the goals of care. That the clinical team, maybe not every member of the clinical team, but there should be a multidisciplinary team that goes in to talk to the patient and or family during the dying process, as well as meeting with them after, even for a brief period of time, to express their condolences and make sure they don't feel like they're being abandoned, right? It's pretty easy for, I think, the clinical team a lot of times to say, okay, the decision has been made, palliative care, hospice, signing off, I'm gonna start focusing on my other patients. But she's arguing here that there's much better satisfaction, as well as they did qualitative conversations with these families, and they said that they really appreciated these, to follow through on having these meetings during the dying process as well as after. All right, so if family meetings are such a terrific way of resolving and helping facilitate communication, why don't we have them more often? What are some of the barriers that we might have to conducting these kinds of family meetings? Time. Yeah. Some family meetings are 15 minutes. Some end up being an hour and 15 minutes, right? And especially when you don't know what you're getting into. Great.
I think a barrier is that sometimes we want to avoid the conflict or the drama or whatever you add with that, because many family meetings, our history with family meetings many times have been, I'll call it adversarial or drama, and a lot of times it's one person of a group who, and they usually are the ones that haven't been around, and they just got here and they have all these ideas of how to fix things, which we've all seen. But I think some of those are some of the reasons, and getting all the players. It's not easy to get everybody in the room at the same time and to be able to meet in advance to be sure we have a unified message. And I don't mean ganging up, but not a conflicting message.
Yep, those are terrific points. Nobody wants to be in a situation where there's conflict or even where you have to give people bad news, right? That's not fun. Nobody wants to do that. Great. The logistical point is also an important one, right? Especially when you have surgeons involved. They can never tell you when they'll be there. No offense to anyone who's a surgeon. They're like, I'm doing a lung transplant. I'm not sure when I'm going to finish up. How can I argue against that? Okay, fair enough. But it can make it hard, yeah. Other barriers? I think you've gotten a lot of the key ones here. So they actually did an empirical study on this and interviewed physicians and nurses and maybe social workers, if I remember correctly, about these barriers to especially preemptive family meetings. That's what they were focusing on, but a lot of these things apply to any kind of family meetings. Physicians don't think it's necessary to have meetings that aren't necessarily prompted by some particular change in the patient's status or some decision that needs to be made. So the nurses were very much on board with doing these kinds of meetings, but it was the physicians who said, I don't need to do that. I gave them a clinical update already, right? We don't need a full meeting. Physicians don't want to have difficult conversations. Time and coordination, which we've already mentioned. The nurses said one thing that made it hard for them to sort of join on with these meetings is because they're not just caring for one patient, they're caring for at least two patients typically in the ICU. And if it's outside of the ICU setting, they might be caring for more than that. So this idea that they would be able to not only step away from caring for that patient, but also their other patients can be really challenging. All right, any other comments or thoughts on these sort of big picture pieces of the puzzle? And there's many more kinds of guidance that we could offer, but those seem to be like pretty important big picture ones. All right, let's go ahead and then get into a couple very specifics. So this is again where I was hoping to have you all participate. So my colleagues and I actually wrote a paper, which I failed to cite on here, I'm now realizing, a couple of years ago based on our experiences in the ICU. So most of this conversation is based on actual family meetings where I've been sitting there and somebody says something and I'm like, oh, don't say that, please don't say that. And then I have to try to work them around it. So these are a bunch of quotes that I've heard, and I would like to hear your all ideas about how we could say that better. Okay, so one question we hear very often, and this is, I think, a very sort of typical way of starting out a family meeting, but also even just any kind of conversation, which is, what do you understand about your medical condition? What do you understand about your mother's situation? Okay, why do you think that? Any ideas about why that might not be the best framing right? You're wanting to understand where the patient's at, what they know about their situation. We have talked to patients and families, and they tend to find that to be sort of like a quiz. It puts the onus on them. It's like, what do you understand about this situation, right? Like, do you understand? I think it puts a lot of pressure on patients and families to like be able to say things in a way that, you know, are like right or appropriate for the doctor. And it says basically if that information is not correct, that it's a failure of my understanding. Okay? So what is a different way we could phrase that question if we want to kind of get to the same idea? We want to understand what's going on with the patient or what the family knows.
Let us discuss this situation.
Okay.
And then like start it like that, but then try to gauge how much they know.
Okay, so just kind of have it be a natural conversation and not sort of put them on the spot that way? Yeah? Good. Other suggestions?
Still along the lines of, tell me what's going on with your family member. I'm not saying what you understand, but
yeah,
I mean, because we still want to know what they're thinking. And
absolutely.
Whether they think they're doing better or not.
Yeah. So tell me about what's going on or what's been going on the last couple days, maybe. Yeah. My favorite way of phrasing this is to say, what have the doctors been telling you about what's going on? Did you? Yes. Did you say that back there? Oh, you said it. Okay. Yeah. So what has the team been telling you? What have you been hearing from the doctors about what's going on? And it puts it on the doctors, right? Then this is what I've been told. It's not my fault if I didn't get it correctly. Which of course we know that. Like it's not all the doctor's fault either, but it's an easier thing for them to say. So yeah. That's what I've been, and that's particularly easy for me as not being a doctor, right? But when you are the doctor, maybe it's hard, but it's harder to be in that situation. But to say, you know, like what have you been hearing from folks about what's been going on? You know, if you're new to this patient, that can be one way to do it. All right, good. All right, offering information. So when we want to kind of explain what's going on. You know, that maybe they have questions, or maybe this is a family meeting where we're kind of giving an update, or maybe we kind of are taking a step back. You're new to a family. You want to kind of make sure they are on the same page. This has to be the most common thing I ever hear. Your mother is very sick. Okay, any ideas about why I get cringe when I hear people say that? They know that they're sick. They're in the ICU, right? Like, of course they're sick. Like, that is code for us. When we say your mother's very sick, we're saying, like, we think there's a good chance she's not going to leave the ICU. They don't know that. They are not part of our little, like, circle of confidants, and we haven't had this conversation many times. Like, this to me is, like, the distance here is very far apart. When the team says, I explained how bad the condition was, and the family's like, well, they said she was sick, but like she's been sick, she's had cancer for 3 years. Of course she's sick, right? Like, so we really, this is what I really, really, really dislike. Oops, sorry, got ahead of myself. No, I can't go back. What might be a better way to talk about instead of your mother's very sick? And you can start with it if you really need to, but then at least say more than that, right? What else would you want to say?
You should just offer to tell them what the problem is.
Mm-hmm.
Your mother is admitted with pneumonia, it's in both lungs. That makes her, and it's been there for a week. We should just offer them the information instead of telling them, sorry. forgetting that. I think I'll just keep it. Thank you. No, what I was saying was that I think you should just, instead of telling them your mother is very sick, you said, I'm just here to give you some information about your mom, and that, she has pneumonia. I mean, just give them the information, the factual information. That's how I would approach it. Maybe there's a better way that our wonderful nurses can guide me on that, but that's what I've done.
So kind of a review of symptoms or of systems.
Yeah,
kind of
sort
approach.
of. And the most prominent thing that has brought her to the ICU, you know, that I know, I mean, if they said, well, she is sick and she's had cancer, and said, yes, but right now she has I mean, kind of explain to them what the situation is. And it is hard, because sometimes you do end up saying your mother is very sick as the first thing. I've done it.
Yeah, good.
Okay.
Other. So in general, we just want to be more specific and more clear. Are there other ideas for how we can kind of communicate more clearly?
So for me, I would typically ask, how's your dad, how's your mom, and then they will answer, and then I will just follow up with further question and information. Or sometimes I will say, can I answer any of questions you might have? Something like that.
Yeah, good.
I was just going to say something funny. I'll just tell them, what have the nurses been telling you about your mom?
Right, there you go.
Bedside more than we are, so and there's a much longer communication period, and, so.
Yeah, good. Okay, good. So just trying to be more specific and give more clear guidance, kind of painting a picture of what's going on. All right, prognosis. I'm concerned that your brother won't make it through this. There's a lot of this use of the language, I'm concerned that. When you say I'm concerned that, you mean your brother won't make it through this, right, most of the time. I'm concerned that, their neurologic recovery is not going to be what you hope it is. Means that it's not going to be, but from your perspective, that's like 90%, right? Likelihood of whatever X you're concerned about is going to happen. From their perspective, it's like 25%, right? They're concerned that this might possibly happen. That is another point of sort of disconnect. So again, trying to be more specific. Try not to use that language of I'm concerned that, unless you genuinely are somewhat concerned but don't think it's particularly likely. Another quote that I've heard that makes me cringe about offering prognosis. Yep, you're laughing because you've said it too, I'm sure. I don't have a crystal ball. Okay, because a lot of times the families do ask, right? They say, well, what is the likelihood that, you think that she'll get off the ventilator? And I understand that everyone has been trained not to give too specific answers to these kinds of questions, because nobody does know for sure, right? I don't have a crystal ball. That's another one I could put in here. No one knows for sure. This kind of very vague notion, because if you say everybody's had a situation where they said, I think they have 3 weeks, and they lived 6 weeks, and then they get in trouble. Or they say 3 weeks and they live 1 week, and then they also get in trouble, right? So they've all had a bad experience where they've been very specific, and so their response is to be super, super vague. But the problem with I don't have a crystal ball is kind of saying I have no idea. Anything could happen, which is not true, right? You can't be 100% specific. You can't say, 4 hours and 7 minutes is how long they have left. However, saying I have no idea is also not helpful. You have an idea in many cases what's going on. And so I have no problem with people sort of hedging their advice to say, look, patients always can surprise us, but given what I know, I think, X number of, somewhere in a range, 1 to 2 weeks is a reasonable thing, right? You can hedge your bets without giving this impression that it could be anywhere from, a week to a year. And that really makes a difference in terms of decision making for patients and families. They need to know that information. For them, 1 week, 2 weeks, 4 weeks might make all the difference in terms of how they decide to, proceed with a decision. So I definitely don't like to hear crystal ball. There's a little bit of literature about patients' and families' preferences out there about how they would like to get prognoses. One piece of the puzzle that I actually hadn't thought about before I read this article was that they not only want the prognosis, but they would actually like, in some cases, an explanation of how they arrived at that, right? So if there is statistics out there, or if there are reasons to say, sometimes patients with cancer would live this long, but this is a particularly aggressive cancer, so I think it would be less than that. Whatever the explanation is, to try to be transparent about how you came to that estimate. Patients who were interviewed, or their families, said they really want that piece of the puzzle, which I think is pretty interesting. They also offered a couple of fairly obvious suggestions, including using lay language, not a whole bunch of jargon. They specifically requested visual aids when possible, either pictures from the chart or potentially, other like decision aids or things that kind of help to explain what's going on. They also said they liked it when clinicians left informational materials with them so that they were able to look over it later and try to refresh their memory, and when they forgot what it was that the clinician said, they could go back and look at it again. They did, as I already sort of alluded, they did say that they appreciate when clinicians give them specific numerical estimates of how long somebody will live, and conveying a possible bad outcome early. So if they are in a situation where they think there is a reasonable chance that the patient is going to have a bad outcome, to start that process earlier than they might want to, when they see that that's a significant possibility. There's also some wisdom out there that says you shouldn't hang crepe, right? Have you guys heard that phrase? It's this idea that you shouldn't start talking too early about a patient dying and their likelihood of dying, because then if they don't end up passing away in the period of time that you suggest, that can really undermine trust as well. And then the family comes back and says, well, you said he was going to die last week, but he's still here. So now I don't believe what you say. So you have to kind of find this line between like raising the possibility, but not scaring them into it so much that they're not going to believe you in case it doesn't happen. So it's a very fine line, but this is what the patients and families who were interviewed in this study said they really did want to know that information early. Another way that we try to help our clinicians give a more clear prognosis, and this connects a little bit with with also the sort of explaining the scenarios. If I'm in a family meeting and somebody's being vague and somebody says something like, I don't have a crystal ball, I'll say, no, we totally understand that you can't say, for sure exactly what's going to happen, but can you describe what might be the best case scenario for this patient? And then sometimes the worst case scenario in the ICU, obviously that's not always relevant because a lot of times it's a complication that results in their death. But under under less acute circumstances, I might say, what do you think is the worst case scenario? If we do nothing here, what could happen? And then always push them to also say what they think is the most likely case, which is usually somewhere in between those two. Starting with the best case kind of gives hope, but then backing off of that to say that is kind of the least or the less likely option. What's more likely is that we'll only get to here, right, instead of to where we really would like to be. Sometimes that can be really helpful to describe very clearly what capabilities you think a patient will be. Will they be able to talk? Will they walk? Will they be able to take care of themselves? Will they be able to go home? Very specific things like that can be really helpful. All right, have a couple more. Elucidating values, this is one that we already talked a little bit about. We don't ask patients or family, what are your values? Or what was important to the patient, right? I mean, important is a little bit better, but I mean, there are many things that are important, like their dog is important to them, like maybe that the mailman leaves the mail in the right spot at the, like patients have a lot of things that are important to them. Let's try to be more specific. What are some, I guess we've already kind of talked a little bit about what are some possible ways we can talk about that. What does a good day look like for you? If we're in a family meeting, I might say, you know, what would your father say if he could sit here in this conversation with us? You know, those kinds of more specific questions rather than just trying to understand a patient at this like very high level. All right, now when we're talking about options, when we're trying to lay out what the decision to be made looks like, there's nothing more we can do. Why would I cringe when I hear there's nothing more we can do?
Kind of takes their hope away when you say that.
Mm-hmm. Okay, takes their hope away.
You really can't do anything. Then
Right.
there is a point where medical therapy is futile, but still I would not use that word. We have done everything we can, and we will continue to do to, you know, make the person comfortable, or, you know, something to tell them that we can still do something.
Great. Yes. So what you said, the way you revised it is to say there's no more medical therapy that's available, right? That is a different thing to say there's nothing more. There's always something more we can do.
Right.
We can always make sure that the patient is comfortable. We can, you know, whatever our goals are, we can do something to try to achieve those goals. Are you jumping in? Oh, sorry.
I was wondering if there was only one mic and I had the.
They have a mic back there too. Yeah. Yeah. Good. Okay, so we already said one better way to phrase this might be there's no more therapy. I don't have any more medical therapy to offer. You know, we have used all of the treatments that we have available to us, something like that. Anything that we could try to cure the patient. To just be very clear that it's not that we can't do anything more, it's that we can't do anything to achieve the goal that we had initially hoped for, which was to get the patient out of the hospital, to get the patient back to the baseline, whatever it is. So just trying to be very clear. Yeah? Oh, sorry. Okay. All right, nothing more we can do. On the flip side, do you want us to do everything? Okay. Do you want us to continue to do everything? This is very common. I'm hearing snickering, but we hear this all the time. Right? What is a person going to say in response to that?
Intensivists.
Go ahead.
I said, hopefully not from intensivists. They know better than to ask that question.
Well, I'm not going to throw anybody under the bus, but it has happened. Maybe it was a long time ago before any of our current folks are here. Let's say that. Do you want us to do everything? Why might this raise concerns? Right.
It also opens.
Yeah. That's not right.
Mm-hmm. Good. Right, so of course, yes, do everything, right?
Yes.
I mean, that is like the obvious answer. The question is everything in service of what, right? You need the second, do you want us to do everything to keep your loved one alive as long as possible, right? That's a specific goal. Do you want us to do everything to make sure they're comfortable and not in pain? And it's also very rare that the only option is do nothing or do everything, right? The vast majority of the time there are options. There's non-escalation of care. There's changing of code status. There's the decision not to start certain therapies, right? Like not to start dialysis, whatever it happens to be. It makes it seem like a very black and white sort of situation. So let's try not to use, do you want us to do everything? The thing that, in my view, in my experience, is that it's important to describe all of the options thoroughly and to paint a clear picture of all of those options. So many times I'll hear folks say, like, do you want us to continue with the pressors and continue doing dialysis and things like that, or not? Right? What is not? What does that mean to a family, to a patient? That just means death, most likely, right? So I don't want that, so I'm going to choose this, right? A much better way to do it is to try to explain, okay, so we can keep them in the hospital, we can continue ventilator support, add pressors if we need to, continue dialysis, or we can decide not to add anything more, and at some point when you're comfortable with it, we can decide to stop the ventilator. We would make sure that all of their, that they have medications on board to ensure that they don't have air hunger, to make sure that they don't feel pain, that you can be with them while they, nobody wants to describe that moment of somebody dying, but if you only have two options, like keep them alive or just not, right, that frames things in a way that patients and families don't really see the whole picture. So even though it's really awkward, and I understand, I'm always shocked, even palliative care folks who I would think would be very comfortable describing those, and when push comes to shove, when we say, what does that look like, they will do a lovely job of describing it. But when they're just kind of putting the options out there, they're like, do you want us to do this or comfort care? So really to try to describe what each of those would look like, painting a picture, talking about, what this means. We'll still do, sticks every day. We're still going to continue. And if their heart stops, we're going to continue, we'll do the chest compressions and things like that. And versus painting a clear picture of the alternative, I think would really benefit patients and families. If there is any way, hopefully as part of your rich value conversation, you've had a chance to elicit some ideas about what was important to the patient, what their values were, what they might what decisions they might make. And then if at all possible to sort of, as you're offering options, explicitly connect those to things you know about the patient. You don't want to make assumptions, so it's kind of a fine line, but I heard you say that it was just really important to your mother to make it to, her 80th birthday, or to get to see a picture from the wedding, or to wait until her grandchild is born. This option seems in line with that goal, like to try to be explicit and connect them. And they might say, oh no, she did want that, but not if she's going to be under these, conditions, or vice versa. So just trying to be explicit and make some of those connections for families. Or at least you could ask them about how they might connect those. I think a lot of times we have been trained, so everybody is sort of aware that in the old days there's medical paternalism, and meaning that basically clinicians made the decisions, told patients what it was, didn't ask them what their preferences were. This is what's best for you. Now we have understood the importance of self-determination, of autonomy, of informed consent. We want to allow patients and families to make the decisions that are best for them. But I think we've swung too far to the opposite extreme, where we will end up messaging families like, here's one option, here's another option. Either one is totally fine. It's totally up to you. Well, I'm going to get to that. That's my other pet peeve. It's coming up soon. I went to the doctor one time with like swollen lymph nodes, and I hadn't been for a long time to the doctor. I don't really like doctors all that much. I mean, I like you as colleagues, but not as, being there. Anyway, I don't know if she assumed that because I worked at the medical school, like I was a clinician or had some, but she was like, okay, well, we'll do routine blood work. And do you want me to check your thyroid? Like, I don't know. Like, is that related to swollen lymph nodes? Like, I have no idea. And then she's like, okay, well, it's probably time for your mammogram, but do you want to do that today, or do you want to like wait till next year for that? Like, I don't know, you tell me, right? Like had like taken this idea of just information to the patient, let her make the decision to the extreme. Like, I really wanted your recommendation. What do you think is the right thing to do to try to solve this problem? And so I see this oftentimes in critical conversations as well, where we want to make sure that the patient and family get the treatment that is in line with their values, and so we're reluctant to make a clear recommendation. I'm sure as bedside nurses, sometimes you get asked, well, what do you think we should do? And we've kind of been trained to be like, whatever you think is best, whatever is right for your family, but sometimes I think they do genuinely want a recommendation and your perspective. All right, speaking of which, this is another of my favorites. It's your decision. It's up to you. Why might we be concerned about this kind of language?
They don't have the knowledge to make that call that, that it's their decision. This has happened to me as a patient, and it's also happened to my husband recently as a patient.
Mm-hmm.
And it's the most, my husband's not a physician, and he was like, what do you think? that was his answer.
Yeah, good.
Yeah.
So they might not be prepared to answer that question. Good. Other thoughts on this?
Well, I think it's what I was saying earlier. In a way, that puts a lot of pressure on the family, and they can have a lot of, if this is like an end of life, it can put a lot of guilt that they'll never get over, and I don't think that's fair to the family.
Mm-hmm. Absolutely. So it puts a big burden on families to make it feel like it's all on them, right? If the clinician is more likely to say, we're going to talk to you and work with you on this, but I would recommend making her DNR, then all the family's saying, like, I'm going along with what the doctor said, instead of making that decision. Some families are fine with that. They can say, I know that they wouldn't want this or whatever, but sometimes they're not, and they're just saying, I can't make that decision. It can be a really, really huge burden. I've had cases in which clinicians, like the family will say, I know this isn't what she would want. And then even once they seem to have made a very clear decision, the team will say, just think about it for another day. And I'll be like, I heard them say that they're ready to call hospice. Like, are you ready to call hospice? Like, yes, let's get the consultation going. Like, again, trying to make sure you've heard what they're going to say. And if they have made their decision, don't kind of keep making them make it again and again. I had one other situation. Oh, there was another anecdote I was going to tell you. Now it's gone. Oh, no, I don't know. I can't remember. Should have written it down. Anyway, so exactly, the burdens of making that decision can be pretty significant. We'd rather not do that.
But one of the challenges we have a lot are the families waiting for a miracle. And
Yeah.
maybe it's again that one person, or it could be family.
Mm-hmm.
And they
Mm-hmm.
they want to keep doing everything.
Yeah. Yeah, I think there's different versions of that, yeah.
They're having necrotic tissue and stuff like that.
Yeah.
Not talking just a simple case.
Right. So my colleague Trevor Bibler, Dr. Bibler, has done a lot of work on sort of explaining different reasons why people might use miracle language. So he argues that sometimes people do that out of genuine faith, that they just are really hopeful that there will be a miracle. Sometimes they use it as kind of like a tool to say, like, I have this, like, maybe they are or maybe they're not, but it's a way that sort of you have to respect their belief, right? You have to kind of say, or sometimes it's like they're hopeful, but they don't necessarily believe that it's going to happen, but they're like, I'm waiting and hoping for a miracle, right? They're maybe not convinced that it's going to happen. And sort of trying to understand what somebody means when they say, I'm hoping for a miracle, and how we respond to that. We might do it in different ways. Sometimes getting a chaplain and or a religious, person that they trust to talk them through that. The chaplains are very good at sort of unpacking the idea of what does a miracle mean, and maybe God is acting will bring you a miracle. Maybe the fact that the patient got this far already is a miracle, right? There's different ways to engage with that. This is a whole nother tangent, but I think you probably want to give some thought to whether you would consider engaging in that kind of conversation beyond just active listening and reflecting what you hear. I think some folks who do have a certain spiritual approach do feel comfortable engaging in those conversations. And I think others are probably feeling like this isn't really my role. I need to get somebody else involved here. But yeah, good. Good. All right. And I think this is the last substantive big comment here from me. Do you have any questions? Any thoughts on why? Do you have any questions? Made my list of things not to say.
It's too broad. Do you try to focus it around the treatment or around, I mean, do you try to focus it, is that?
I don't mind the fact that it's open-ended, but it's just kind of a yes/no question. And it often kind of can communicate that, like, I'm done. I've said everything that should be said, kind of going back to our very first, like, what do you understand? Like, obviously I've told you everything you need to know. What questions could you have, right? Like, that sort of putting the onus on the patients to flag that they have some concerns. I much prefer, like, what other questions can I ask, right? That invites people to say, like, you're totally welcome, like, what can I tell you? I don't know if any of you have seen Dr. Al-Sadi, if you know who he is or if you've seen him in a family meeting. He will, like, sit there and, like, hold his hands and crouch down in front of the family and be like, what else can I answer for you? Which is, like, so, it just is so inviting to them, like, to say, like, I really, like, he just communicates, like, how much he wants to help them understand what's going on. That probably isn't authentic for everybody, but it really works for him. But even if we try to say, like, in these open-ended, ways, like, how can we answer your questions? This is a quote from one of those interviews that we talked about earlier. The wife of a man who developed ARDS after being admitted with pneumonia conveyed, there are a lot of times the doctors say, well, do you have any questions? And I don't know what to ask. I might say no, because I don't even know what to ask. Right? So maybe that's a situation in which more specific would be helpful. All right, so the last, I think we have like 15 minutes left. I was going to leave it open for any questions, and also interested to hear if you all have any similar phrases or concerns, things you have seen in the clinic that you say, oh, that belongs on the list of, don't say that.
I think I want to offer, because some people don't know that this is a service we have at Houston Methodist, but we have creative arts therapists, so music therapists and art therapists that can come and learn about the person's life. So whether that's through writing a song for the person or telling their story in artwork with the family members. So that question about, like, how do you get to know them? And then those things can be put up in the room so that everyone that comes in knows that patient a little bit more. They have a question, you can talk about it, you can invite things. Sometimes we'll leave lists. These are the things that my person likes and would love for you to do. Sometimes there are simple reminders that we should already know, like talk to them when they're getting care. But it's nice for the families to have that time to advocate for it. And we do have the time to sit down and talk with them for hours. I mean, sometimes we have 2-hour-long times where we sit in a patient's room with a family who's just struggling, and maybe they're just they're going through their process of trying to decide what they're going to do, and they're doing it cyclically, and we're just reflecting it back to them, and every time they tell it, they think of something different and something new, and they kind of get there on their own. And we work really closely with the chaplains also to pull them in when those times are appropriate. But you may not know that we have that service at Houston Methodist, and we have it at most of our ICUs. So we certainly have it here. We have it at Baytown. We're looking to get it at Sugarland, but we do have a music therapist at Sugarland who can come from priority cases. We have it at the Woodlands. We have it, West is a position that's open, so we're hiring for West. So it's growing, but something else to lean on.
How do you put in a consult for that?
You do it in Epic.
It's called Creative.
You click on order and you type in music therapy, it'll pop up.
Uh-huh.
And then
So
it'll ask you to pick, is this for end of life? Is this for neurologic need? Is this for physiologic homeostasis? What are you asking us to do?
Great, I didn't know that. Thank you.
Yeah, that's why I said.
Yeah, no, that's fantastic. Other thoughts on this, or just any questions related to communication in general? I don't know if anybody, I don't see anything.
Some of the challenges we've had in the last last couple of months or so were things like where a patient was intubated for 30, almost 40 days.
Mm-hmm.
I mean, the evidence is 14, right? I mean, about. And this family did not, I mean, we had several family meetings with a whole, and ethics, so it's situations like that. We recently had a woman who wanted, when she was awake, she wanted to not get intubated. But then she finally changed her mind at kind of the last second. And it's those family, then she didn't have immediate family, and her decision makers just had a really hard time coming, making a decision, and she was with us a long time.
Mm-hmm.
And ended up, she did pass away. But, I mean, it's just clearly in a lot around COVID.
Yeah.
I don't really have an answer, just some challenging situations.
Well, I think that's, one, we didn't talk at all about, the value of advance directives, but certainly that is one big piece of communication, is trying to solicit, or to get patients to do those sorts of things and express their preferences earlier, so that we're talking to the patient themselves rather than the family about what they would have done in this hypothetical situation. Yeah. Good.
But most of the time it is hypothetical.
It is. Well, and there's also a lot of interesting discussion about whether advance directives really are all that, because, a lot of times they're created years and years prior. They don't know what the real, the actual situation in which they're going to be applied is going to look like. But I actually still think I would stand by their value, even if we don't hold them as like the end all and be all of the discussion. I've seen many families take a lot of comfort in knowing, that I have this piece of paper and this is what they said. And so, like, again, going back to that burden of surrogate decision making, to say like, well, I don't know what I would do, but Dad said this is what he wanted, and that can help. Any other thoughts or comments? All right, well, if not, thank you so much for all of your ideas and participation. I really appreciate it. Enjoy the rest of your weekend.